Journey must begin with the patient. At the IHW Council, our work is anchored in Sustainable Development Goal 3, ensuring healthy lives and promoting well being for all, with a deep and enduring focus on the prevention and control of non communicable diseases. Cancer, in particular, has been central to IHW's mission since 2019, well before it occupied the prominence it holds in today's public discourse. When the COVID 19 pandemic disrupted health systems globally, cancer care risk became collateral. Cancer care risk became collateral damage. During that period, the IHW Council worked with
India's premier health and well-being advocacy institution, inspired by the UN holistic approach to sustainable development goals. IHW Council is dedicated towards its high five philosophy of good health, good food, good water, and good lifestyle. Since 9 years, IHW Council is driving its advocacy missions of holistic health and well-being, fighting non-communicable diseases, climate action and social determinants of health, women and child health, policy discourse and public awareness. Among all the missions, fighting non-communicable diseases remain the area of deep concern, with more than 41 millions of deaths due to cancer, and it is likely to increase to 55.
इसके लिए हमारे एयर पोल्यूशन और वाटर पोल्यूशन को कैसे सुधार इस बात पर जोर देने की आवश्यकता है। मुझे ऐसा लगता है कि भगवान ने हमें कहा गया है और इस शरीर को स्वस्थ रखना हम सब लोगों का पूरी कर्तव्य है कि जीवन पद्धति और खान पान बदलाव लाना होगा। तो आइए one of that you all have recently heard that 17 of the drugs which are life-saving drugs important for various cancer treatments have been waived off for the custom duty. Definitely, this kind of step help us achieving better access, better affordability for therapies for the cancer patients. But more importantly than that, we have also seen the announcement of Biopharma Shakti initiative from the government, where they have allocated nearly 10,000 crore for that. And this is going to be an important step towards the long term capacity of the country in dealing with
the major diseases, especially NCDs and especially diseases like cancer, where you will have more indigenous innovation in terms of advanced therapies and treatments. Friends, ISW Council, when started this cancer initiative and the cancer summit in 2019, 15 lakh cases were reported in the last year. And out of 15 lakh cases, nearly 9 lakh deaths happened. The issue is that many of these deaths could in our journey to have Ayushman Bharat or or a developed Bharat. So thank you so much. I look forward to hearing from our guest of honor more on how we can and all.
Yes, it is moving toward younger age group, but it is more likely to happen when your life expectancy increases. Coming to the last point, we need to do more about prevention. And in the morning over tea, we were discussing with Amit Ghoshji. Tell me what we can do. Yes, that is important. You open hospital and look at cancer from hospital window outside. You will only see cases. But when you look at family and community towards hospital, then you will look at prevention. How do I prevent cancer happening so that they never fall victim to cancer? Few examples. We have hepatitis B vaccine, which came into national immunization program around 20 years back. Is every child covered? Is everyone who's at risk of hepatitis B is covered? And that causes cancer later in life. So we need to see the interventions we have today. Are we reaching the last beneficiary? The next vaccine is HPV vaccine, which prevents cervical cancer. I remember when I was in Geneva about 25 years back, this vaccine was available in the market, and my younger daughter was going to school. I bought this vaccine. Air pollution has been air pollution has been talked about, and it contributes to cancer. Every one of us needs to be serious about it, from government to individuals. Tobacco, 40% of cancers are directly or indirectly caused by tobacco. What are we doing as individuals, as family members, so that nobody smokes in my family and your family? Government has policies in place. But what are we doing in our families? What are we doing in our schools? And what are we doing in our neighborhood? We need to take it seriously. Polo, Juba, Canceri. You know, the advertisement so attractive. It is cancer, not Juba Canceri. It is Juba Canceri. What are we doing to stop this cancer? The marketing which is being done by tobacco and gutka companies, what we can do to stop it? And tell them this is not cancer, it is cancer. And we can prevent many cancers by this alcohol. And I often become very unpopular in social gatherings when I say no alcohol. My friends in Rotary get together, alcohol is a part of it. And if you want to work against cancer, please stop taking alcohol yourself and stop giving alcohol to any party you host. So start with your family and yourself if you want to reduce intake. Alcohol is not just cancer, many other diseases as well. Similarly, tobacco and smoking and non-smoking tobacco cause many other diseases. You will live a very healthy life and you will prevent many non-communicable diseases. Physical activity. Stand when you're sitting and walk when you're standing. Non-physical exercise activities can contribute to 50% of physical activity. So don't ask for someone to give you a cup of tea or glass of water. Get up and help yourself. You will increase physical activity. Diet intake, it was referred to in the inaugural address by Kamal as well.
we need to make sure that our food habits are healthy. So, to end, I have another point which I want to emphasize. You talk of cancer patients from clinician point of view. Who is fighting cancer? Not the ministry, not the bureaucrats, not the doctors. It is the patient who is fighting cancer. It is the family of that patient who is fighting cancer. So we need to be more sensitive to caregivers. I learned from Indian Cancer Society the situation in which caregivers in the families of many of them have to quit job to look after a cancer patient. They have emotional stress which we never think about. So start looking at the person who is fighting cancer, the patient, and the caregivers. Thank you.
Thank you very much, Doctor, for the insightful and strategic address. May I now invite Mr. Amit Kumar Ghosh, IAS Additional Chief Secretary, Medical Health and Family Welfare and Medical Education, Government of Uttar Pradesh, our guest of honor, to deliver the inaugural address, keynote address. Can you please welcome him?
Thank you. Mr. Kamal Narayan Omar, founder and CEO of IHW Council. Dr. Sanjeev Kumar, my old colleague, we used to work together about 10, 12 years ago when he was in the National Health Systems Resource Center, NHSRC of Government of India. And I was the Mission Director, National Health Mission and Secretary Health UP. Then there was a gap of about 8 years when I worked in other sectors, and now I'm back to the health sector. Pleasure to connect with you. Srimati Jyotsna Govilji from the Indian Cancer Society, and what I understand, having met her for the very first time today, that she is a big name in cancer patients' rights advocacy awareness. My old colleague and friend, Dr. Pandharkar Saab, with whom I share not just a professional relationship but also an emotional connect. And I'll be talking about that in a short while. Dr. Amita ji from Thermo Fisher, my colleagues from Government of UP, other distinguished partners, and representatives from the industry and hospitals. It is a privilege to be part of the seventh edition of the Cancer Summit and Awards being organized by IHW Council. This is a platform which brings together different voices, united by a shared purpose, which is to strengthen cancer care and public health outcomes in India. I extend my sincere appreciation to the IHW Council for conceptualizing and sustaining. Sustaining conceptualizing is easy. Sustaining something takes sankalp shakti. So you have that for conceptualizing and sustaining this summit year after year. Your work in patient advocacy, evidence-based dialogue, and health system strengthening is commendable and timely, especially in the evolving landscape of healthcare delivery. India today stands at a defining moment in its public health journey. Just 2 days ago, in the budget which was announced, for the first time, the budget outlay for health sector has crossed 1 lakh crore, and I think that calls for a round of applause from everyone. We who work in the domain of public health are extremely enthused by the announcements for the health sector by the Honorable Finance Minister of India, and under the visionary leadership of our Prime Minister, Honorable Sri Narendra Modi ji and his Council of Ministers, I think that we can say that, the pharmacy sector, the medtech sector, these are all going to grow at a very fast pace. Remember that we are all united by the vision of India at 2047. And there is space for each one of us who are present here in this room today to contribute and be a part of this journey and grow along the way. I'm just getting a call from my minister, if you permit. That, so sorry for interrupting. As far as the state of Uttar Pradesh is concerned, I wish to tell you that in 17 I came to Government of India. At that time we had 9 medical colleges and 6 institutes. Today we have 43 medical colleges in UP in the government sector. And this great change under the leadership of our Honorable Chief Minister Yogi Adityanath ji, uh, I can say that, healthcare in the state has moved from being episodic to system driven with focus on preventive health, and it is now technology enabled. Health is no longer seen just as a social obligation. It is recognized as a cornerstone of economic growth, social equity, and national resilience. When I talk about economic growth, let me tell you that in the vision of Uttar Pradesh as part of India at 2047, we have the Viksit Bharat Viksit Uttar Pradesh 2047, in which the health sector has been assigned very ambitious and very clear goals for bringing economic growth. I'm happy to tell you that 2 days ago in the budget announcement, medical tourism has been recognized. And all of you who have read the announcements would know that medical tourism has been recognized as one of the key areas to emerge as driver for economic growth and bringing forex to the country. So we in Uttar Pradesh have also decided, yesterday there was a meeting, that we will also, promote medical tourism very strongly in our state. And our team is already working on the proposal in this regard. So, one of the most transformative initiatives in this direction has been the Ayushman Bharat ecosystem, about which Kamal Narayan also spoke. The Pradhan Mantri Jan Arogya Yojana PMJAY has fundamentally reshaped access to healthcare for millions of Indians by ensuring cashless quality treatment for secondary and tertiary care. In the morning, we were talking about access for patients suffering from cancer, and I think that if we can further refine the packages and the procedures in public hospitals as well as private hospitals covered under PMJAY and give some preference to the hospitals who promote cancer care, we will be able to improve access for the patients in the state of Uttar Pradesh. So, our aim is to reduce catastrophic out of pocket expenditure for families, and we wish to empower families to seek timely medical care without fear of financial distress. Another very good initiative of Government of India is the Ayushman Bharat Digital Mission, a forward-looking initiative laying the foundation, I repeat the word foundation, for an integrated digital health infrastructure. Digital health IDs, interoperable health records from this hospital to this hospital, from private hospital to government hospitals. Data driven care pathways are now the vision. They will enable continuity of care wherever the person goes, the patient goes. Transparency and efficiency across the healthcare value chain. This is a huge area of intervention. Now, you know, healthcare cannot succeed as long as it operates in silos, which is the situation today, which has been the situation for so many years. So, the role of the private sector, healthcare institutions, diagnostic companies, and innovators, while it has been critical in expanding capacity, adopting cutting edge technologies, and delivering specialized care, it all needs to come together, especially in the area of oncology. The collaboration of the public programs and private expertise has to be strengthened because this collective ability to reach to the last mile patient is what is required. As Dr. Sanjeev said, it is not for the policymaker or the bureaucrat to fight cancer. Ultimate fight is by the patient and patient's family. So whether they fight it in the public sector or in the private hospital, it is the same. Dr. Pendharkar here, a much respected name, he has worked seamlessly from public sector to private sector, not only in India but abroad. And I have been part of his, growth and professional journey for the last 10 years since I met him in 2016. And I can say that, he has given us some very good models. I will digress a little. I went as election observer to Jaisalmer, Rajasthan in 2018. He called me just like that. I said, I'm sitting in Jaisalmer. So he said, you must go to the district hospital there and see the daycare center established over there. So imagine the surprise of the civil surgeon, the chief medical officer, when a message went to him that the observer wishes to visit the district hospital. It was a Sunday morning, and early morning I went there. And I'm telling you, there was a woman patient there, all of 70 years of age. She could not speak Hindi. She could only speak that local Jaisalmeri Sindhi dialect. She had never been to the town. She had lived all along in the desert. But she was down with cancer. She could not walk. She was brought to some health outpost. The doctors brought her to the district hospital. And with the help of the interpreter, when I asked her, how are you feeling now? She said, God bless all these people. She was an old woman wearing that traditional desert ka काला लहंगा and यहाँ तक जो because to prevent sunburn यहाँ तक black कपड़े right till here and all silver kadas in her feet, hand, neck. She was laden with silver. So she said, God bless them. I had so much pain that I could not sleep. My pain has gone. I can eat. So his work has been, he had set up that center in Jaisalmer. So we need people in the private sector who are public spirit and who can do this, you know, crossover, who can do this public-private partnership. So Uttar Pradesh is now moving firmly in that direction, and the state has made sustained investments in strengthening cancer care. Let me just very quickly mention that we have the JK Singhania Cancer Institute in Kanpur, set up in the medical college premises with the help of the Singhania Industries, Singhania Foundation. And it is now nearly 2 decades old. And it played the foundational role in the state of UP. Now we have set up the Apex Institute called Kalyan Singh Super Speciality Cancer Institute Lucknow. I invite all of you, whenever you come, you must visit this institute, state of the art, huge campus, ultra modern equipment worth a visit for all those engaged in the area of oncology. And this institute represents a new generation of comprehensive tertiary cancer care. We offer advanced diagnostics, radiotherapy, surgical and medical oncology under one roof. I envision that in the next 10 years, Kalyan Singh Institute will become one of the leading cancer institutes in northern India, uh, because we are committed to, bringing the best in terms of equipment as well as HR. Already, the Sanjay Gandhi Postgraduate Institute of Medical Sciences, SGPGIMS, ranks fifth in the National Institute, what is it called? NIRF ranking framework. So, but while I'm talking about these three institutions, let me tell you, this is not our whole strategy. Importantly, cancer care delivery in Uttar Pradesh is closely aligned with the national programs. So there is the NPCDS, CDCS, I should say, which emphasizes population-based screening. Population-based screening is one of the top priorities of our Honorable Chief Minister, and we are focusing on early detection and robust referral mechanisms. Today in the morning, I have requested Sri Kamal Narayanji and other colleagues with whom I was having a cup of coffee that we wish to launch, or should I say, relaunch a really high profile, lot of publicity, lot of awareness, reaching the last mile, distant habitats, difficult to reach habitations for, you know, a rapid screening this year because we wish to really identify and come to know the number of cases in the nation have been discussed by Dr. Sanjeev Kumar. And as you see, what he said in 2016, the incidence of cancer was X. Now it is 30% above 1.3x. But the number of deaths was Y and now it is 1.8Y, 80% above. This means had though many of those cases have been screened and detected earlier, probably this number 1.8Y could have been 1.5Y or 1.4Y. So the rapid increase in number of deaths is indicative of the challenge that the country and the state faces. And one of the ways to go about it is to go for comprehensive and rapid screening. So this year I have with me Dr. Alka Sharma. I hope that many of you will meet her during the course of the day after I leave. She is leading one particular task, which is setting up of 67 daycare centers in UP. We have identified 11 mentoring institutions. Each institution will receive 5 to 6 daycare centers. I was discussing this, how to make our daycare centers effective with Dr. Pendharkar just a couple of days ago. And we really want to look at, not only just allocate these to the mentoring institutions, but we really want to see what goes on over there. Dr. Pandharkar has also suggested to me that we should look at the opportunities for setting up private daycare centers apart from the government daycare centers because he feels that in a state like UP with 75 districts, with a population of 25 crores, every sixth Indian is from the state of UP. Therefore, we need to also have maybe an equal number of more of private daycare centers in the state of UP, and that is what it is his suggestion to me. So, we these daycare centers will deliver follow-up chemotherapy, counseling, supportive care services closer to the patient's home. By reducing the need for travel, they will help us in lowering financial burdens, decongest that's important, decongest the tertiary hospitals like Tata Memorial Bombay and ensure continuity of care. But, ladies and gentlemen, as very well said by my friend Dr. Sanjeev Kumar, cancer care is not limited to treatment alone. Prevention remains the most important tool. Remember, when we were young and we used to travel in trains, those days एसी के इतने डिब्बे नहीं होते थे हर ट्रेन में एक डिब्बा होता था we used to travel in first class, open the shutter, get in the fresh air, otherwise sweet air. Everybody would smoke in your face, but that culture has receded. Unless we are very fond of, becoming a passive smoker, now we have opportunities in public spaces that we don't have to really become a passive smoker. Now it is a matter of choice. If you want to sit with friends who are smoking, that is quite another matter. So one of the ways of prevention was also mentioned in a very personal way by Dr. Sanjeev Kumar. And this reflects this adoption of the HPV vaccine represents a proactive science-led approach where vaccination, awareness, early screening, they all work come together and work to reduce disease burden and prevent its manifestation itself. So preventive healthcare, especially for women and adolescents, is an investment not only in health but also in social progress and intergenerational well-being. जिस घर में माँ स्वस्थ होगी वो परिवार स्वस्थ है. So India is witnessing significant. I come to the other thing. India is witnessing a significant progress in diagnostic innovation, and that is redefining cancer care. Technologies such as liquid biopsy represent a shift towards less invasive. Thank you, sir. Less invasive, more precise, and early detection of cancer. The ability to identify molecular changes through simple blood samples has immense potential, particularly for monitoring disease prevention, guiding targeted therapies, and improving outcomes. For example, in Calcutta and North Bengal, pulmonary cancer, lung cancer is widely prevalent. When we come to UP, we find that, gallbladder cancer and in that region of the body is is more prevalent. So we have to look at these things. What is the occurrence? Is it significant? How to deal with the same? So a very important approach is of deploying eyes of everybody here, the ISW Council. How can we go ahead in this? Because we wish to work towards responsible action, evidence-based integration, and equitable access of these innovations, not mindless adoption. It has to be well thought out. And I am not a fan of a scenario where advanced diagnostics and therapies are limited to a few. That is not my job. My job is to work in that area where these options and alternatives are available to the many, or I should say to everyone. So this brings me back, helps me circle back to the theme of the day, to the work of the ISW Council, to the reason why we are here for health advocacy and dialogue. We are here, ladies and gentlemen, for health advocacy and dialogue. This is a platform provided by the ISW Council to us. I'm happy to be part of such a platform. This kind of platform will play a critical role, has to play a critical role in bridging gaps between policy and practice, and science and society, and patients and institutions by bringing clinicians. I am given to understand that today 40 leading oncologists of various further specializations are coming here and they're being honored on this platform today. Today is the eve of the World Cancer Day, which is celebrated or observed, I should say, not celebrated, observed across the world. So, such clinicians, leading clinicians, industry leaders, and government representatives to foster conversations which translate into real world impact. I encourage the ISW Council to continue to focus on, you know, patient voices, ethical decision making, and system accountability as you know, go through the dialogue during the day. So priorities must always be clear. We have to strengthen preventive and primary healthcare. Ladies and gentlemen, focus on tertiary care doesn't mean that we forget where we start from. The foundation of public healthcare is primary healthcare. We have to expand early detection and screening, support innovation with regulation and responsibility. Innovation with regulation and responsibility, and we have to deepen the public and private collaboration. Remember, I talked about the need to do away with silos. We have to make sure this has to be our top priority, what I'm going to say, that the patients remain at the center of every policy and program. Whatever we do, this dialogue today, the action tomorrow, it has to be about the patient's welfare. So it has to be about trust, access, dignity, outcomes. Let me tell you, in the last 10 years, twice I have been touched by death due to cancer. One of a childhood friend, which brought me in touch with Dr. Pidharkar, and another of a very, very dear cousin. And I can tell you that the loss of a loved one due to cancer is truly something that families need counseling about. This. I'm glad that Josna Govil Madam and her team is working towards that. I commend the organizers, partners, speakers, participants, sponsors of this summit for their commitment to advancing cancer care in India. Let us continue to work together. And at this point in time, ladies and gentlemen, I'm happy to announce that I have already requested the ISW Council to work with my team here and civil service organizations and leading doctors from the city of Lucknow and Uttar Pradesh to host a national dialogue in Lucknow within the next 2 months, bringing a large number of practitioners, policymakers, especially from the state of UP, onto the common platform where we can do a deep, you know, brainstorming, intensive brainstorming. And I welcome the participation of ISW Council so that cancer care in UP becomes, future ready, resilient, and continues to be inclusive. I wish the seventh edition of the Cancer Summit and Awards every success. Thank you, Jay.
I request Mr. Ghosh to kindly join us back and give us this opportunity to thank him, requesting our guest of honor, Mr. Amit Kumar Ghosh, to please join us back, along with Mr. Omer. Ladies and gentlemen, please give it up for our guest of honor for his remarkable address and will now present a token of respect, a token of gratitude, thanking him for his gracious presence and sharing his valuable insights with us. Please give it up for our guest of honor, Mr. Amit Kumar Ghosh. Thank you very much, sir. Kindly give the applause going as we perhaps so we look forward to the team presence in the coming time also with us. Thank you very much. I now invite Dr. Sanjeev Kumar to please join us on stage and give us the opportunity to thank him for sharing his expert insights with us and gracing us with his benign presence, requesting Mr. Omar to now present the memento, the token of gratitude to Dr. Sanjeev Kumar. Thank you very much, Mr. Omar, for doing the honors. Ladies and gentlemen, with this we conclude the inaugural session of the seventh edition of Cancer Summit and Awards, and we once again thank our esteemed dignitaries for joining us. We'll now quickly prepare our stage for our upcoming session. We request you all to kindly remain seated and give us 5 minutes as we prepare our stage for the upcoming session, which will explore how technology enabled innovation is improving early detection, diagnostic accuracy, personalized treatment planning, and clinical outcomes, while also addressing the challenges of access, standardization, and real world adoption across India's healthcare ecosystem. We have our esteemed panelists who will be joining us shortly and will then begin this very relevant panel discussion starting in next 2 minutes. We would request you all to kindly remain seated and keep your phones in silent mode. And now, ladies and gentlemen, our stage is all set to begin the first panel discussion of the day. Please join me in welcoming the panel speakers for our upcoming session. We have with us Dr. Shivani Sharma. Our panelists will be joining us in the next 30 seconds. Once again, requesting you all to please remain seated. Ladies and gentlemen, please join me in welcoming Dr. Shivani Sharma, Director and Vice President, Core Diagnostics. Can you please welcome her on the day? Dr. Sharma brings deep expertise in advanced diagnostics and laboratory medicine, playing a critical role in strengthening accurate and timely cancer detection. A very warm welcome to you. We also have with us Dr. Amita Yadav, Director, Government Relations, India and South Asia, Thermo Fisher Scientific. A very warm welcome. Kindly applause going. With strong experience at the intersection of science and policy, Dr. Yadav works on enabling access to advanced technology through government and institutional partnerships. Please join me in welcoming Dr. Shelly Mahajan, Lab Director, Mahajan Imaging and Labs, Dr. Mahajan is a leader in imaging and diagnostic excellence, contributing to early detection and precision led oncology diagnostics. We now welcome Dr. Dinesh Padharkar, Director, Sarvodaya Cancer Institute, a highly experienced medical oncologist with over 3 decades of experience, will be joining us shortly. And we now welcome the esteemed session moderator, Dr. Indu Bansal Agarwal, Group Director and HOD, Radiation Oncology, Paras Healthcare, a senior radiation oncologist with decades of experience. Dr. Agarwal is known for her leadership in advancing technology driven cancer treatment and multidisciplinary care models. Can we once again give a very energetic round of applause for all of the three panelists? And with this, I hand over the session to the esteemed moderator for further proceedings.
Good morning, ladies and gentlemen. I'm honored and privileged to be invited by ISW Council for the seventh edition of Cancer Summit and Awards. And I think after the very wonderful address by the previous dignitaries, we will proceed further on how the cancer care is undergoing a transformation by advanced imaging, molecular diagnostics, artificial intelligence, targeted therapies, and the evolving health policies. Yes, innovation only delivers value when these pieces work together. Today, we will explore how precision medicine is changing the diagnosis and treatment and what still stands in the way. So, we have a very, very elite and esteemed panel. I'm privileged to have Dr. Shelly Mahajan from Imaging and AI, who is the lab director of Mahajan Imaging. We have Dr. Shivani Sharma from Molecular and Genomics Delivery from Core Diagnostics. She is the director and vice president. Dr. Amita Yadav from Policy and Health Systems, Director, Government Relations, India and South Asia, Thermo Fisher Scientific. And I have the privilege to have Dr. Dinesh Pandarkar, who was my first mentor and guide. So it's truly a pleasure for me to share the stage with him. Thank you so much, sir. She is currently the looking after medical oncology, head of the department at Sarvodaya Hospital, Faridabad, and he has set up many daycare centers all across India. So it's truly a pleasure to share the stage with him. So with this, I would first move on to Dr. Shelly Mahajan. How are advanced imaging, radiomics, AI, diagnostic innovation improving the accuracy, turnaround time, and confidence in cancer diagnosis? Good afternoon to everyone. Thanks to IHW Council and Mr. Rohit for having us here. I think in terms of cancer innovation, we get really, I mean, of course, there are so many new therapies which are coming up, like robotic surgery, immunotherapies, targeted therapies. But I believe that all of this is as good as the diagnosis that precedes the same. So, if we talk about the country that we are practicing in India, when the patient comes to an oncologist, he has already had multiple rounds of consultations with allopathic and other alternative medicine specialists. There is a lot of fragmented reports available with the patient, and usually the patient comes in a very late stage. So, keeping all of that in mind, I think diagnostic innovations is one of the most critical things that we need to discuss and know today. And we are surely practicing in a very exciting era when it comes to diagnostic innovations. And specifically, if I talk about imaging, we have, I think, moved on from finding to understanding the disease. Today, just finding a lung mass in a CT scan is definitely not enough. With the advanced PET imaging, we or functional imaging, we need to give a very precise answers as to how much what's the stage of the disease, how much has it advanced, is it an active mass or is it a pre-post treatment fibrosis, so on and so forth. So we need a very
specific diagnosis for the clinician, which is not just good to have or an optional add on today. It's a must have, and it's a basic expectation from a diagnostician today. Now, also with all the with AI enabled scanners and like the new PET scan that we have in our Gurgaon center also, it provides AI enhanced images, faster images, and a much faster turnaround time with lesser radiation exposure. So I think these are the innovations which are changing the way cancer diagnosis is being made. And this is just about imaging. If we talk about laboratory, of course, histopathology still remains the gold standard. But when we talk about high volume labs and high volume patient load, then there is a lot of it's not uncommon to have a lot of variability in grading of say a breast cancer when it comes to histopathology. So that's where whole slide imaging, AI enabled AI assisted grading systems and mitotic counts, all of that is now very easily available, and it does help in answering the main question every diagnostician has, whether am I improving the accuracy, confidence, and am I saving the time for the patient. And so there are multiple, every day there is some innovation in terms of AI and other technical advances. So yes, I think it's really changing the game of cancer diagnosis, and we do have a lot of technology. It's just sort of about the adoption of the same.
Thank you so much. That was a really nice update to know that, because we know that artificial intelligence is taking over every place, and I think the diagnosis of it is becoming much easier and much quicker because AI is able to analyze so much data with machine learning, deep learning algorithms, and all. And I think the accuracy of the reports, the turnaround time is also improved. So, and earlier, I remember when I joined medical college, then the diagnosis was mainly depending on the clinical examination, history of the patient, X-ray imaging and ultrasound, and at the most you had the liberty to get CT scans or MRIs, and you would get a histopathology report which would just, or an FNAC which would tell it's cancer. That's all. We didn't know whether it's a small cell lung cancer, it's a non-small cell lung cancer, it's EGFR mutated, or I mean, we didn't know anything about the precision medicine and molecular diagnostics. Now, I was just reading that the projected incidence of precision medicine and diagnostics, the forecast that is expected from 2025 to 2034, this is projected to rise from US dollars 146 billions in 2024 to US dollars 412.95 billions by 2034, reflecting a compound annual growth rate of 10.98% in the next decade. And in this, I think North America leads in molecular diagnostics as of now, but the projection is that Asia Pacific is expected to witness the fastest growth. And the next generation sequencing is supposed to dominate the market revenue share by 38%. Diagnostics and assays will share the revenue by 43%, and oncology trials by 2034 will have a revenue share of 52%. So I can see a lot of promise in the field of oncology. So now, with that, I would like to move on to Dr. Shivani. So, how do you feel are the advances in molecular and genomic diagnostics improving early cancer detection and treatment selection today? Because now we are not restricted just to a small bit of tissue which tells whether it's a cancer or not cancer. We are moving from, we don't treat any patient without a proper biopsy. And then we do an immunohistochemistry, and now we are deep diving into molecular oncology. And in fact, we are moving from solid biopsies to liquid biopsies. So I would like you to shed some light on how the genomic profiling, liquid biopsies, and biomarkers are changing how we classify cancer today. So it's a very exciting field for us as clinicians.
Right, and I think this is the right question to ask. You've already set the context. I think we've moved from a reactive treatment to cancer to a proactive approach where we detect the cancer early. When you're talking about impact, I think the maximum impact comes when you detect cancer early. make the life of the patient better, and he's able to live for longer years. And I think this is the whole purpose. So, what has helped us to do this is next generation sequencing, and as you've already told us, that this has a huge impact. Now, catching the cancer early by next generation sequencing is what we do by liquid biopsy. So, what exactly we are doing is that either we are catching that circulating tumor DNA, which might cause the disease, and looking for the correct mutation or maybe the SNPs there. Or we are trying to look at the methylation profiling of the DNA, looking at a pattern in which the methylation is being done to understand whether cancer is there or not, or is it there early. Or we could use AI to look into a lot of genomic data, which has a lot of noise. So, what is artificial intelligence helping us is to subtract that noise and increase the sensitivity and understand that genomic data better. Or we could just combine all of this with some protein marker. And believe me, there is a huge amount of work that is being done across the world. We are not there as yet where we could stand and say that, yes, this is the test and this is how it is to be. We still have to go a long way, but the work is going on. What what help comes through this is not just that we are detecting the cancer early. Imagine a patient who is already treated and is under remission, and now you want to know whether the cancer has come up again or not. So, minimal residual disease. Again, next generation sequencing turns out to be the most sensitive technique in that. So, if you ask me in short, what has helped next generation sequencing has enabled us to detect cancer early, but this has also increased the sensitivity and give us the tool of precision medicine, because now we are treating the right patient with the right treatment, because we know the right biomarker in that tumor, because no tumor is the same in any patient. So this has helped us and enabled us better. I feel artificial intelligence is going to help us even more to understand those vague patterns that we don't know. Once now we know data, we also know that where and how this pattern has been seen in some other set of patients with different ethnicity, to understand the disease better.
So I think that was very, very well answered. So what I get from this is that the way we are looking at the tumor or the genome of the cancer is totally changing. It's not just one size fits all approach. It's a piece like a stitching a bespoke suit for every patient, understanding the molecular genometry of the tumor and then deciding the treatment for the patient. Moving on to that, I would like to understand from Dr. Dinesh Pandadkar, who has a wealth of experience in treating patients, maybe 40 years or more than that. So, and he has been working at the grassroots levels also. So, I would like to understand from him, how is this advanced diagnostics or this elite medicine or elite procedures that we are doing or precision medicine, is it actually translating into patients who need it the most, or it's in the select few group of patients where like liquid biopsies, we as of now as a radiation oncologist we are using it mainly for diagnosing, but as far as my knowledge goes, we are doing it only to detect minimal residual tumors in leukemias, but not for every patient. So I would like to have your perspective, sir.
Thank you very much for getting me here. One thing we have to understand that we are evolving. So, if when we started our practice, the most important thing was just proving whether it is cancer. Then came a necessity to classify the cancer, what type of cancer. And then came a necessity to further classify the cancer. And today, latest in this is I would like to classify the patient molecularly or genomically, that is NGS. Is it doable? Absolutely doable. Does India have the capacity? Absolute capacity. This, I don't know whether I will give you just one statistics. All of you know IIT or Hodge class. In the Hodge class area, in 3 square kilometers, there are 5 NGS machines. That's our capacity. So today, we don't have to say we have nothing. We have everything possible. Is it being utilized? Fortunately, in major cancer centers, it's being 100% utilized. I don't have a single patient who does not have a genomic report or an NGS report with it. It is available. Has it reached the periphery? It has not reached the periphery for two reasons. The reason is not the availability, it's fortunately available. Like the labs we have, core diagnostics or Mahajan imaging,
All of them have penetration up to smallest village of logistics of picking up the sample. So we have reached everywhere. It is still not being done. Why? Because it is not being prescribed. So the major fault lies with the prescriber, with people like me who don't advise the patient to get it done. Why I don't advise? Because I feel that it is not possible or my patient cannot afford. That is what I think. This is again a wrong narrative. Why? In CGHS, believe it, NGS testing is covered for every patient. So CGHS allows this kind of a test to be performed without asking a permission. So NGS reports of 160 genes is available to all CGHS covered patients. What is meant by CGHS? All central government employees, all PSU employees, all defense employees, all retired employees from these organizations. To a huge chunk, it's already available. Now, is it available to a patient under Ayushman Bharat? Not available, but then we have got people sitting here who have a power with Ayushman Bharat. We just have to convince Ayushman Bharat today that please include NGS in Ayushman Bharat because the cost of the test under CGHS is cost of the test which is otherwise available in Ayushman Bharat. So my first demand would be we should raise a voice, include NGS testing in Ayushman Bharat, and it would really become accessible to every Indian. There is another way of making it accessible. Government of Odisha, we did some initiative. I actually work with 9 state governments of India at a district level. I covered 200 districts of the country, physically traveling for cancer care. So I know what cancer care is. I know what district is. I know what governments are. Government of Odisha 4 years back approved NGS testing for every cancer patient being generated in a government hospital available for free, irrespective of Ayushman Bharat or any other finances. It's a great move. So NGS is available free, but if you ask me, is it being done? I would say, I'm sorry, no. Why? Again, I am at default because I'm not prescribing. So there is a challenge at every level. Majority of the challenge lies with us at a prescriber level. And I think if I have to increase the availability of the test and usage of the test, uh, we will have to work. All of us will have to work. A patient has to start demanding that amount of test, and a prescriber has to realize that it is affordable. It's just the small tests are available even at cash if you want to do 15, 20,000 rupees. This is less than cost of the majority of the anti-cancer drugs. So it is a mindset if I'm not doing it. We should have to change because AGS is the core of diagnostics today. And I'm sure with more tests coming in, my laboratory partners will be even able to reduce further down the cost. So it's doable. It is available for public. Only thing is, I should start using it more and more. Thank you.
I think that was very nicely put, and I want all of you to clap for all the efforts that have done for the cancer patients. So I think the one point that emerged from this discussion was that we must first understand what does next generation sequencing means. It means that we dig deeply into the genomic profile of a patient and understand at the DNA level what gene is causing the cancer in that particular patient, and then prescribing the drugs accordingly to the genomic profile of that patient. So the issue as of now is that, as sir said, that we are not prescribing because two main reasons what I feel in my clinical practice is that these tests are costly as of now. So when you prescribe any test, the patient feels सारा पैसा तो टेस्ट में ही लग गया, इलाज के लिए तो कुछ बचाया नहीं. So even if you counsel them regarding the need of a test, they are not willing to get the test done because of the cost. They feel इतने में तो एक cycle chemotherapy का ही हो जाए. So this is the problem that I face. So now I would come back to Dr. Amita. You being the Director Government Relations, India and South Asia for Thermo Fisher Scientific, I would like to know from you how can policy frameworks and public-private collaboration accelerate the access to advanced care diagnostics and precision medicine in India? What can we do to bring down the cost of these tests like Illumina, your lab, and there are so many other players who are in the market. And as a clinician, sometimes we also get very confused because like we're talking about NGS. There is a 32 gene test, there is a 161 gene test, and there is a 500 gene test also, which goes to US and all. So sometimes, and there are multiple labs which are doing this test. So sometimes, even as a clinician, we don't know which test to order for which patient, what would be the minimum panel which is needed. So can we do something to like make a policy or something that for a particular patient for lung cancer, these are the minimum things that we should do, and this should be done with which lab because it's giving you better answers. So what do you have to say on it? Difficult question, I know.
It's a very difficult question. So, being a public health professional, as Shri Amit Ghosh said, that we need to talk about equitable access to care. It is not going to be limited. We don't want to be limited only to a particular section of the society. So, to begin with, and when we talk about cancer, unfortunately, we are living in a world where we are not done with cancer yet. We all wish to come to a day when we can say that, okay, we are done. But unfortunately, we are not. To start on this question, first I would like to pick up different sections we have. We have government as a policy maker. They decide on the policy. We have industry players like Thermo Fisher, Illumina you mentioned. We have clinician like Shelly is there. We have diagnostic partner like Co Diagnostics. Everything has everything have to come together. No one organization or a company or an individual or one intervention would solve this issue. So the first thing which I think should be done, inclusion of better diagnosis and targeted therapy into the AI Ayushman Bharat scheme. I do understand government has limitation on funding and budgetary limitation we all are facing. But then we can carefully do our health technology assessment and see what can be done. The second thing would be to think from a perspective where moving our needle from cost, which is coming as an immediate, to the long-term benefit. We all know if we diagnose a patient at an early stage, the cost of care and quality of life would be better. And if we think in a long term, even if I am investing more, we are investing, government is investing more at this moment, the overall the burden from health economic perspective would be less in the next 5 years. So that's the second thing I would say. And third, as we are discussing about equitable access to care, uh, having a public-private partnership so that we can bridge the gap of infrastructure capabilities we have and also increasing the access to reach to the last or remotest part of the country. We need to have a solid foundation for that. And the last piece which I would say, or maybe it would simplify our work or help us in enabling or getting to a point where we can work cohesively, is to inclusion of database, evidence-based decision making, so that we can come to a point and we all work together and vision for a country where every individual in this country has access to a better cancer care.
Thank you. I think that was very beautifully summarized. And the world cancer, the data says that the incidence of cancer is projected to increase by 77% by 2050. So that's a very, very alarming, disturbing, shattering figure for me. So, and since morning we have been talking about, I mean, we are talking mainly about precision diagnostics and all this, but I think everyone is focused that we need to move into preventive diagnostics and preventive healthcare. So, I would like to come back to Dr. Shelley, and I would ask request the panelists to give short answers because we have to cover too many things. That we are using imaging to monitor response to targeted therapies and immunotherapies beyond traditional size-based criteria. So one move is that where we are diagnosing the tumor accurately, monitoring the responses, and now the response to a chemotherapeutic drug versus response to a immunotherapy drug versus response to a stereotactic radiosurgery on an imaging is entirely different. So on one side, we are working at this level, And on the other side, I think nothing much is being done to diagnose cancers early. So the maximum that we are doing is a low dose CT scan for smokers. But is anything happening in diagnostic field to diagnose cancer early? Because in my 3 decades of career, I have not seen even a single test which I can offer to a patient to diagnose cancer. So what do you have to say on that?
So, I think this is a big problem. Primarily because there is no lack of technology or expertise in this regard. Um, that said, the first thing that comes to mind is that patients are not getting, say, for example, a mammography done because of the cost. What we have experienced in our practice is that that is not the case. This is it's still unfortunately a big stigma, or the fear of getting tested. So in fact we have also had campaigns where we have provided free mammo also, but hardly anybody shows up for that. So I think the guidelines are there. It's Mammo getting a PAP, getting a PSA profile, everything is there in the guidelines. We have good packages which have integrated both pathology and radiology tests to diagnose cancers early. But still, I think because of the awareness and because of the fear of testing, um, uh, in the general population. So it has got nothing to do with a clinician prescribing. It has got nothing to do with the cost of the test. I think it's just the lack of awareness in the general population. That awareness, I believe, needs to start from not from age of 40. That awareness has to start from the age of 20. And because we are only thinking about, oh, my mother had breast cancer, so I should not get breast cancer, and that's why I'm getting only a mammo done. That's not enough. Generally, the concept of health awareness in the society is so less, and I realize that it's also related to literacy or education. The most educated young female would refuse to get tested because क्या करेंगे जान के types. So I think awareness is the major issue here, and that's what I always urge our referring physicians, general physicians, and gynecologists to because those are the only the doctors who are usually in touch with the patients, and a healthy patient usually trusts more than a lab would trust a friendly clinician. So I think awareness is something we really need to work on, and awareness of the fact that an early diagnosed cancer is even curable, not just treatable. So that's
You there, because I think what I feel is that awareness is also there a lot regarding breast cancer, but I think जो सबसे दिमाग में डर रहता है कि निकल गया तो क्या होगा. That is because I counsel patients day in and day out to get their test done, my relatives, my family members. But हर किसी के दिमाग में एक ही डर रहता है कि अगर टेस्ट करा लिया तो डॉक्टर कुछ ना कुछ तो निकाल ही देंगे. But I think डॉक्टर कोई नहीं निकालेगा, वो कुछ होगा तो रिपोर्ट में आएगा. But if your cancer is diagnosed in stage one, it's diagnosed early, or now we can detect cancers even in a pre-cancerous stage, then all the patients would be curable. 90, 95, 98%, even 100% patients would be curable. So आंख बंद करने से जैसे कबूतर ने आंख बंद कर ली कि बिल्ली मुझे नहीं खाएगी, ऐसा नहीं होता. अगर है टेस्ट कराएंगे तो टाइमली डायग्नोस हो ही जाएगा. Just for a show of hands, how many of you or someone in the family has got a mammography done? Means the males can raise their hands if they have got the mammograms done for their wives. So in a crowd of around 60 people, I can see only 6 hands being raised. So that's a very dismal figure. So even if from this session you take this, that you go for preventive health checkups, I think the purpose of this session would be achieved. Now moving on to you, doctor, how do you think that drug discovery in human biology translates into real therapies, and where does the translation often breaks down? Short and response. You want me to repeat that? Yeah. So how do discoveries in tumor biology translate into real therapies, And when do you think that translation breaks down? When it does not translate?
So, as we discussed before, all cancers are not safe. There will be a tumor that is labeled as lung cancer. We always classify it into small cell, non-small cell further classification. But even two adenocarcinomas of lung will not be the same. How we know this is because they don't respond to the therapy similarly. So what we need to do is, and where does it break is when you study that particular tumor in detail to understand what kind of genomic signature does this tumor have. Very interestingly, we also have this concept of tumor heterogeneity, that within the tumor also there will be different kind of clones present, which makes it even more difficult because we don't know whether one particular therapy according to the guideline would affect that. So that's the point where it breaks. And how genomics helps is that we understand the disease, we know that which kind of genomic driver is predominant, and sometimes there will be many, which one to target. And maybe if one does not work, what is your second option? And here comes the answer to your previous question that there are so many genomic panels of so many number of genes. So specifically for each particular point or moment in the journey of the cancer, there will be a test that is available to bring this part, to give the right medicine at the right time and understand why the patient is not doing well. And a very small example one is that why would you do such a big panel for cancer early on? Now, if I do that, I know that this patient carries a resistant mutation for some particular drug. So this is an information that the oncologist should know on the first day itself. It makes him more able to, treat the patient, follow up the patient better, and give better therapy.
I think that discussion raises one more controversial question, which I pose to Dr. Pandit, sir. So, like all of us, we have seen that when we, as a clinician, when we perform these tests, and sometimes a gene pops up which shows that this gene is responsible for a cancer in this particular patient. But sometimes, even after spending a lot of money on the genomics, the report does not show any gene. Or sometimes a gene is shown which does not, for which we don't have any effective medicine, or even if you have an effective medicine, does not actually translate into giving a value to the patient. So, sir, you being a clinician, you must be coming across cases where even after giving the right drug as per the right genomics being seen from the report, we prescribe a drug, but even then the survival doesn't increase much. We talk in percentages, but actually it's a few months. So for you, are we moving towards a future where treatment selection is algorithm driven? And if so, how do we preserve the clinical judgment and decide in which patient should we do this test and in which patients we can avoid? Because India, we have to focus on the economics of the patient.
So if the question is should we do the test, there is no question. It has to be done for every individual, irrespective. This is like if you ask me a question, shall I do a biopsy? I'm suspecting a cancer. Yes, there is no question. Similarly, there is no question. NGS has to be a part of diagnosis of every cancer patient. It's not only trying to get a mutation. If I get a mutation, I have a treatment. But if I don't have a mutation, I have a data bank of mutation which my next generation will decipher and find a drug for it. So I don't only need information to treat today, I need the information to treat the patient tomorrow. So there is no question. NGS has to be a full as wide as possible, a whole comprehensive genomic profiling has to be a must. Number one, and as somebody else suggested, I need a data bank of all this information. So probably the government should make it mandatory for all the reporting labs, for all the reporting doctors to put this data into one database. So that database is available to researchers for future analytics. Which mutation is common, that this mutation probably can be targeted, if not today, tomorrow. So there's no question. NGS is needed. It should be done because even if one mutation is not working, by the time this mutation is failed, tomorrow there will be a drug for the mutation which was already reported last year. So I can use it. So we have to go as wide as possible. We have to invest into diagnostics, and there's no question. Thank you.
Nicely said. So I think the message that I'm getting from this conversation that biopsy is a risk. So that we all know, and although that also becomes split up when we're talking to a patient. But what is emerging from this discussion is it's not just we are not just stopping at biopsy, But we have to go further and get an NGS testing done or the next generation sequencing done so that maybe even if we today we don't have an answer, maybe we get an answer tomorrow. With that, I move on to Dr. How do we balance innovation and cost, regulation and equitable access? She's giving all the difficult questions from my side. You mean to say from regulatory perspective or like overall? How do we balance? I mean, as I said, the balancing would come from health technology assessment. Like whatever penny we are spending, what is the overall benefit we would see at the end of the day, and which has to be done at patient level. PGMIR Chandigarh is doing all the HTA analysis on the basis on the recommendation of National Health Authority. But I think regulatory also plays a role, which innovation is coming and how quickly we can adopt this in the country. And Sugam portal is working well, but it does take a lot of time. And anything which is coming or which has come in first world or in European Union or US, it takes almost 3 years to come to India. So if we can reduce that gap, the timing, and for that, I think the two things which needs to be done is decentralization. As of now, we do have state authorities on CDSCO, but the final decision comes from state federal level, and that takes time. So if we can reduce the time window over there, and second thing I which I wish it should be done, if we can integrate with AI, any technology which is coming, we do have data on that. We do have what is there in that technology, how it is being beneficial to the people. We can get it from AI. So if we can use AI with AI as a support to help us in coming to a decision, what CDSCO is thinking at central level or at state level. So if we incorporate that, and then of course everything has to be done at the economics level. If we do this analysis proper way, then we should incorporate. That's the balancing point I guess. That's a very good way to put it. Now, Sean and Chris answers because I have to cover more. Coming back to Dr. Shelly, what will cancer diagnosis and treatment look like in next 5 to 10 years according to you? For sure, it will be focusing more on how fast and how accurate and how confident a diagnosis can be. So, definitely, we are talking about a lot of AI assisted diagnosis, which will help in definitely not replacing a pathologist or a radiologist, but helping in triaging, highlighting suspicious areas, and hence helping create sort of virtual tumor boards, even in remote areas where actual subspecialists are rare. So I think that's where we are heading to, and that is going to be a game changer. Right. So I think virtual tumor, because we are having tumor boards, but having diagnostic and molecular tumor boards is what we need. So that's a good takeaway from this conversation. From you, Doctor. So we know that we talked about next generation sequencing, liquid biopsies, circulating DNAs and all, and then cell-free DNAs. And then nowadays there is a lot of nanotechnology where we are using nanovesicles and also circulating proteins and exosomes, which are used not just for diagnostics but for drug delivery also. Like I was reading for glioblastoma multiforme, which is a very difficult tumor to treat. Nowadays they are trying some vectors which can be put into the nanotechnology is being used to deliver those things, and CRISPR, which looks like a scissor which can delete, edit, and reinsert a gene, which is cancer-causing gene. So the short answer: how will this look like in the next few years? And is this technology arrived in India?
Yes, so a lot of work has already been done. I'll divide it into two parts. One is diagnostics, and another is therapy. So for diagnostics, as you said about exosomes, now we look for DNA and RNA or nucleic acid, which is free in the blood, which is very unstable. What we have now achieved at a level is to understand and find some vesicles which have a lipid layer, which makes it very stable. Now, this is very important because this vesicle also has information which is in the form of protein as well as nucleic acid, which makes it very, very effective. Not just for diagnostic purposes, there have been n number of studies for PDL1 and other markers for where exosomes can be very good. The second part is that why is it important? It is important because we want to increase our sensitivity. We want to increase our specificity. When we tell a patient early on that you have a cancer, we want to be really sure. So these advancements will definitely help us to make us be very sure that we are calling this cancer or an early cancer, and it is. The second part is the therapy part, wherein we are going and affecting the place where the disease has actually happened. Now we have achieved this great work, and this has been done for years now. This is the time to leverage and execute it, where we can just go there and do that correction inside and make sure that that therapy is done. Why is this important? We are not going to do any written trial. There will be very less side effects. We are treating the disease as it is where it has been caused. But we all understand that this will take time. In India, a lot of work at research level is being done, and I'm very proud that we, being Indians, are able to do it at a larger magnitude because we have more number of patients, more number of data. It's just that we have to all get together and do it. I think a very strong policy which governs everybody, each one of us, can enable this to actually make reality very soon.
So that's so good. So I mean, I think nanotechnology is helping not just in drug deliveries, but this is being used to deliver radiation also. I see a future where nanotechnology will be used to deliver radiation exactly inside the tumor, so that there's no damage to the surrounding areas. So I want to ask from you. We have been talking a lot about so many things, but everything actually starts from gut. So there's a lot of work nowadays being done on gut microbiome. And there are around 11 or 17 microbiomes which have been diagnosed, which are directly related to cancer, like human papilloma virus, Epstein-Barr virus, hepatitis B virus, warning about the vaccination. So as of now, Helicobacter pylori, there are around 17, 18 uh, microbiota which are being assumed, which are thought to be carcinogenic. And then, so can we do something? I mean, we Indians, we are very fond of fatty food and all, and so a lot of work is being done in diagnosing cancers, and the therapies are being based according to the gut microbiomes. So anything you have to say on that?
So, gut microbiome is extremely important part of the body. What resides in your intestines decides what diseases you are likely to gain. It has been now proven. Fortunately, in India, recently somebody just started probably a testing of gut microbiome testing using a capsule that they can actually study your gut microbiome. It is extremely important. So, in fact, it is a reason for cancer. It is a reason for allergies. It is a reason not only for cancer. It is a reason for efficacy of anti-cancer drugs. You will be shocked to know that side effects of the latest immunotherapy drugs, which are most in fashion today, is actually governed by gut microbiome. Uh, I cannot say it proudly, but I know of the cases, and I use this in my clinical practice. I've seen a few cases. Okay, so don't take it like some Babaji speaking, but it's a truth. That a patient came with side effects of immunotherapy, and we advised him to take dahi. Believe it, the side effects reduce. Not reported, not quoted. Please don't quote me. But why so? Because just taking dahi changes your gut. What is gut microbiome? What bacteria is sitting inside? These bacteria go inside and stay there. So they go through your mouth. So the pushing in probiotic. Probiotic is a business. It's a drug. It's a company. But dahi is not a business. So use of dahi, the curd in your diet, the regular use is actually going to change your gut microbiome. So it's my really request, please follow the Indian roots. We didn't have a science. It's always said that dahi and curd and buttermilk has to be part of your daily living. I personally feel within today is really very early, but within next 2, 3 years, you will actually get the data that people who use dahi and curd and buttermilk are either living longer, they have less allergies. So I've been trained outside India. I've lived outside India multiple times. If you go to a clinic in Europe, the most thing you see in a pediatric clinic is children with rheumatism, heart diseases, and joint diseases, and skin allergies. If you know your friends in America, they will all be complaining of allergies. Oh, it's a hay season, it's a cold season, it's that season. In India, none of you speak of hay season, cold season, ठंडी हो गई, गर्मी हो गई. Our children are healthy. We are a different race. Why are we healthier as far as allergy is concerned? Probably, in my personal opinion, the reason is our gut microbiome, which is really different than a European gut microbiome, and it's probably thanks to the our eating habits of curd and buttermilk. That's my feeling. I'm sure somebody will prove this. There's no great science. So I feel gut microbiome is important. How can I use it clinically? Yes, we need to do the research. Thank you.
Yes, I think some work is being done on people, microbiome DNA is being tested for cancer diagnosis and developing.
So, just one second. I'm really sorry to introduce. She just said fecal microbiome. The latest treatment available in America is a capsule made from the stool of a human, and it costs a hell, few $1,000s. So, I'm just to sensitize you how much work is being.
Who are on some who have some panel like ECHS, CGHS, or Northern Railways, or I mean, they still get the best of medicines because the costly medicines they get it through the government. But a cash paying patient actually is not able to pay much because the treatment is very costly. So, how can we ensure, apart from working on prevention, what else can we do so that it reaches more and more people? So yes, I'm a passionate advocate for equitable access. I have been speaking and using this word very frequently, and this is where I come. Like in my answer to your first question, I said that we all have to come together and work together and put a united front. But the major decision maker, the government, will have to think and move the thought process that okay, I am coming. She's coming from a private company. She has a vested interest. She's coming from a hospital or she's a doctor, she has a vested interest. She is everyone has so do government has should have a vested interest how to bring that equitable access care to cancer. So if we move our needle and think that everyone has its own role and everyone will play a role and then only they will be achieving this goal. That is the most basic part. I would say I have been interacting with bureaucrats, minister for long now. It's been more than 15 years. So this is where I always say that you need to think that what is important for the people. Whether I am getting benefit, yes, I am getting benefit, but then it is helping those people. It is your duty, right? We all are responsible, in our own zone. So we have to work together. There's no other way to achieve this. I think that at the center of everything should be the patient. In the interest of the companies or of any hospital or diagnostics or molecular, that has to be separate. We have to first keep the patient in the center of everything. Only then we can achieve what we want to achieve. So I would like to have one line answer from every one of you. Dr. Shaili, please. What one change, technological, clinical, or policies, do you feel would have the biggest impact if implemented to them? I would repeat the question. What one change, technological, clinical, or policy would have the biggest impact if implemented today? Because I want every one of you to answer this. So I think the one change would be better regulation around AI and AI-based softwares. Because why it's becoming infamous is because there are no guidelines and everybody is doing their own thing in silence. So we are not able to get the best use out of it. So I think I would echo Amita's words here that better regulatory guidelines from the government are required to implement and deploy AI better. Thanks. So I think we talk about ethical AI also these days. So similarly, do we have something, just adding on to what she said? We talk about ethical AI, but do we have something like ethical diagnostics or ethical molecular uh, drug type, molecular genomics? Any talk with any regulations there?
So when we talk about regulations, it encompasses everything: the government, the drugs, the diagnostics. But when we talk about the protocol for diagnosis, it's very limited to certain guidelines which are more internationally placed and then accepted by Indians and all of us together in our own way. Because it has to be customized to a manner where it is affordable and also available. So I feel that the uniformity that is brought in how the algorithms for diagnosis work in the country can make these things even better, which should be in collaboration with the regulations. So those algorithms of which one to be tested, how to be tested, at what point in the disease frame, by what technology, and putting them together and making it uniform according to our country's affordability and population conditions. I think that uniform algorithm guidelines for diagnosis. Yes.
Yeah, so we don't have to mimic everything what is happening in the West,
Has
but
to be
we have to customize it as well.
But we Indians, we do that. But we do it in a very, bits and bit manner. It's a little scattered. If we just collaborate and bring together everything and make this uniform, it will be better for our country.
So, should have one, I'll give two, one on diagnostic side and one on the treatment side. So, there is a program called District Cancer Care Program, which was launched in 2014, working in 6 states very well across 200 districts of India. The program was taken out by central government in last budget with a layout of 3,200 crores and called as DCCC, District Cancer Care Center Program. So my first wish is that we run DCCC very well, taking it to the clue how it is already running in 200 districts. This is a solution to affordability and accessibility. This is on the treatment side. And on the diagnostic side, the commonest cancer in men in India is a lung cancer. Is our real problem. Diagnostics of lung cancer is a real problem. And one of the companies has already tried in few district hospitals an AI-based solution. So that's a software that is connected to a routine X-ray machine which is available in every district hospital of India. And that AI software directly determines based on the X-ray chest whether it is likely to be a tuberculosis or malignancy. So I think this software, which is available by free, provided by one of the pharma companies, should be deployed across all the states immediately in all district hospitals and will be able to probably solve a question of early detection of lung cancer, which is one of the commonest in India. Thank you.
Okay, so that's my last question to you, ma'am. What will help Tier 2 and Tier 3 cities leapfrog technologically without huge budgets? What will help? I think we should have epitome of diagnostic center, and then we should decentralize it at the district level and block level and try to connect in one line. That's the way we can reduce the cost one way. And yeah, that's the only way I see as of now. Maybe going forward, we will have some more solutions to this. But yes, decentralization is the goal. So I think we'll wind up this session, and I'm thankful to all my panelists for such a wonderful discussion. So I would just wrap up what we all learned in this session. Number one, we all have to work, first of all, on cancer awareness, talk about cessation of smoking, tobacco, alcohol, adopt healthy sexual practices, talk about HPV vaccine, hepatitis B vaccine, go for the best of diagnostic facilities, get a biopsy done, deep dive into molecular diagnostics, and then choose the drug for a particular patient that will work. And we all have to work together as a multidisciplinary team, and all the cases should be discussed in tumor boards, diagnostic and molecular tumor boards, and then every patient deserves the right to be treated and live a long life. With that, I would like to thank IHW Cancer Summit Awards for having all of us here, and thanks once again.
Thank you very much. I request Omer to please join us on stage for the presentation of mementos. Sir, to please join us, and we'll now be thanking our esteemed panelists for sharing their insights. We'll begin with Dr. Shivani Sharma to please step forward, Director and Vice President for Diagnostics. Kindly keep the applause going as we now progress from England. Dr. Amita Yadav, Director, Government Relations, India and South Asia, Thermo Fisher Scientific. Can we give them a more energetic round of applause? Dr. Shelly Mahajan, Lab Director, Mahajan Imaging and Labs. Thank you very much, ma'am. Dr. Dinesh Vidharkar, Director, Sarvodaya Cancer Institute. Session moderator, Dr. Hindu Bansal Agarwal, Group Director and HOD, Radiation Oncology, Paras Health. We will now request our panelists please come together for a group photograph, and come together, step forward for a group photograph. Thank you very much. With this, we conclude the first panel discussion. And we will now prepare our stage for our upcoming session, which is an insightful industry presentation by Dr. Tina Bhardwaj. As she has a presentation to make, so we'll clear the stage so that you all can see it properly. Ladies and gentlemen, now please join me in welcoming Dr. Tina Bhardwaj on stage, Head Oncogenomics Lifestyle Diagnostics. Dr. Bhardwaj leads cutting edge work in cancer genomics, helping translate complex molecular insights into clinically actionable oncology solutions. A very warm welcome to you. Over to you.
Very good afternoon to all the dignitaries. Thank you, IHW Councils, for having us today and giving us the opportunity to speak, where we will be unveiling the integrated genomic analysis for precision oncology, navigating tumor heterogeneity through three specimen types, that is your tissue, chromatic, your cell-free DNA with liquid, and cancer risk assessment by inherited risk assessment. So this is a multi-faceted approach that we are having, where we are testing and comparing the bridges and collaborating it with the most common specimens that are being referred for testing when it comes to tissue biopsy separately, when it comes to liquid biopsy for monitoring separately, and when it comes to cancer risk assessment separately. We will be creating the bridge where it is being hand curated the 1200 gene panel. So it's not the 1200 gene panel that we are looking into. Our body, our human body comprises of more than 20,000 genes. Why only 1200? Because these are the relevant genes that needs to be studied when it comes to tumor suppressor, when it comes to oncogenes, whether these genes are relevant in causing cancer. Because studying anything and everything doesn't make a point. Hence, it is very essential that we hand curate and understand these 1200 genes that fixes the problem of giving dot to the diagnosis. So these are meticulously created and hand curated by the molecular pathologists as well as molecular scientists following guidelines, the evidences that we have evidence from the start till now with the medical literature, along with the comprehensive and understanding what these genes are coming, whether they are of diagnostic importance, whether they are of prognostic importance, or whether they are of predictive. Are there any emerging biomarkers that are upcoming into the clinical trials? Just before this session, we have a wonderful insight from Dinesh sir, where we understood that maybe it might not be actionable right now, but in near future, definitely these are the genes that needs to be talked about and studied about in cancer genomics. So these genes, the 1200 that we follow, is understanding what are the cellular pathways. Are there any resistance mechanisms involved? What are the next genes? What are the evolutions that are happening? Cancer is not made with a single gene clone. It is made up of multi-clones that come together, creating multiple hits and leading to a full-blown cancer. So it's very essential that we understand them in form of short nucleotide variants, in form of insertions, in form of deletions, in form of fusions, a DNA and an RNA, along with the molecular and mutational signatures when it comes to TMB and MSI. The turnaround time for this is 15 days, and also we have validated this as per the CAP and NABL guidelines, and we could see that there is more than 300 genes that has been detected with a VAC of less than 5% in somatic and less than 0.1% when it comes to liquid biopsies. So the Department of Oncogenomics at LifeCell have a vision. It's not only the genomics we study, it's very essential that we study the phenotype. What is the cancer? What type it is? Whether the cancer is primary, whether the cancer is metastatic, whether any relapse has happened, any previous histories of medication is there and patient has landed into secondary cancer. So it's very essential that we study all of them and come to a conclusion, because what is ultimately a question is how much ever genomics will talk. In spite of all the advances that is happening at the therapeutic fronts, whether we talk on immunotherapy, whether we talk on chemotherapies, the combination, still we are landing up into therapeutic resistance, metastasis. Why all these problems happens is because of the inter and the intra heterogeneity that is encountered into a patient tumor, and it doesn't need to be the same every time. Two cancers same with the histology type have different genotypes, so it's very essential we study them, the subclones, because a cancer is not made up of a single mutation. It's a club and a plethora of mutations that comes together and leads to a cancer risk where a patient develops into a full-blown cancer. So this panel helps us to understand all the genomic profilings along with the TMB and MSI, backed up by the bioinformatics expertise that we are having, develop a computational tool that helps us to standardize this, especially when we are dealing with 5 to 10% tumor contents for somatic testing, whether all our low lying VAF mutations are actually mutations or they are actually noises. So all this quality score standardization is must, and that is done by a very powerful bioinformatic team, so that we don't land up into a false positive or a false negative. Overcoming critical barriers. So we know when we are segregatedly testing when it comes to tumor biopsy, when it comes to liquid biopsy, is there an integrated approach? No. First is the diagnostic, the hematoxylin and eosin staining to establish a patient if he is having a cancer. After that, because of the finances, the economical, we go for a single gene testing when it comes to IHC, when it comes to RT-PCR, when it comes to fish. If all turns out to be negative, the last, the scarcity arises where I am landing up with 5 to 10%. This, as a lab, this is a daily story that we teach with. A comprehensive genomic profiling cannot be tested on a 5% tumor content with 10% necrosis. So it's very evident that we go for a holistic approach, go for an integrated approach when it comes to solid, backed up by the liquid, and also see if any germline or if any inherited risks are there to understand if the patient will work on chemotherapy, will work on immunotherapy, will work on combinations, or maybe there is a different horizon. Today, an NGS report might come with multi genes to you, which might not be relevant. Where you think, no, I cannot action it. But you never know. We are developing a South Indian cohort, an Indian cohort, where we will be landing in the second time in the near future that these can turn out to be action. Now, all these problems, when we are dealing with 5 to 10%, if my DNA and RNA content, the yield is super pure, definitely I will catch hold of the biomarkers. This is backed up by the unpack and NAPL facilities that we are having. And the platform that we are using is MGI, which is drug thrice. And because of that, we are able to cater the Indian cancer patients and give lesser time, quicker time, and more information. So coming to the different blind spot and why this integrated approach we have taken, why we are testing the patient's tumor in form of a block, in form of a liquid biopsy, in form of a EDTA, that is your germline, is because there are multiple blind spots that are present. If a CGP is given with 10%, 15% tumor, no actionable, what happens? TMB MSI is high, but you are not getting a TP53, but maybe at the back end the TP53 may be there, which will synergize into this. I recently have a case. So it's very essential that we study all these cellular mechanisms. There might be a part which may be going under the mutation where the therapies will not work. So it's very essential that we check the tissue. In case if there is sparse tumor content, check the liquid biopsy. If the patient is into a therapeutic or is into a therapeutic management of previous medication history, check if any clonal evolutions are there, if any mutations have evolved, if there are any additional mutations that has popped up. A CMP negative can turn into a positive. That might be a gain of function where the patient's cancer is not resolving. Today, in the era in 2026, we are standing where still we don't have a complete cure for cancer. Why? Definitely, this lacks a problem and also question us what needs to be done in this art so that we can get better clinical outcomes, better assistance to the clinicians, where the broadening of the therapeutics is done and more combinations can be applied for better clinical outcomes. So, coming to this is a paradigm shift that we are having. And that helps us to unreveal the diagnostic limitations when we are testing these three specimens singly and collaborate them to give you a more holistic approach. The clinical impact, yes, we will be developing. It is a more renowned platform where we are testing. NGS is now upcoming in India. Upfront, we are going ahead with the molecular testing. More data, more information is getting unveiled, and every day is a new day with new landscapes coming. And I know the potential of this data that we are having and testing into the clinical when it comes to NGS. So, what is our insight? All the CGPs that are being outsourced outside India, it's better to get because these kits are all manufactured from outside India, whether it is US, UK. It's just a thing. Being a Indian, it's our responsibility that we exploit those information, get to India for the Indian patient testing, use these informations, and can build up a cohort where yes, today we can stand that yes, we do have the actionability, and if we don't have the actionability, and answer that why we don't have the actionability. If a chemotherapy will work, why it will work? If it will relapse, why it will relapse. So it's very essential that we understand this and build up a new tomorrow so that we have better outcomes therapeutically. How we will be scaling this? Yes, we do have 3 runs, so we are looking forward for scaling. And also we are developing this panel so that we go into more proteomics, protein expressions, and also the epigenetics, the methylation. These are all research, but yes, these are the areas which are unexplored in oncology and needs to be evidenced because this information carries lot of information patterns for further therapeutics and why a failure is there into a patient success, why a success answers. So I will, at the end, thank you everyone for listening to me, and I would like to thank all the patients for donating their samples so that we can broaden our horizon and assist the clinicians for better clinical outcomes and for better treatment strategy for them. Thank you.
I request Mr. Uttara Kumar to please join us on stage for the presentation of Memento, Senior Consultant, IHW Council. Mr. Uttara, or do we have anyone from IHW Council to please be on stage for the presentation of Memento to Dr. Tina Bhardwaj? Any representative from IHW Council can join on stage. Ma'am, please take the center stage as we now present a Memento. Can we all please give it up for Dr. Tina Bhardwaj, Head Oncogenomics Lifestyle Diagnostics? Thank you very much for sharing your valuable insights with us. Thank you so much. We'll now kickstart the next panel discussion for the day on research, capacity building, and collaboration. Now we'll quickly prepare our stage for the same. Building a sustainable oncology ecosystem requires more than clinical excellence alone. It depends on strong research frameworks, skilled healthcare professionals, institutional capacity, and cross-sector collaboration. Our upcoming session will focus on how partnerships between clinicians, civil society institutions, and policymakers can strengthen long-term cancer care infrastructure, improving workforce readiness, translate research into real-world impact. And now, ladies and gentlemen, please join me welcoming our esteemed panelists for this session. We have with us Dr. Shipra Gupta, Associate Consultant, Oncology, Paras Health, joining us on stage. Dr. Shipra Gupta. Can you please welcome Dr. Gupta on stage? Is actively involved in critical oncology and capacity building initiatives that strengthen patient care delivery. We also have with us Mrs. Jyotsna Govil, Chairperson, Indian Cancer Society, a veteran cancer awareness leader. Mrs. Govil has dedicated decades to cancer prevention, early detection, and patient support initiatives across India. She'll be joining us shortly. We also have with us Dr. Shweta Bhardwaj, HOD Internal Medicine, Military Hospital, Agra. Kindly keep the applause going as our speakers join us on stage. Dr. Bhardwaj brings strong experience in clinical medicine and institutional healthcare delivery with defense health systems. We have Dr. Urvashi Prasad joining us, former Director Niti Aayog. Dr. Prasad has played a pivotal role in shaping India's public health and policy planning framework. And at last, I'll be inviting our esteemed session moderator on stage. We have Ms. Anshul joining us as our esteemed session moderator. Senior radiation oncologist with a doctor with decades of experience. Can we, our remaining speakers will join us shortly. Over to our esteemed session moderator for further proceedings. Meanwhile, I quickly introduce our moderator, Ms. Anshul Sharma, stage 3 breast cancer thriver and founder, Can Heal. A powerful patient advocate, Ms. Sharma brings lived experience and grassroots engagements to conversations on survivorship, access, and emotional support. And now we have the entire panel joining us on stage for our upcoming panel discussion. And with this, I hand over to Ms. Sharma for further proceedings.
सो काफी सीरियस बातें हो गई हैं और काफी देर से सब लोग बहुत चुप चुप बैठे हैं। मैं अपने बारे में एक बात बता देती हूँ पहले टू मेक दिस लिटिल लाइटर। सिर्फ कीमो ब्रेन नहीं है मेरा, एक अनएक्सपेक्टेड रिसेंटली कुछ नया डाउनलोड भी हुआ है जिसकी वजह से ब्रेन फॉग हुई है। इट्स कॉल्ड पेरीमेनोपॉज व्हेन आई एम नॉट इवन 40। सो एक्सक्यूज मी इफ आई फॉरगेट समथिंग and please give your full attention because all the panelists are very important here, and I think when they speak, you will take lots of information. So please be with us. This is my second panel till now, so excuse me for that also. Yes. How can survivor-led advocacy research and collaboration help build a more patient-centric and sustainable oncology ecosystem in India? Right? Each of you bring unique clinical institutional here and lived experience perspective, and we are confident that your collective insight will make this session deeply impactful and actionable. मैम आपसे तो मैं बहुत कुछ पूछने वाली हूँ क्योंकि हमारी अभी अभी कोलैबोरेशन हुई है। So Dr. Shipra, Associate Consultant Oncology Paris here. What are the most critical capacity gaps oncology care today, and how can clinical institutional address them effectively?
Hi, thank you. First, thank you for inviting me to this forum. And as we have already talked about it in the last panel, there are multiple gaps today we are feeling in India oncology system. The first and the most important is the population and the professional trained oncologist gap. So ideally in US or let's say in all of the Western countries, there is one oncologist per 400 patients. In India, if we talk about the same number, then we have one doctor per 2000 population. So if you see the care gap, the number of people, the population we are having versus the number of doctors in all the fields, be it medical oncologists, radiation oncologists, surgical oncologists, even professional trained nurses, the number is so less that that is where the first gap arises. If a patient is having some symptom, the first most important thing is he want to go and visit a professional doctor. And if it is not even available in the vicinity, so I'm not talking about the metropolitan cities or Delhi, Gurgaon like we are seeing here. I'm talking about all over India. You won't believe 70% of total Indian healthcare system is actually grouped or being present in metropolitan cities. But if you see the oncology patients, 70% of the patients actually come from urban, like rural population, non-urban cities, or cities where there is lack of infrastructure and lack of doctors. So you see there is a major gap, it's major discrepancy between where the more number of patients are like, why the patients are high there, maybe illiteracy, maybe lack of awareness, lifestyle activities, economical conditions. There are so many things. The number of patients are high in rural settings, while the number of doctors are higher in metropolitan cities, maybe because of the good lifestyle, you can say. So the first important thing is that. Second important thing is the hospitals. Even if you see all the good hospitals, they are present in bigger cities. So if a patient, let's say 200 kilometers from here, wants to come and get treated, he has to come to Delhi or Gurgaon or Noida to get the treatment done. And for a cancer patient, cancer is a chronic disease. It is not a one-time disease that you go and visit a doctor one time and then it is done and then you take the treatment home. You actually have to keep visiting, sometimes even weekly. There are chemotherapy regimens that are given weekly. Every week, patient has to come and visit the doctor. So he has only two options. One, either he will shift to the city, so that will add to the cost burden to the patient and a family member. So patient cannot live alone. You need a family member along with him. So somebody is going to leave their job from their original city, move to another city, buy a house there, rent a place there, stay in the vicinity of that hospital, that doctor, so that they can take the treatment there. So this is an additional cost they are going to bear with a loss of income maybe to the other family members, and then the loss of having the family connection and everything. They're not going to live at home. So that is one major problem. Then third is there is no you will say diagnostic setting or good labs available. So I do peripheral OPDs because of the same reason. So I go approximately 120 kilometers, which is not very far. 120 kilometers, I hardly take 2 hours to go there. So the first time I went to my OPD. So I saw like 5, 6 patients, and all of these patients, first thing, they were not aware that whatever symptoms they were getting could be cancer. They were so illiterate. It was a free camp. I actually organized a free camp, so many of these patients actually came forward, and these were not poor patients. They were enough, middle to upper middle class, well educated patients. But they did not know that actually this could be cancer. They just came because they thought some doctor is coming, it is pre OPD, why not visit? Some screening is going on, okay. Mil aate hain jaake. That's how their attitude was. But all of these patients had one or another symptom which was having actually they were having cancer. Then I asked for a biopsy. It was a township of approximately, I would say, 1.5 lakh population, but they did not have a biopsy. Uh, somebody perform a simple biopsy for it. Forget about getting the NGS molecular test. All these are very advanced levels we are talking about. I'm just talking about a simple biopsy. A patient who's coming with a lump in the tongue for let's say last 6 months. I just want a simple biopsy. Somebody who can do it. I actually inquired to almost like there were 70 doctors. I talked to the IMA in the same town. I tried inquiring that why is it like that? And out of 70 doctors, not even a single doctor was comfortable in doing a biopsy because they were not from this field. They were not doing biopsy over there. And one of the doctor who was, she told me that because biopsies aata hi nahi hai, it is very difficult for me. That is why I don't have that settings right now. It was so, I mean, I felt very bad listening to the situation when I saw that I'm just moving 100 kilometers from the city. All these people, they have to come to Gurgaon or Delhi or somewhere, and for that, they need to try and get it done. And sometimes cancer patients are not even in the condition or very good shape to actually travel every day, 120 kilometers on one side. It's very difficult for them. So this is the practical ground reality which we get not even very far. I'm not talking about moving to deeper parts of UP and Rajasthan and Haryana. I'm just talking about nearby NCR. Even there, the situation is bad.
How do we fill that gap? Like we all know where we are lacking and what all practices need to be done. And even forget about the 100 kilometer away from the city. Talking about Delhi, Delhi जैसे शहर में भी काफी सारे even वही जैसे डॉक्टर महाजन ने कहा शैली महाजन ने कि हम लोग इसी पहले तो इसी बात से डर जाते हैं कि कहीं कैंसर ना निकल जाए. That is the biggest gap I see as of now कि निकल जाए से डरना चाहिए या निकल जाए और उसको क्योर करने से बचना उससे होना चाहिए.
You're 100% correct. I'm sorry I'm taking up the time. So, I'll tell you one thing. So, today morning when I went to the hospital, I had my first patient incidentally. She was a lady from Northeast. She was having tongue cancer. Her daughter works at some airline. She is at very good positions. She's some senior executive head. So she came with her mother. Okay, so you understand the level of education, level of income, and everything. So this lady is having a tongue lesion for last 6 years, and she did not even get a biopsy done. I took half an hour in my OPD, first thing in the morning, even before keeping my bag and taking my set home. I tried explaining her for half an hour why biopsy needs to be done. And she did not agree. She did not agree. Even after half an hour, I tried even telling her that you're coming with your daughter. She's unmarried. Think about her. Forget about you're doing something for yourself. Your children, they need you. Do it for them. She did not agree. The first thing she was like, some Ayurveda center has told her that ultimately cancer patients ka kya hota hai. They eventually also come to us. So even if you get a biopsy done, it's going to spread your tumor. So there are so many myths associated in the society where people and she also tell me she learned it from Google and YouTube videos. So
I
there
always say stay away from a Google and a Pinterest.
so many social media videos platforms are telling so many wrong things. So people who are actually doing the work, actually treating the patients, they don't have time. They will not be there on Google, Instagram, and YouTube making videos. Ye karna hai, aisa karna hai, come and visit me. They will not have time to do that. People who are not doing anything and they want to do something, they will be the people who will be there on YouTube and Instagram and telling you कि this is the diagnosis, ऐसा करना है, ऐसा मिला तो patient को ऐसा होगा. So this is just imagine the level of destruction that one YouTube video has done to the mindset of this lady who was been suffering from tongue cancer for last 6 years. And now, as I could see from her symptoms, it was already stage 4. I tried explaining to the daughter that this is the last chance we have. Maybe she have a lifespan of 6 months, but I cannot do anything if she's not even gonna get a diagnosis done. And one more thing, the innovative. So you see the disparity now. So this is one place when I'm talking about that there is no availability of even a biopsy to the patients. Now, since this patient was affordable and she had come to a city like Delhi or Gurgaon, I gave her an option of liquid biopsy. So liquid biopsy is nothing but a blood test which would actually help detect cancer. She was very clear, मुझे biopsy नहीं करानी है. Nobody will touch my tongue. कोई नहीं करेगा. She was very clear, even if I die. So, but I had to take a treatment out. I have to do something. I asked for a liquid biopsy. She agreed for that because I did not tell her it's actually a biopsy. This is nothing but a blood test where you can actually detect cancer cells. How did it, shape the whole thing? Somebody who has the affordability, who has the availability, can actually go to the as much higher levels, precision medicine, molecular oncology, and all those things. While there are people it's not just about money, but there's a care gap. Then there are people who are not even able to afford a biopsy in a sense that they're not even aware about it. They do not have the availability somewhere in the near place so that they can get it done. You know?
My next question to Dr. Joshna Gubit, Chairperson Indian Cancer Society. And yes, we recently come together to raise little more awareness through Can Heal and Indian Cancer Society together. And I'm very happy doing that. So, what role do civil society organizations play in strengthening cancer awareness, early detection, and patient support in India?
I think Dr. Shipra said, Shipra, um, about trust between the knowledge and the patient. That is the biggest gap. And that is the gap that we try to address. At Indian Cancer Society, we are not rabbits. We do have the odd one. There's Dr. Nalini sitting out there, who's a researcher, but most of us are not. We have studied cancer. We have studied the risk factors, the symptoms, the side effects, everything around the main point of just cancer. When we go out into the community, we speak their language. Very important it is. We are not talking biopsies and surgeries, but we talk about having sensible diagnostic tests. We also put our money where our mouths are. we provide them with a certain amount of financial assistance to get basic tests. It's not a huge amount, but it is together with the discounts that diagnostic units give us, a fair bit which covers most of their costs. I'm not talking about the Paras or the Fortis or the big hospitals. I'm talking about the Delhi State Cancer Institute. There are good doctors who want to help, but no facilities, no medicines, no availability of diagnostics. And like you said, cancer does not wait. So you call somebody for a diagnostic test 8 months, 10 months down the line, you have seen their life. So if we can get diagnostics done quickly, if inexpensively and readily, then it makes a huge difference. Even hospitals like Safdarjung, I'm sorry, I'm naming hospital, but that. But even hospitals like Safdarjung, Delhi State are government hospitals. They are meant to be doing all this free of cost. It's nothing. It's not available. So they send everyone to us. So what is this public-private partnership everyone's talking about? Where is the public? The public are waiting in line.
Recently experienced ma'am, what you were saying, and I wrote on LinkedIn and somebody came forward and they were like, oh, you don't know how hard work and this and that. I'm like, no, I'm the biggest supporter of healthcare and the doctors, but what I'm sharing here is my experience, what I witnessed there in the ground with my open eyes, that what. So I always request this profession, which is your passion, all of your passion, not become pressure for all of you. I request that system will, improve a little better.
Absolutely. None of us are criticizing the system. Whatever the government is doing, sir, aankhon pe. It's all right. We've taken 75 years before we've come to a policy like Ayushman Bharat, where we are talking PMG, where they're giving something. It's an insurance against illness to all the private hospitals who are pitching in. But their outcomes are as many as mine. So we have to work together, I agree. But in all the talk, I have not heard since the morning anyone say thank you to the NGOs who are doing that.
I can relate to that, ma'am.
Right. So I was told that we were going to be talking research. And I wanted to thank Pawan Narayan. He has invited me to every single one of these summits. He always throws me a goopy. He never asks about anything I actually work in. So research is not my field. So I just wanted to say thank you to them. He exercises my graces. Trying to allow him.
Ma'am, we need this expertise every time and everywhere. I think the more is best. और कैंसर इतना बड़ा एक स्पेस है आई थिंक इवन 10,000 of us more created in the ground still we have enough space to work for.
Yes, absolutely.
Question is to Dr. Shweta Bhargava, Head Department, Internal Medicine, Military Hospital, Agra. How can multi okay no, it's okay. How can multidisciplinary care and capacity building at secondary and tertiary healthcare level strengthen oncology outcomes?
Thank you, ma'am. I would like to thank the IHW for giving me the honor to share the stage with such a hero. I must compliment ma'am that till now I was listening to doctors, caregivers, pharmaceutical brothers and sisters, but just
predecessor to my talk, I have listened the voice of a healer. So, ma'am, thank you so much, ma'am. First of all, multidisciplinary care, it is a teamwork. It's a team outcome which starts from physicians, surgeons, oncologists, radiation oncologists, pathologists, pharmacists, nutritionists, to healers, and also comprises of patients. Now, when we talk of multidisciplinary uh, approach at secondary and tertiary level, I must compliment Dr. Shifra as she has discussed her today's experience that the distance of caregivers and caretakers is so, it is there is so much of gapping, and for every single thing which is that stigmata of cancer, one has to rush to a metro or a bigger city, and the secondary, zonal, and mid zonal hospitals and caregivers are given a secondary heed also. For taking a simple biopsy, as ma'am has mentioned, even the doctors are scared. Why? Why so much of gapping because of stigmata and in the minds of an individual? Of course, the literacy rate of India is a matter of discussion. But the truth is that when we talk of public private partnership and relationship, one doesn't need to discuss only about the policy makers. We have to talk about policy commitment and how the policy is implemented at the grassroots level. It is very, very difficult for a doctor also to explain every patient when he or she does not want to understand. The reason, जब भी कोई कैंसर शब्द का प्रयोग करता है, पहले लोगों को डर लगना शुरू हो जाता है. The matter of the fact is that they are quite skeptical of the outcome. So, secondary level has to be taken into account. This decentralization to the secondary level hospitals and the caregivers, which will comprise of basic pathology, basic diagnosis, and the robust referral. रेफरल का मतलब ये नहीं है कि हम अपना बोझ आपके ऊपर डाल रहे हैं, बट ये इंडिया है, भारतवर्ष है. हमें एक्चुअली ऑन ग्राउंड ये समझना पड़ेगा कि what we are expecting in a remote place in UP and Chhattisgarh, it will be just an expectation. We have to understand that yes, in tertiary care referral system, there is availability of diagnosis which is better because cancer, as ma'am has just very brightly brought out, cancer रुकने वाला नहीं है. Cancer is progressive. So the sooner the better. Early and accurate diagnosis and early and accurate intervention so that the management is done, so that the person is he is actually taking the medicines, he is actually getting the radiotherapy and chemotherapy done, and there is adherence. So outcome is definitely बात करने से नहीं होगा, वो करने से होगा. There has to be a grassroots level linked up with the tertiary care. And the matter of fact is that all of us are firm believers of the outcome, and we should have a patient-centric approach. As ma'am has told that there in her center, she is not a doctor. She is somebody who's first supporting the patient. अगर किसी भी बड़े अस्पताल का नाम लिया जाएगा, then patients are highly skeptical of the money. I belong to a military hospital. I have served in army for last 15 years. I have realized that there is the reason why most of the patient visit to me as a physician is because it is free. It's not that they can't afford, but of course, the reason is most of us are, the most of the patients they have an average standard of living. So for them, at their level, they should be made to understand that such is the facility available, and definitely this is a teamwork of the policy makers, of the caregivers, and the caretakers. So that has to be streamlined.
half of the people, like half of the community, actually don't know what is the policy. Like I get almost every second or third day, आंचल किसी को कैंसर डायग्नोज हो गया है, बताओ कौन से एनजीओ को रीच आउट करे, कौन सी ऐसी पॉलिसीज है, गवर्नमेंट पॉलिसीज है जहां से हमें हेल्प मिल सकती है. Forget about villages. दिल्ली में रहने वाले लोगों को नहीं पता है ये सारी चीजें. So how do we fill that gap?
Yeah, ma'am. So I have attended this discussion, and the way ma'am has brought out that yes, awareness is lesser. The matter of fact is when we talk of AI, when we talk of nanotechnology, awareness has to increase. There may be ways and means, from right from the pamphlet to the actual caregivers. It is actually our duty as well to make people understand. But kitne log hain? So from it starts from you and it doesn't end on anyone. Everybody is responsible. If each of us start thinking that जितना हमारे एंड से होगा उतना मैक्सिमम हम करेंगे तो आई थिंक दिस इज माय सबमिशन दैट मोस्ट प्रोबेबली एक टाइम आएगा जब हम ये डिस्कस नहीं करेंगे कि लोग को अवेयर ही नहीं है. एक टाइम आएगा and we have to be positive about it because right from our rigorous system of studies as a doctor to our channelizing it as a caregiver, that is very important, ma'am. So I'm highly blessed to share the stage with a healer. I must compliment and I would request everybody to please give a big round of applause for ma'am.
Urvashi Bishar. So I um the Niti Farmer नीति फॉर्मर नीति आयोग डायरेक्टर, और मैं इनको देख के थोड़ी सी नर्वस हो जाती हूँ क्योंकि यहाँ पे जो सवाल के जवाब आने वाले हैं वो कई बार एक्सपेक्टेड नहीं होते हैं बट बहुत रियल और बहुत जेन्युइन होते हैं. सो प्लीज लिसन टू हर वेरी केयरफुली. And the second thing is, on this stage, I'm very happy to share with all the experts, and on the same time, the survivor is also on the stage, and the person who's actually right now dealing with the cancer is also on the stage. So it's not easy to explain the perspective of a person who's actually going through cancer right now and supporting so many conventions, so many awareness events with so much of grace. So big applause around for Urvashi Prashad. And Urvashi, here's your question. How can multi-stakeholder collaboration between government, industries, and civil society accelerate to development of a sustainable oncology system in India? I think no one can tell better than this.
Thank you, Achal. I'm a last minute addition to this panel, but pleasure to be here. Achal is a dear friend, and of course, we also work together on Canteen. Ms. Govil is somebody I collaborate with a lot, and of course, somebody whose work I respect tremendously. So, pleasure to be sharing the stage with them and also the another two experts. So, in terms of, before I answer your question, I think just quickly for those who don't know me, my background is in public health. I'm a public health professional. Um, and then I have worked in the policy space for many years, as Anchal said, with Niti Aayog. And for almost the last 4 years now, I've also been living with a condition called ALK positive lung cancer. So I think I'm quite uniquely positioned, unfortunately, to answer a lot of these kind of questions. So I think, yesterday, on Sunday, in fact, we had the union budget come out, and there was a lot of talk in that about karma and dharma and kartavya. So I want to use some of that terminology where I think that it is our kartavya as a society to worry about cancer, to action at our own level. Just awareness is not enough because we see abysmal screening uptake rates in India. And that's not because none of us are aware. I think when it comes to a breast cancer today, there will be a fairly large number of women who will be aware that yes, something like this exists. But do we really go and get ourselves free? Even if we have access, even if we can afford to, and technically, of course, the government is supposed to offer this free of cost at the primary care level. But again, implementation is uneven. But the point is that that awareness has to translate into meaningful action. I think we are scared of the word cancer because if I ever want to kill a conversation, I just bring up that I'm living with stage 4 cancer, and you should see the color of people's faces change. So it's a great conversation killer, which means we are terrified, of something like this. But are we translating that fear into some concrete action? That is true, not just for the government. Of course, the government has tons to do, and I could go on this forever. Whether it is investing more in indigenous research, the budget has announced a huge biopharma mission, and several, hundreds of clinical trial sites. I really hope more clinical trials open up for people living with cancer in India. Of course, we also need to improve schemes like Ayushman Bharat, see how we can include more cutting edge therapies, because, we're all, people like me are on targeted therapies, many people are on immunotherapy, but those are not covered, in our public health insurance. Private health insurance penetration is still patchy. So we definitely need to improve on that front, because when you have a cutting edge therapy, it is very painful that somebody in the US can take it and live on, even with stage 4 for 10 years, 15 years or more. But somebody in India says, I've sold everything I had to sell, and I cannot afford
During
this
my
anymore.
treatment.
Yeah. So I think that's very unfortunate because life should be equally valuable, no matter where we are born. So I think obviously the government has a lot to do. And obviously, the health system has a lot to do. But I would say that this is a societal issue. This is not just a health system issue. It's not just an oncologist problem. You need all kinds of services to come in. You need mental health support, you need fertility, sexual health support. Nobody, we've had so many discussions, Aanchal and I.
I'm surprised कि अभी तक मैक्स हॉस्पिटल में और अपोलो में पहली बार I'm very proud and I'm not ashamed of talking women's sexual health, because अभी पहली बार हम लोगों ने मैक्स में और अपोलो में women's sexual health के ऊपर वर्कशॉप कराई है, and where people are saying मैम कैसा सब्जेक्ट है, कौन आएगा, क्यों आएगा, we see a response, crazy response. Every single woman is curious to know about कि क्या होगा उसके
बिकॉज
बाद treatment
हमारे
करने के बाद.
सेक्सुअल हेल्थ वैसे ही टैबू है, उसके ऊपर अगर आप कैंसर के साथ सेक्सुअल हेल्थ की
Right.
बात कर रहे हैं तो बड़ी प्रॉब्लम है.
बड़ी प्रॉब्लम है, that is also
आप
female.
तो मरने वाले हैं, आपको सेक्सुअल
Yeah.
हेल्थ के बारे में सोचना है. That is our mindset.
Yeah.
And I think we need to tackle all of this. Only as a society can we do it. We cannot expect that oncologist sitting there who is desperately trying to treat you and control your cancer to do every other thing as well.
See, I also have one more question related to this. You know that कैनिंग community के अंदर बहुत सारे ऐसे young faces हैं जो आते हैं, and you are right now dealing with it, right? So there are so many girls who are not married. Right, when we talk, they are not married, they are pressured not by their families only but the societies also. किसी को पता ना चल जाए इस लड़की की शादी नहीं होगी, इस लड़की की अगर शादी हो गई तो बच्चों का क्या होगा, और कैंसर रिलैप्स हो गया तो कैंसर का खर्चा कौन उठाए. These are the very regular things we hear, right? Now we are doing every year so many events, so many awareness campaigns, and burning thousands of crores all over the world. But I don't understand positive in what manner. When we say positive, we're taking right of our jobs. There are so many job rejection. There is that girl is not able to marry now. And on top of that, if that woman wants to adopt a child to live her rest of the right, she cannot. We are not eligible. So why we live or be positive and for what? Yeah, exactly. Positive. Oh,
Urvashi, you have been to our survivors. So as answered, if I'm not mistaken, when we started the concept of survivor's day, the number of deaths far exceeded the number of new cases. But people came, and now we take the open area which can seat as many as possible. So to everyone in this hall, on the 16th of February, it's a Monday, 3 o'clock onwards, our survivors will be there. Nobody is talking cancer therapy. Sorry. Yeah. But it's a lot of fun because we want to showcase the fact that our survivors are people first. They're not cancer patients. That label has to go.
Yeah, please don't give us that label of survivor fighter to our name.
हम विजेता कहते हैं. But in English, unfortunately, survivor is the term that is.
I mean, terminology, just very quickly, I know you're up of, running out of time, but just to say terminology matters, language matters. New York Times, there was a headline saying lung cancer patients. And I said, this is wrong. I'm not a lung cancer patient. That's not my identity. I am living with lung cancer. So you can say a person with lung cancer, but please don't say cancer patient because that's not all that we are.
Person. We are discussing.
Yeah. And I think just finally, if I would just take 10 more seconds to just say that the point you were making, Achal, about the positivity, I think that, it cannot be artificial. It has to be enabled. I have people reaching out to me and saying, oh, nobody will give you a job because you have stage 4 cancer, you could die anytime. The adoption rules of the country will not allow someone like me to adopt, even if everyone else around me is fine, healthy. So we discriminate in so many ways. And then we tell the patient, go be positive and live in the moment. And, all of this is such artificial nonsense. Unless we create the actual ecosystem, we stop discriminating. You cannot just put the onus of positivity on a patient.
You're taking a right from a survivor who's actively do everything. It's sad. So I think we need a change in society. We need you to accept us as a human, not as a survivor.
And as a doctor, so it was almost 10 years back. You could understand when doing your MD, there's something called thesis. Thesis is one of the worst nightmare a student has during their residency time. It's a 2 years project. You have to collect the data, and then it undergoes like thousands of revisions. Even then, your mentor says this is not correct. So I did my thesis. It was on breast cancer patients. I'm just telling a small thing. So uh, I did it, and then there was a lot of research, this, that, and there was a lot of data. Everything was done after 2 years. So after at the end of two years, I was very happy that finally all the revisions has been done and I'm going to submit it. When I finally got it done, and that night I slept very well, that tomorrow my thesis is going to be finalized, I went to my mentor and he read everything and he rejected my thesis outright. And I was like, sir, I have done everything like you said. I've done all the revisions, all the references, everything. It's marked, it's been grammarly said so many times, every word, this, that. It's like everywhere you have written patients with this. You were not supposed to write patients. You're supposed to write women with breast cancer. It's not patients with breast cancer. So that thing 10 years back, which just struck me so bad that I actually was referring all the people as patients with this. Everywhere I've written patients. And then I did my full revision and it was women with this. So, the whole time it actually starts from us and we don't even realize at times what we are doing. So it's just when you interact, when you actually talk to the people and you realize that it is not patients. They are people. People, just somebody in your family, somebody around you. They're your friends, they're your family, they're just people.
Thank you so much. Thank you so much, everyone. And I'm so happy, and I think they all deserve a huge round of applause. If you think they made a point, और यहाँ पे कुछ उन्होंने ऐसा बोला है जो आपके लिए बहुत अच्छा टेक अवे हो सकता है. So
Thank you very much for the enlightening session. Request Omer sir to please join us on stage for the presentation of mementos. We'll begin with Dr. Shikra Gupta. Please step forward. Associate Consultant Oncology, Paras Health. Please keep the applause going as we present the phenomenal to our community and thank them for sharing their valuable insights with us. Mrs. Jyotsna Govil, Chairperson, Indian Cancer Society. Thank you for following. Dr. Shweta Bhardwaj, HOD, Internal Medicine, Military Hospital, Agra. Please step forward. Please give it up for Dr. Shweta. I request Mrs. Govil to please stay with us for a few more minutes. So you may please stay with us. Dr. Urvashi Prasad, please step forward, former Director, Niti Aayog. Ms. Anshul Sharma, founder, Can Heal. We now request all the panelists to please come together for a group photograph, to kindly come together for a group photograph. And meanwhile, I would request Dr. Sanjeev Kumar to please join us on stage. Thank you very much. I would request Dr. Urvashi Prasad to please stay back and Mrs. Jyotsna Govil to please stay back. We request or maybe with our ladies and gentlemen, will now be honoring Mrs. Jyotsna Govil for an award for leadership in cancer awareness and community outreach. For nearly 4 decades of international global leadership in cancer prevention, tobacco control, and community education. Can we give her a more energetic banner? We are honoring her with an award for leadership in cancer awareness and community outreach. And we have the entire panel joining in at this moment of pride and honor. To all for joining us for this session. And this recognition as well will now begin the next panel discussion and then we'll break for lunch for this session. Ladies and gentlemen, we request you all to remain seated as we'll quickly prepare our stage for our upcoming panel discussion on public health policy, which plays a defining role in shaping cancer care and access and affordability. Our upcoming session will explore how Ayushman Bharat, national health schemes, and public-private collaboration can be better aligned to strengthen coverage, equity, financing, and system-level integration, ensuring the policy intent translates into patient-level outcomes. And now we are starting in next 10 seconds. We once again request you all to kindly remain seated. We'll begin the next session on policy and public health integration. Starting very shortly, to all to remain seated. Post this session, we'll break for lunch. And our stage is almost set. Ladies and gentlemen, now please join me in welcoming on stage our esteemed panelist, Dr. Monica Puri, Chief Commercial Officer, Roche Pharma India. To please join us on stage. Dr. Monica Puri. Dr. Puri has an extensive experience in driving access to innovative therapies and shaping value based healthcare models. She'll be joining us shortly. We also have with us Mr. Sharad Goswami, Senior Director, Global Policy and International Public Affairs, Pfizer. Mr. Goswami works on aligning global policy frameworks with national healthcare priorities. A very warm welcome to you, sir. Please welcome Ms. Hena Dhawan, Head Country Public Affairs, Novartis, India. Ms. Dhawan brings expertise in health policy, stakeholder engagement, and advocacy for patient access. I think we can give them a more warm round of applause. We also have with us Mr. Uttara Kumar, Senior Consultant, IHW Council. Mr. Kumar works at the intersection of policy, partnership, and program safety, contributing to collaborative health ecosystem development. And this session will be moderated by Dr. Vibhav Garg, President, Global Government Affairs, Merrill Group. Can you please welcome our esteemed session moderator? Dr. Garg brings a deep experience in global policy and advocacy, market access, and government engagement in healthcare. And now over to esteemed moderator for further proceedings.
A very good afternoon, everyone. Thanks for joining us for this session, which is between you and the lunch. So I know what I want to do. I want to quickly finish it off. But before we get there, I have a wonderful set of panelists with me, and my worry is three of them come from pharma background, the largest pharma companies of the world, and I'm the only one who's from medical devices, but I'm asking questions. Okay, so I will request all of you to also give some flavor of technology whenever you are responding, Putra as well as you as well. But I will try to bring certain facets from the medtech area also whenever we are discussing. With that, I start. Maybe I start with Sharad with you. Pfizer globally has been involved in research and development for many, many molecules. But I think what I see you doing in India and maybe other part of the world also is a lot of PPPs driving to improve cancer care across globe in many geographies. So, PPP is very important, particularly from India angle, because we as a country are working on bootstrap resources, basically, right? Whether it is um, diagnosis of cancer to palliative care of cancer patient, right? All the steps. So, in your understanding, in your observation, if PPP has to be a redressal mechanism of cancer care in India, what do you think are the components that we need to be taking care more to be able to make it a success in this program?
Thank you, Vibhav. And I think we are in very, very good hands because I know the quality of your moderation. I've seen it many times. Thank you. You're going to get the best out of this panel. Um, and I made some notes because Vibhav, I knew you were asking. Here are a few good examples that I'm sure we've all heard of, and you can go back and research a little bit more. But so accelerating or enabling cancer care, I think, has many, many components. I mean, for the one that we understand very easily is how do you make the drugs or the therapies more available and more affordable and more accessible to the population at large. But then there is a whole lot that goes into this even before a new therapy is available to be made accessible to patients. So there are so many examples of PPPs which are targeting different parts of this journey. So Cancer X, which is a fantastic initiative under the Cancer Moonshot Initiative in the US. I was reading about it. They've got such tools which are targeted at solving the clinical trials aspect of this. There is Trial X, which is a AI-powered clinical trial finder. There is a Predict X tool that has been developed as PPP, which is looking at an algorithm to determine precision dosing. There is Match Miner. There are these kinds of tools which have been developed so that the clinical trial journey can be more accurate, it can be faster, and you can get to, from preclinical to phase 1 to phase 2 to phase 3 much, much faster.
The City Cancer Challenge, which I think a lot of you are perhaps aware of, is trying to solve health system strength. That's again a PPP with large global multinational companies as well as with the governments. The one thing that struck me when I looked at Cancer X was, and maybe that's a learning for us in the country as well, is how in some of these countries the regulator is not just a appellate body. It is not a institution to which you simply go once you have the data and then you get a yes or a no or a do it again answer. In many of these countries, as much as I was reading, I was realizing that the regulator is becoming more and more of a partner with you. This Cancer X and all of these tools that they have made to accelerate clinical trials have been made jointly by the US FDA and the large oncology companies. Because the US FDA perhaps realizes that it is in their interest also that the quality of data is better, that the decision making is faster. And that I think is a journey that in India we are able to take as a next step, such that we work much closer with the regulator to accelerate this journey. That would be a very good example.
Oh, thank you. Absolutely. I think bringing regulator in the picture is going to be very, very critical because at the end of the day, time to market is in the hands of the regulator, right? So I think it's very critical that we make them as part of the entire ecosystem and not just leave them because, okay, you just approve and then we start access to market. That will be very late, actually. Thank you for that, Sharad. And I move to Hina now. Hina, well, PPP is a fantastic, tool to bring access faster and closer to the patient, right? Um, I think access to care is also very important, and your organization is running many patient access programs globally. Um, the if you really translate that into how do we improve access in India, I think PMJ today is really playing very important role. 60 crore people will be benefited across the nation, and government is now also thinking to make it a universal health program for everybody in the country. I don't know how much time would it take, but there is a effort towards that, right? However, I still see from a policy angle that I look after in the company is there are a lot of barriers still in that access of care for PMJ beneficiaries, right? So there are financial barriers and there are non-financial barriers. So financial barriers will be addressed by PMJ, fund which is coming in 5 lakhs rupees per family to be increasing. But your thoughts on non-financial barriers, Hina, that you can think of, and how do we address them, and from your experience of access programs that your company is running globally? So over to you, Hina.
Thanks for the question. And just to balance the tipping scale in favor of pharma on the panel, I do have a public health background, so I will try and integrate those learnings in this discussion as well. So, PMJ, there are a lot of non-financial barriers because, as you mentioned, one of the biggest barriers, and you would relate to it coming from medtech and that side of the industry, is the late diagnosis or screening. Because most of the patients in India, when they are diagnosed in advanced stages. They are not diagnosed in early stages. So there is a need to strengthen that piece of the ecosystem. And PHL being in predominantly inpatient scheme is not helping in that aspect. So there needs to be a continuum of care which needs to be built in, which links your primary care, early diagnosis to final diagnosis of the staging, everything, and then leading to the care of the patient through PMJ network. The other non-financial barrier, which I think all Indians are facing, is the lack. And more so in the PMJ because PMJ is a public-private empanelment kind of a scheme. You can't just walk into a hospital. The hospital has to show interest to be expanded under the scheme, which again acts as a barrier when the patient is looking for a hospital and there is no hospital around there to take that care that they need. The third one that I would consider is the absence of a standard rating protocol. Even if you walk into a hospital, there is absolutely non-standardization of the care that will be better. There are a lot of advanced therapies and advanced treatments which are there, but because the quality of care differs across different hospitals, you don't really know what treatment will you get. Will it be optimal? Will it be suboptimal? And so on and so forth. And considering the paucity of time, I will limit myself.
Sure. Thank you, Hina. Thank you so much. And I have a trivia question between I'm asking question from my panelist. Anybody can tell me how many cancer cases roughly are diagnosed in India every year? Additional, the new cancer case diagnosis. I will take the answers after the question. You are sitting in a cancer summit. At least you should all know what kind of burden we are talking about. 1.2 billion. Yeah, okay. 1.2 is little less. We are close to 2 million actually. Annual cases. That's the kind of burden that we're talking about of this disease in our country. And I think that's where this summit is so timely and so important for discussion. Thank you. Oh, Monica, you are the only commercial person among four policy people sitting on the panel. So I will not leave this opportunity to pick your brains on some of the commercial questions that I want to ask in cancer care, right? So I think you as an organization and individually also, you guys have been involved in health system strengthening. And I think health system strengthening is becoming so critical because it is important to overhaul our health systems, particularly public health systems in our country, state-wise as well as, of course, the central government. But you know, when we talk about access to care, pricing models are very common, right? You have patient access program, different pricing models for the disease, for the drugs and so on and so forth, or the therapies for that matter. But beyond pricing models, do you have any take on other procurement models that we're talking about, value-based procurement or volume-based procurement, which will be helpful for a scheme like Ayushman Bharat? We talked about, if you remember, about 2 years back, they were talking about HEFTA unit, which is supposed to procure centrally based on value or volume, right? So your take on some of those initiatives and how would they add value in creating better access? Your thoughts?
Okay, I'm audible now. Thank you, Vibhav. I think every time when I'm being called in as a commercial person or a Roche person, I think first thing I remind myself that one thing I hold myself very proud about is that I'm a doctor first. And that's the point, being a doctor yourself and worked in public policy and then going to the corporate side of the world. It gives you a 360-degree view of how you can deliver healthcare. I can tell you from my own experience and now being more pertinent towards what you asked, the pricing. I always wonder asking question to others also and myself that, but what is the value that you will add to the life of a person? Can it be said in numbers, lakhs, crores? The value that it means to the family, the for whom it could be a breadwinner. What would be the value of a cancer? I don't want to call patient now because we've talked about it, a person living with cancer in terms of the societal impact that person can create. And that is why this entire model of pricing needs a discussion, whether we are talking about cost or we're talking about value. Because value cannot be defined by a monetary number. Value means what is the clinical benefit a new therapy or a technology is bringing to the life of a person living with cancer. What is the value in terms of societal impact and in terms of government policies and programs it is bringing in? And to that point, we all love Ayushman Bharat. I mean, Henna and myself have been part of Ayushman Bharat rollout 2018 from the government side of things. And one of the focuses from the very beginning was on cancer care. What, and of course, it has been iterated. You talked about HEFTA. She mentioned about diagnosis as a challenge. If we know the life journey of a cancer person seeking treatment, majority of the expenses are in the first or second year of life. If you could intervene early, if you could intervene faster, chances are that you will be able to save and salvage the life of that person, which means it will be cost intensive, resource intensive. Which means even if I look at Ayushman Bharat today, where we're talking about a 5 lakh family floater, can this be a flexi group? Which means if a family has a floater of 5 lakh for a year and I multiply it by 5 years, it's a floater of 25 lakh rupees. Can this be a flexi pool for that family, which they continue to use as or when within that 5 year range? Which means
might be resource intensive in first or second year, because even if you look at basic cancer treatment, and we talked about, these patients usually come at the end stage, the treatment will never suffice in 5 lakh. You might do more harm to a patient by giving more, chemotherapies, which are toxic, have more side effects, versus giving targeted immunotherapy, or what you call now with immunotherapies coming in to really pick up the cause and treat it then and there, which of course may be expensive. And that is why reimbursement of these therapies, and you talked about HEFTA, I want to bring in the very fact that India is moving towards technology assessment is a great move. I totally appreciate that. And one of the learnings of those studies that came was the drug. And I don't want to name the drug because it belongs to my company, but a drug that has been a game changer in the history of breast cancer, because it was the first monoclonal antibody which saved millions of lives across the world, turned out to be cost ineffective in our HIFTA studies, right? And the reason is not that the drug was really expensive, because every company, when they bring innovation, they use the differential mechanism and indigenous drug made in India to have the same ICER value to evaluate assessment for that drug. And that's where the challenge is. HEFTA is good. We're talking about value based procurement, but we also need to bring those standard frameworks of how we evaluate these drugs and really add value they bring to the person.
Thank you for bringing that aspect, Monica. Uttara, I come to you, and you are coming from a public health background from ISW Council in-house. I think, and I've seen a cancer from very close angle in year 2023 in one of my family member. And I can tell you, it is just not doctors, just not dietitian, just not the food, just not the care around the patient. It is multiple stakeholders which came across the journey of that patient along with the family, to create that ecosystem for care, right? And I think how do we how and not everybody in the country is getting the same care actually, right? You will see the stakeholders are missing somewhere the care level is missing. If you go to private hospitals to public health hospital systems, you see the level of care is different basically, right? So in your view, Uttara, in terms of, if you see the collaboration between the government, the care providers, the therapy providers, the pharma company, the medtech company, the academia, the civil society, very, very critical part of the ecosystem. How do we accelerate the development of this sustainable oncology ecosystem, utilizing these all stakeholders? Any thoughts there?
Thanks, Dr. Very relevant and tough question, right? Because if we look at cancer care in India, there are hundreds of challenges. So anything you pick up, whether it's screening, diagnosis, treatment, everywhere there are challenges, right? And if we're able to solve one or two of them, we'll be actually able to transform cancer care. Now, if you were to start at the beginning, what are the issues? Like key issues, I think some of the panels already spoke about it. Oncologist, right? One is there's limited capacity. The second is the limited availability or access to medicines. How to improve cancer care in India, then we need to have a multifaceted approach, right? Which works around one is building public awareness to get a prevention in the first place, and if not, at least go and get tested, right? Second is education of physicians at a primary care level, right? Third is building up the primary, right? Third is building up the primary care workforce so that they are able to screen a bit earlier, right? Fourth is getting appropriate referral mechanism pathway so that patients or suspected patients are going for appropriate diagnostics, are going to an oncologist. And then a lot of work which needs to be done around the policy space so that there's adequate resourcing so that patients are getting the best appropriate treatment. Because right now, if you look at me talk about PMJY, right? But does PMJY provide you the best opportunity? No, right? It provides very basic treatment. So then we need to have a mechanism in which such treatments are funded, right? And that requires a lot of collaboration between civil society, organizations like IJB can work on that, with pharma, with government, and multiple players who come together to find a solution. Whether we have a solution right now, no. There are solutions, yes, they work in bits and pieces across the country. But how do we build up something which is sustainable? That's a challenge that we all need to work together and solve.
No, thanks, Uttara. Very important. How do we resource the entire care continuum for cancer patient is very, very critical. And not every step in that continuum is provided in the same ecosystem as well. Sometimes it is, the patients are moving from tier 3 to tier 2, tier 1 cities at times, and care continuum is really broken if you really move from the city. So very, very good. Thanks for that bringing, Uttara. My second trivia question for all of you, which state in India is contributing to the load of patients that we talked about, which are diagnosed new cases every year? Which is the state contributing the most to the new cancer patient diagnosis burden of the country? So there are 2 million we talked about. Which state is contributing the most? That's my question to all of you. Please keep your answer ready. Now I go to for my next question, I'll come back to you for the answer. So Moni, I'll come back to you again, and I'm finding this combination of yours as doctor, commercial, and public health very interesting. So, I'm a pharma student and I did my biotechnology after that. And I was doing my MTech biotechnology project. Human genome was decoded, right? It was 2001 summer. It was published in Science and Nature both. And I became so interested. I said, what next? And then what started next was pharmacogenomics, personalized medicine for people, right? Do you think that as a reality for cancer happening in India? And if yes, what would it take to get those things included in schemes like PMJ? And whether it is really possible to include, or they will remain for accessible to only for private payers or private insurance? Your thoughts?
Absolutely. And if I may ask, I mean, cancer is no surprise for anyone sitting in this room. We all may have in our close family, distant family, friends and relatives. And if you ask a very basic question to anyone dealing with cancer in the family, is like, what is the outcome you want? Beyond, of course, financial hardship that you may have, the outcome that you would want is to say, we just want that person to survive longer and healthier, whatever it takes. I think that's the answer anyone will give you. And when we talk about survival, I mean, like I mentioned earlier also, you could diagnose faster. You could let women know that they've got breast cancer and then let them suffer, say, I don't have a treatment to provide, or I have some treatment to provide, which is a chemotherapy, and live with it and you will die soon. Versus, I have a targeted therapy for you, and if you just take it now, your chances of survival is 95%. And you may live as longer as anyone else, near normal. What do you think that lady would choose? Of course, to live a longer life with a 95% survival rate. How is that possible? You talked about decoding the genomes. I mean, and I'm very proud to say this, Roche, just last year we announced now we can, through a diagnostics division, we can decode the entire human genome in less than 8 minutes. And that is the innovation that we are talking about. Now, bringing it to medicine and cancer treatment, like I said, I mean, everybody would want that targeted therapy to live better and longer. But of course, it comes with a price tag. And that's also because innovation, one molecule that comes out of successful molecule that comes out of lab to market takes 10 years. And in that 10 years, billions of dollars have been invested to get that one innovation out of 2,000, 5,000 clinical trials going wrong. Who's going to pay for it? Of course, everybody needs to pay for it. Government needs to pay for it. Scientists who are putting their time into it, organizations which are putting money into it, and patients who are looking for a solution to that. We all need to come together. The challenge is when we push the entire industry to take that cost. My humble request is we all want the best. But when we all want the best, we all need to come together and look at a model that works for us. Which would be like we talked about value based agreements, right? But I think the bigger challenge is can we also talk about pay for performance? I give you a therapy. If it works well, you continue to pay for it. If it doesn't, I'm happy to make sure that whatever cost I can take as a provider, I take it. That's the pay for performance model that we are talking about. We can talk about outcome based agreements. If the disease is progressing, I am happy to make sure that you have the next level of treatment available for you. At least let's start to work together. And only when we move from this, L1 procurement to very value-based procurement, we can make it accessible for all. Because see, no pharma company, I would say on behalf of all the MNCs sitting here also, want to be in a situation where we don't want to treat. Because if we don't want to bring an innovation, why would I bring it to a country? I can very well profits in other part of the world. The very reason we want to work is that's where the prevalence is high, the need is high. The only thing we ask is to let's trust, let's discuss, and let's come together where government has its stakes, private care has its stakes, regulator has its stake, and we all can work towards a financial model and make it happen.
Oh, thank you. Dr. Monica, coming from a physician paper performance is music to my ears, honestly, right? That's where I think we can change the entire ecosystem in the best possible interest of the patients, right? When I can tell you the case I was referring of my close family member, we ended up spending 1.8 crores in just 7 months with patient not with us anymore. Right? That's how many people in the country can really afford it? Not possible. I think that is something, I think it's a very good example of what innovation can be brought into the care itself. Paper performance is a very good example of it. Thanks for that. And I come to you now, and I touched about this in the previous discussion as well. When a patient moves from tier three to tier two to tier one, the standard of care is very, very different, right? And they end up moving to tier one because that's where the care today is concentrated for cancer disease, right? PMJ, however, I'm again going back because that's a reference in front of all of us. It has beneficiaries in tier 3, tier 2, tier 1, and tier 4 also now, actually. So, how do we utilize this scheme to really standardize the care or standardize the protocol at least across T4 to T1? What's the thought on that?
When the scheme was being conceptualized at the time, the idea was not to build hospitals because as a country we tried to do that and we don't accept that. The idea was to give the purchasing power to the people wherever they are based in the country so that they can go and buy the care by getting that financial security. But unfortunately, the centers of care are still limited in tier 1. The expectation and the hope was that as the scheme matures, as the availability of funding matures, the care centers will get developed closer to the patients. Tier 2, tier 3, tier 4 now. That is still taking some time. But globally, wherever we've seen that there is an attempt to standardize treatment protocols, there are two things which are needed. And that's the same for India. One would be try and have a standard treatment protocol which is applicable for the entire country. Today, we see that certain states are trying to do that for their cancer care programs. We see that ICMR has one. We see that certain other programs have their own. Certain institutions are trying to build their own. There is no national cadence updated kind of a treatment. Even if there is one that was developed by HG, it's at least 6 years, 7 years old. There hasn't been any update to that in so many years. One is that requirement that we need to have that protocol, building on the expertise of the experts which are there, both global and national, which gets updated frequently. Second is to try and align, at least at the central level. I know that health is still a state subject, states will still have their variations. At least at the central level, that parity of the care which is delivered to a patient, and that should be equitable. A CGHS patient should whatever care they are getting, the same care should be extendable and applicable to PMJ patients. There should be no difference in the kind of care that is extended there. If a PMJ patient walks into the same hospital, same treatment protocols, same degree of quality of care, that's the norm that we are looking at. And it's not easy to deliver that. We are a country of 1.4, 1.5 billion people. It's not easy, but benefit is that we have amazing digital infrastructure to support us there. We have ABTM, which is getting strengthened and still needs to get strengthened, which can get us know that monitoring, that data, all of that, which will help in evolution of these standard records as seamlessly as possible. We should try and link different streams at the center and state level so that we are pooling them as well to be able to deliver those standard records. Today we have a Rashtriya Arogya Nidhi being implemented, we have PMJ, we have state schemes, and they're all fragmented. And the patient keeps running from pillar to post to figure out which scheme will I get money, what treatment can I get, how much can I get. All of that needs to be combined, converged, made into a comprehensive national cancer care. So that is
Absolutely. If the claims are being analyzed based on what protocol was followed, I think a lot of things can be standardized in my mind, right? Rather than just using which drug was used, which device was used. If the treatment protocol could have been, sort of reviewed, I'm sure a lot of things can happen there. Thank you for that, Lina. Appreciate it. Any answers for my last question? Which state is contributing the most? Uttar Pradesh, how much is that? Anybody? So about 10% of the national burden is coming from UP. I'm not sure if Mr. Ghosh or is any associate is here. We need to pass this on. The UP has to really look into how do we really pass it on. You're there, ma'am. Please, we need really. I myself belong to UP. I'm very worried about this data. Honestly, thank you. Thank you. Okay, it is indicating that the time is up almost. All right. Just last question from the panel, and then I make rapid fire for each panelist for 10 seconds. So, Sharal, I come to you. We keep talking about innovation in cancer care, right? Very critical. I mean, it can't happen that new drug will keep on coming in terms of whether it is a innovative molecule or whether it is a immunotherapy or whatever it is, right? Or even say technology, medical technology for that matter, right? Now, what happens is when you bring a newer therapy, the government is always asking for how do we contain the cost. The industry, if it is a global company, obviously they will bring it to India. They will need a ROI. If I'm an Indian company, if I innovate a technology, for me, India is a market before I start exporting. So I definitely need a ROI, right? So for us, for us, regulatory approval, regulatory predictability, pricing regulations in the country are critical. What policies do you think, in your mind, in your experience of public policy, Sharad, will really balance these two, where the government is saying cost contain the cost and industry really needs that ROI or regulatory predictability? Over to you, Sharad.
Thanks, Vibhav. This question is very clear. And since Vibhav was asking the audience a lot of trivia questions, I will also ask one. If you can just estimate your wildest guess, how much money does it take to bring one new cancer drug from preclinical to the market? Any idea? In dollars or in Indian rupees? Any guess? How much?
Not even close.
Think significantly more. So, without wasting a lot of time, 2.5 billion with a B US dollars for one drug. As Indians, it's very difficult for us to wrap our head around $1 million and $1 billion. So I did a quick calculation, but that's about 2 lakh crores of Indian rupees it takes to bring one new drug from preclinical to be ready to be administered to a patient. And guess what? 9 out of 10 drugs that enter preclinical do not make it to an approval. And guess what? 60-70% of the costs are already spent by the time you go into trials. So that is the cost of bringing a new therapy into the market. So let's be conscious about what it takes. Okay. Now let's talk about what does it take for us to find that middle path. And Monica made a very, very important point, and that's been my bugbear for a long time. This FISA of 1x GDP per quality, per quality adjusted life year. This cannot be a standard no matter which country you are. We apply the same 1x GDP per quality in India with a $2,800 GDP per capita, which Canada applies with a 50,000 GDP per capita. They cannot be the same. So most countries, many countries, and we did a white paper on this, they apply multipliers for a disease like cancer. Especially, let's say, if you are in a metastatic situation, you do not have, a very, very long life expectancy, but you can extend your life to a significant amount of time. Can you put an additional multiplier for these kinds of therapies? Right? So we've got to find those kinds of solutions within the HDF framework that make cost effectiveness more reasonable and logical. The last thing I will say is even at this current 5 lakh, which I think we definitely need to increase, this 5 lakh was set up when our GDP per capita was much less. We have grown a lot as a country. We should be proud of that. This needs to improve. But even within this, a lot is possible. A lot is possible. As companies, there are solutions that we can have, that we can kind of work with the government and say, fair enough, let's meet midway. You support us halfway, we will find a way to support a halfway. Let patients get access to the latest and greatest treatments. I can tell you it is possible, maybe not for all treatments, but for a large number of innovative therapies. There is a solution even today with the current resource constraints. And if you are able to grow this further, she spoke a lot about managed entry, pay for performance, differentiated pricing, social contracts. A lot of these innovations are available, which we can also apply. So, long story short, we need to increase the funding. There is no magic. We need to be more creative in how we are using the current available funding. Trust us as pharmaceutical companies, and Monica made a wonderful point. She's like, no company here is interested in keeping medicines away from patients. I mean, our business and our purpose both are aligned. More and more patients who can benefit from our drugs should be able to get them. These are the solutions that are very much possible.
Sounds good. Thank you, sir. Appreciate that. Panelists, I have, and I start that with Uttarayu, which is my rapid fire, is one policy or regulatory change that you want to do today if you are the Prime Minister of the country. One change which will increase the survival rate in India at least 2 times in next 5 years for cancer.
Maybe mandatory annual screening for most common cancers.
You said increase the screening?
Mandatory annual screening for most common cancers.
For most common cancer for all people?
All population.
Okay. Okay. Sounds good. Thank you. Hina, thoughts?
Maybe look at healthcare as an investment instead of a cost. To me, when we look at the budgets of the health ministry, we look at how much we are spending. We don't try to measure it in terms of how much will it lead us into future as a healthier population and what dividends will it serve.
So what is the change you're looking for?
Increase funding and look at healthcare as an investment.
Increase the GDP spent on health? Okay, sounds good. Sharad?
Pradhan Mantri Jan Arogya Yojana, the only program that can significantly move the needle in our country is PMJ. There are times when we were young and used to hope and wonder, aisa koi din aayega when we will have anything which is close to universal health. Absolutely. And we today have it. This program can change and double the life expectancy of cancer patients if we can be creative and progressive with how we include new age modern targeted therapy.
Super. Thank you, sir. Monica?
Since I'm the last, so I have the advantage
absolutely.
of more money than I has asked.
Yeah.
PNJY more strengthened.
Absolutely.
For me, it is about whether you're living in US or you're living in India or you're living in Australia.
you should get the same quality care, especially for cancer, irrespective of where you're born and what you earn. And that can only be probably happen if all this is done and you have regulatory approvals faster. If there's a drug discovered in US today, it should not take 10 years for it to come to India. So regulatory harmonization, expedited regulatory pathways, look at the same clinical data, give waivers where it's needed faster, and make sure the drug is launched at the same time in India when it's launched in the US and you have the best treatment there.
Super. Thank you so much, panelists. It was fantastic. I will not even attempt to summarize this panel. There were a lot of wisdom of nuggets which came out from each one of you. So thank you for your contributions. Truly appreciate it. Thank you, man. Can I have a big round of applause for the panel, please? Thank you. Appreciate it.
Very much, I now request Kamal Narayan Umar to please join us on stage, founder and CEO, IHW Council, to please join us to present the token of appreciation to our esteemed panelists. We will begin with Dr. Monica Puri to please step forward, Chief Commercial Officer, Roche Pharma, India. Please give it up for Dr. Monica Puri. Mr. Sharath Goswami, Senior Director, Global Policy and International Public Affairs, Pfizer, to please step forward. Kindly keep the applause going, ladies and gentlemen. Ms. Henna Dhawan, Head Country Public Affairs, Novartis, India. Thank you very much. Mr. Uttara Kumar, Senior Consultant, IHW Council. Kindly give the applause going. Our esteemed session moderator, Dr. Vaibhav Garg, President, Global Government Affairs, Merrill Group. Will now request our distinguished speakers to please step forward for a group photograph. Kindly come together for a group photograph. Thank you very much. Ladies and gentlemen, we'll now pause for a 30 minutes short lunch break as we are running behind schedule. So we seek your cooperation. Kindly join us at sharp 3 p.m. for our next session. Lunch is organized outside the hall. Thank you very much. Enjoy your lunch. We shall begin at sharp 3 p.m. We can do a little better. Dr. Sood is known for integrating clinical excellence with compassionate, patient-focused care delivery. Please join me in welcoming Mr. Prabhat Sinha, Director, Public and Government Affairs, Boehringer Ingelheim. Mr. Sinha brings deep expertise in public policy and access advocacy. We now welcome Dr. Ravi Mehrotra, founder CHIP Foundation. A leading public health advocate, Dr. Mehrotra has dedicated his work to tobacco control and cancer prevention. Can you please welcome him on stage? We also have with us Dr. Kapil Goyal, consultant medical oncology, Rajiv Gandhi Cancer Institute. Dr. Goyal focuses on evidence-based oncology care and patient-centered treatment pathways. And the session will be moderated by Mr. Srimanta Bhattacharya, Director, RS Associates. A seasoned public affairs professional, Mr. Bhattacharya brings strong experience in health policy and stakeholder engagement. Let's once again extend a very warm welcome to all our distinguished speakers, panelists who have graced the stage with their presence. Can we once again welcome them all together? Thank you very much. And I now hand over the session to the esteemed moderator for further proceedings.
Yeah, good afternoon. I think I welcome you all at the post-lunch panel discussion. Now, as you know, this probably is the most difficult session, as they always say. So hopefully, me and my panel will keep you nice and awake throughout the discussion. So we have a very esteemed panel, as you all heard just now. So the topic of discussion is ensuring equitable and patient-first cancer care. Now, there are two very important words here. One is equitable and the other one is patient-centric. So as we all know, equitable is to minimize or get rid of disparities in cancer care, and how pertinent that is in a country like India, which is as big and as diversified as we all know. And then putting patient at the center of decision making. So during the course of our discussion today, I will be asking questions, on which are connected to the central theme of the discussion. And we are fortunate to have a panel comprising of doctors, oncologists. They are at the heart of it. They're treating patients day in, day out. We have representatives from the industry. So they would bring the industry perspective into it. And then we have someone who has deep experience in the community side of the story. So someone who deals with the communities, with the patients, and has hand-to-hand experience of understanding their issues and challenges. So I'm sure you would appreciate the discussion that we are going to have. So to begin with, may I start with you, Dr. Sood? As you are treating your patients, on a day-to-day basis, according to you, where do the patients struggle most? Is it in the early part when they come for diagnosis, or during the treatment, or post-treatment follow-up part? Where you find the patients in Indian context, in your center, they tend to struggle more. If you can highlight on that.
So when it comes to the hurdles are unique at each step. I wouldn't say that a particular step is the one where there will be a more struggle. So since we're talking of equity, in terms of equity, the screening and the diagnostics is a hurdle because there are so many systemic disparities in the country. If you look at disparities also, rural-urban divide is the biggest challenge. I think all the oncologists we face because the screening programs, the penetration into the rural segment is still too low. Diagnostics, the ability to diagnose cancer in time and to stage it is also different in the rural and the urban scenario. So most of our population is in the rural countries. But our healthcare facilities are more polarized and more clustered towards the urban cities and the metropolitan. So the diagnostic element is also worse. So we see more people from the rural segment often coming to us in late stages compared to the ones in the urban cities. Although even in the urban, because of lack of awareness of disregard of symptoms, people do come late, but it is a portion of the rural which come more in the late stages.
Then for treatment, again, if somebody is situated in an urban city, in the metropolitan, the access is better. Since cancer treatments are long, they may take months. So the ability to comply with the treatment is more in these patients compared to the rural because on average, most patients, if you talk of radiation, it is said that an average cancer patient travels 4.5 hours to reach to a radiation facility. So the compliance to treatments is lesser in rural. And then relocating to a new city, losing livelihood, finding means to sustain that treatment. So there again is the challenge during course of treatment. So I would say during the entire journey, because of this rural urban divide, and then of course financial access is another very big pain point in our country where we are still seeing 46% out of pocket payments. So there again, our insurance penetration is not too widespread. We really need to find something, work on equity on that regard as well.
Yeah, true. So, I mean, she brought out the points which are very, very pertinent. So, the urban-rural divide that exists in cancer care. Now, Dr. Goel, if I take question forward to you also. So, you are also, seeing cancer patients, and that too in one of the centers probably has some of the highest patient load, in the entire country. If I take the names probably after Tata and one or two hospitals, yours would be the topmost one in terms of patient load. So the same question, if I put to you, you might be seeing a more diversified patient population there. So how do you address this? At what stage they face maximum challenges?
So maximum challenge, if you're talking about its struggle, could be defined by the financial burden, by the emotional trauma, the logistics, and all those. So I think the beginning, that diagnosis and finding a hospital, fixing a hospital, finding a clinician, and starting a treatment. So that is the phase in a family, not just the person, but the whole family. It's the maximum confused. They are in a shock already, emotional stress is there. And also they have to figure out the logistics, maybe relocating to a different city, like ma'am already said. We get plenty of our patients outside Delhi, lots of patients coming from Northeast, from extreme North, from Kashmir, from Punjab, Rajasthan, Bihar, everywhere. So many a time they have to take a temporary accommodation in Delhi for maybe up to a year or two. Outside AIMS also you will see that long queues are there, and there is a whole not tourism, medical economy going on around that because plenty of temporary patient, they settle in Delhi for a couple of months. So that is logistics. And it's not just that you have to pay for the rent, you also are not doing your job which you are doing. So that is also another. So that is the most challenging part. Once you have fixed up that treatment starts, that I think it's still somewhat better. But if the treatment somehow it does not go well and it does not have a good prognosis, then later the dying and death is the again very challenging. So the beginning in the end.
Long back, I remember first time when I visited Christian Medical College, Willow, and I saw so many Bengali patients there, and they have a complete ecosystem as you are referring to
So there is
outside the hospital.
every major hospital outside AIMS, outside Safdarjung Hospital, outside, I'm sure even Vedanta Gurgaon, even any major hospital which is catering to national or even international population. There's a whole economy, whole ecosystem. Right from the time they land at the airport or from the station, their food, their choice of food, particularly for the international patients. So now we have diverse specialized catering services to cater to those.
And it's an additional cost for
Additional cost for them and also so that kind of whole ecosystem economy is set up around us.
Yeah, Dr. Mehrotra, if I switch to you now, and you bring a very unique expertise here because you deal with the communities. You are involved in screening, you are involved in early detection, awareness, you are also involved in policy making and your contribution to that. So you have a very unique skill set here. Now, if I ask you, with your experience of working with the communities closely, what are the most critical barriers that you come across at a community level they have in terms of accessing, cancer diagnosis or care, whatever way you need
it? Thank you. That's a very relevant question. And unfortunately, it's a short question with a long answer. I hope you don't mind. Basically, the three things which I consider are the most important, especially when you talk about, as Madam has mentioned, not only the metros, the tier 2, tier 3 cities, and of course,
the rural India. Aside from the fact I've already mentioned about financial access, about physical distancing, and access obviously is limited because most of the tertiary care hospitals are in the metros. The main problem that I find is awareness of who to go as the first port of call. Quite often find that the first port of call is your neighborhood, mohalla, or uh, colony pharmacist, the small chemist shop, or the so-called general practitioners. Unfortunately, we do not really have more GPs in this country by and large. Very, very few MBBS doctors. Most are from alternate systems of medicine. And I'm sure all of you know many of them are from no system of medicine. They have acted as an assistant to a doctor in some place as a compounder or whatever. Now they have their own flourishing practice, quite often more than many DMs and MCH who are in the neighborhood. They belong to the community, they've been there for years, they can speak the same language far more fluently and have the confidence of the person. That person generally refers to the nearest hospital, or he may not, or she may not go to the hospital. Uh, and that is the biggest problem of people wasting, if not days, weeks, even months, when they try out all sorts of therapies. I'm not going to detail. We all know what therapies people try. And you may have a delay of up to 2 to 4 months, maybe more. So, patient navigation, right from the point of first protocol, is the biggest problem in our country. As you are probably aware, Tata Emergency Center has a scheme called the KWAT. KWAT is a patient navigator, person who takes you from one end of the river to the other. So the KWAT scheme, I was just speaking to the coordinator at DFC. They have trained 154 individuals. Initially, they gave, I think, a certificate, a diploma. Now it has been elevated to an MSc in patient navigation. But and they are now going all over the country, and a lot of government and not only private hospitals they will soon be trading. And they've also traded Indonesia in addition to India very recently, last month, last year. But the problem is how do you reach the kid? So that is where I think the role of a referral mechanism and patient dropout is more important. The second thing which I would like to highlight here is the role of social media. Are very, very popular and well-known influencers all over the place. Some very highly educated, some not at all educated, have a mass following in which quite often they themselves or their guests in their podcasts give completely wrong information. So it has been well said that if we, as doctors and scientists and so-called educated group, do not educate science or do not impart science, there will be others who will be taking your place. So misinformation, especially via reels in various social media channels and via WhatsApp, is the biggest source of problems right now. To give you a very small example, there was a reel which is going viral for quite some time that because cancer cells thrive on glucose, you should stop giving sugar to any person who has got a diagnosis of cancer. Unfortunately, life is not that simple. There's no black and white. The sugar is, of course, important, but that does not promote the of cancer, come what may. And there are umpteen number of things. So, misinformation and lack of awareness would be the two things. The third, of course, we already know is out-of-pocket expenditure and the fact that one has to leave a job or a daily wage salary. A very small example I'll give you how that can be overcome. There is a hospital in somewhere near Siliguri called Kachar Cancer Center, which is not that is in Tripura to be precise. I was speaking to the director there, and what they have done is a unique way. Because most of the people are from the lowest socioeconomic strata. Dr. Ravi Kannan, you might have heard about it. He's the director. So what he introduced was when the patient comes, and the caregiver, the uncle, the aunt, the wife, and siblings, they are given a temporary daily wage job in the same hospital, say cleaning or accounting or whatever. So their daily income is constant. So then they are able to stay for a week, or 15 days, or 1 month. You talked about the ecosystem. This is the ecosystem that they have created, which I personally feel in a smaller setup is something that can be replicated. Thank you so much.
So thanks, Dr. Mehrotra. And I think it's true that the initial navigation, it's a very big issue, and a lot of precious time is wasted till the time they actually end up reaching the cancer specialist or the cancer care center. Now we have two representatives from the industry. So we have Prabhat and Pratima, and I would start with you, Prabhat. So you are working very closely with government. You are dealing with them on a day-to-day basis in terms of policy shaping, market access. So, in your view, after you listen to the doctors and someone who has experience in dealing with the communities, so what, according to you, would be the biggest policy shift at a government level, which could, bring in some level of equity and minimize the disparity that exists in the cancer care. Even Dr. Sood also talked about the disparity between tier one to tier two, tier three cities. So yeah, if you can just throw some light into that.
Thank you. First of all, I think equity is a word we use very loosely, right? I don't know whether equity exists or not, right? It's we discuss equity. I myself, as a caregiver, almost 10 years back to my mother-in-law, felt that equity was not there. It was unaffordable for me to kind of afford a treatment which is a norm now, right? So equity does it exist? I think no, because we are not only representing industry or our departments, but as a human being, we know that whether equity exists or not, it doesn't. Now, it's the PIN code or zip code actually in our country decides about your survival. And for example, Dr. Hemant Malhotra sir is sitting here. Somebody in Rajasthan who gets an advanced stage 4 breast cancer compared to my own state, Jharkhand, the chances of survival is very different because the kind of treatment Rajasthan government provides under its insurance program to patient is probably doesn't exist in many part of the state. So it's a you are fortunate, unfortunate where you are born. If you are born where you are a ESIC beneficiary, if you are born where somebody is a part of CGHS, railway, you are lucky. But if you don't have any such insurance, if you have a private insurance, in private insurance we struggle with the issue of exclusion, whereas in PMJY inclusion is an issue. In PMJY targeted therapies are not there, but in CGHS, ESIC, railway, all the good therapies are there. Where is the inclusion? As a citizen of this country, am I not entitled to get what is a norm? Even the National Cancer Grid, there are treatment which says optimal, optional, and essential. Does the essential and optimal treatments are part of PMJY package as of now? No. Yes, we know that it's a journey. Things will come in future, but till the time it is coming, a lot of people are losing life. Right. So in private insurance, if targeted therapy, if you're not hospitalized, though in a hospital, then you are not entitled to get a targeted therapy. So again, there is a battle. Now, somebody who is battling with a disease like cancer, he or she individually, whether he will spend time at fighting with the insurer or managing their own lives. Right. So to me, I think we are much, and it starts as doctors were saying that, at every level, access somebody, for example, again, I'll go back to my own state, gets even a symptom of cancer, will not even go to Varanasi, will come to Mumbai. And then all the magic starts. We'll go to Vellore, which is a very natural path from eastern part of India. Why? Because it's the infrastructure doesn't exist. So from access to diagnostic, treatment, everything, equity is at every level, which I think is just on word. I think and a lot has to be done. The previous panel has talked on how to do it. I'm not going to repeat that, but I think we are far away from equity. What exists is for selecting, not for ability.
True. And now, if I take this to you, Fatima, now, one, see, there are broadly three pillars to the biopharmaceuticals business. So Mike is looking three pillars, as we know, in the biopharmaceutical business for oncology. So Innovation is one of the pillars. Then you have market access. And then the issue comes how you can combine the both and come with a sustainable business model. So as we heard in the last panel discussion, also they were talking about the billion-dollar cost that you incur in developing a breakthrough product. And then when you consider a moderate to low resource country like India, and you apply the principles of patient centricity. So how would you combine all and still remain patient centric? And you justify your innovation, its cost, and then achieving, at least optimal level of market access.
To start with, I think it's a complex equation, something which reminds me of the 12th standard integration and derivatives. Let's start with innovation. And speaking of innovation in cancers, let's look at most prevalent cancers in India. Do we really have targeted therapies for the most prevalent ones? Breast cancer, I would say yes. But would we say the same for oral cancer? Would we say the same for head and neck cancers? Some, not all. A big question for the industry to go back and look at a neighboring country called China, where innovation is happening primarily considering the incidence and the epidemiology of disease within the country. And no wonder then that some of the biggest innovations, some of the most pathbreaking innovations now coming in from China. And in less than a decade from now, the industry will see a whole storm of product coming from China. So I think to review what is it that we need as a country, and then look at innovation that addresses the need of the country, need of the hour, would be definitely a matter to look at. You spoke also about access. I think access, I would define access as the availability of the right treatment for every person who's eligible. Can every patient who's a HER2 positive patient receive the right targeted therapy is a question that runs in my mind. And I think that's where industry could probably cover some more distance in a country like India. And being part of Roche earlier, where one of the key considerations always is India's contribution to global business is less than 1%. I think anyone who's worked with any company that operates out of India would look at it this way. And then by default, the priority sequence tends to put you down. And with that kind of priority, when you start pushing for a price, being an Indian, and you said being a human, clearly correlate, having lost a few family members to cancer, there's a lot of resonance within saying if this was to happen to someone in the family, would they be able to afford the same drug that I'm marketing? And I think that's what shakes us up. So while we look like the culprits, we also humans and we also go through a lot of this emotional churn where we try and bring the best possible access to patients. And I think I'm also representing the industry when I say this. A lot of us really have the patient in mind, where the idea is to also push our respective organizations because people sitting in various parts of Europe, US, will probably be looking at a very different ecosystem, most of which is reimbursed in a country that pays almost half of it pays out of pocket for healthcare, right? And I think almost each one of us touched on this. The key challenge is number one, diagnosis. Number two, getting the patient on the right treatment. And number three is patient abandonment. The patients are dropping off. How many patients are able to adhere and complete their therapy? That's a big question to answer. How can industry step in? I think for those of us here, well, the big question from the industry is to ask, can margins be looked at considering volumes? We do not, we are a LMIC country, right? No medium income country. Can our volumes make up for the margins? And therefore, can innovators look at lower margins considering the high volumes? I think that's the simplest answer to the equation that comes to my mind. And to your third question, I think what can companies do? Essentially, you would remember the Gilead example of voluntary licensing to multiple companies, right? This was in the gastroenterology space, but excellent example of how companies can really scale up and enhance their access to patients. So when we speak of market access, which market are we trying to access?
Soft area.
Absolutely. I was trying to recollect the molecule names. Which market are we trying to access? The 5% that can pay lakhs of rupees or the larger chunk of patients who probably would benefit from a therapy that's available for a lakh rupees or more. I think these are three responses I'm
Just to probe you a little further, you made a very important point that one thing is the lack of knowledge that exists in the global headquarters of some of these multinationals. And the second is the acknowledgement and true appreciation of the magnitude of the problem. So are you seeing any change in the last decade or so in terms of their overall, recognition of the issue and then a genuine desire to do something to address that?
Thank you. You asked me a question which is very close to my heart. In the recent past, and I have a colleague who will validate what I'm sharing. We've trying to push this across to the global headquarters, and it looked like theory. Another affiliate pushing for lower prices to scale up volumes. What we did do was a no-brainer actually, but I would encourage more colleagues to do that. We got our global headquarter colleagues to India, took them to a Tata, also took them to some of the good private setups in the other parts of the country, but we took them to a Tata. Walking through those gateways, I mean, you know what it is like, right? You cannot come out untouched. I think that experience was life changing for each of the leadership members who walked through the Tata staircases, took them through stairs, so they actually get a flavor of Tata. And I think that changes. That changes you. That changes the way you look at India, because otherwise there are the stories of the snake charmers and the cows on the road. I'm sorry, I mean, but this is how cliche it is. And as an Indian, it shakes me up to think that people are talking about the 1920s and 1930s, then India is among the fastest growing GDPs in the world. So I think proof of today is seeing, getting people to see what this ecosystem is, the kind of clinicians India harbors within its various oncology centers is immense. And I think driving the value of who we are, what we stand for, along with as a country, what our needs are, is super important. So how do we get people closer to the ecosystem, make them experience, and then let them resonate with what our needs are? Could probably be one way.
Now, again, I would come back to you, Dr. Ravi, and and then I will come to the two oncologists that we have here. From your end, if you can just educate all of us. See, we all understand that if there is one disease where early detection can actually make a huge difference in the overall outcome, that is oncology. In most cancers, early detection plays a massively important. Now, based on your experience of dealing with the community, now, what is your take on that? That are you seeing any improvement in terms of early detection of some of the cancers? Some initiatives that might have made a some level of difference in early detection of cancer patients, because you carry out a lot of such exercises also through your own setup.
Yeah, thank you so much. We at the Chip Foundation have been very lucky to be working with all the states, the 26 states and the union territories of the country, looking at capacity building for early diagnosis, prevention, of course. And as you said, early diagnosis is, as the cliche goes, anything that has well begun is half done. So, a few cancers, which are among the top three in our country, come to mind immediately. Number one, of course, is oral cancer. Usually 90% and more due to tobacco chewing. One in three oral cancers is tobacco chewing. And that is smokeless tobacco or non-combustible tobacco is the number one cause. And we have the, I think, the largest number of people who take that, especially lip cancer, as you know, because most people immediately point at the lip if something is wrong, as compared to cancer of the posterior oral cavity. This is the world difference. One has an 80% survival, other is actually not more than 30%. That too, if you are treated well, it doesn't happen all the time. The second one is, of course, breast cancer, um, where we, as a government, when I was in the government, and many colleagues, of course, are responsible, and private sector, of course, because so many celebrities, especially film stars, uh, cricketers, and various other people have come out in the open and talked about breast cancer awareness, the pink ribbon in October, and so on and so forth. That has made a huge difference. Uh, my colleagues at the Royal Institute of Medical Sciences, who we started this whole journey about 10 to 15 years ago, maybe even earlier, tell me that the number of individuals, this is Delhi, I'm not talking about the entire country, it's going to be very, very centric to the metros. especially Delhi, because we have been very active, and Bombay has been very active in nearly all the urban centers. The number of people are seen in state one and two have done course. I don't know the figures, but suppose they were 5% earning, they want 10, they were 10, they want 20, which is a huge difference. And that is in the absence of any organized mammography screening in the country. The way the government has been propagating, and some centers in the private schools, yeah, mammography, but mainly the government will looking at clinical breast examination, CBE, which is about 1 centimeter and more. That already is fairly large. But of course, in the about roughly 5%, 10% individuals have family history, and they, if they are lucky and they are aware, they will go for a screening mammography every year. But the vast majority of individuals in this country do not have access to mammography, but they cannot afford it. So these are the two areas I have felt, and even in my lifetime, in the last say 20, 30 years, I've been involved with oncology in early diagnosis. It has made a difference. One could argue that only about 60% of cancers, although 60% is a huge number, are preventable. But in those that are preventable, if we catch them early in certain situations, we actually can do wonders. The second input I would like to talk about, which is slightly different from what your question was, is survivorship. Once you finish your treatment, you are normally patient is let off a cliff. अब आप ठीक हो गए हैं कीमोथेरेपी रेडियोथेरेपी हो गई आप जाइए घर they're not given any instructions. There is no navigator to tell what will come next. If you have breast cancer and lymph node removal, then you have lymphedema. It can be very painful. You don't know how to handle this. Now, fortunately, there are support groups which are helping, but again, restricted to the major sectors. Similarly, the sword is always hanging over your head. He, the cancer may recur. What are what are the biomarkers? How often you should go? First year or 6 months, they will go to their physician or surgeon, and that's the end of the story. But the scare is always there. And the third thing is stigma from caregivers. If there's a child, for example, who's been treated for leukemia or lymphoma, he loses 1 year of his or her life, lands up in school, is already behind his batchmates, and parents of his classmates may not allow him or her to play. We realize these are the kind of problems, aside from financial toxicity and various other stigma that are there. So I think when you go in the community, you see these kind of issues. They are far improved from what they used to be even 10 years ago. And that's where I feel oncology community has been effective, but a lot more is left.
True. Now, if I come to you, Dr. Cohen, on so the same question I would ask to you also, Dr. Sood. Now, you are at the heart of it. We are discussing patient centricity, and no one deals with patients the way both of you are handling, and the other oncologist sitting here. Now, in a real world hospital setting, we are not questioning the intention. Without questioning the intention of the treating oncologist or the hospital, there are practical challenges that you face in the hospital setting to ensure optimal patient centric care and ensure equitable care also. So, if you can bring some of those aspects and help us understand them.
So biggest challenge when patient come to us is the reimbursement issue. So patient may come from different categories. They may be completely out of pocket expense, could be private insurance, could be government insurance. So as someone already mentioned beautifully, the government insurance are CGHS, DGHS, ESI. So those patients have better access to every kind of therapy that is available. Unfortunately, the PMJY has very basic medicines only available with them. Most of the targeted therapy, human therapies are not accessible to them. So the clinical outcome of that patient may actually be inferior to our patient. And for patient who is being out of the pocket, of course, depending how deep the pocket is. So the treatment outcomes may vary because they are the immunotherapy which have given tremendous results in stage 4 cancer. So they may not be accessible to most of the patient. As a data, only 7 to 10% of Indian patients actually get immunotherapy. 100 patients should get 7 or 10 out of 10 get. So that is the kind of deficit we have there. Second challenge is the location where the patient is coming from. So, for example, because this chemotherapy as well as the radiation therapy, the long procedure, the treatment may go on for 6 months to 1 year.
So if patient comes from a nearby 50 kilometer, 100 kilometer area, then it may be easier for them. Whereas somebody traveling 1,000 kilometer, 2,000 kilometers, then it may be a challenge to deliver the same quality of treatment to them. So what we have done is that we have done a process where we sort of a peripheral network has to be there, which we are also trying to develop. So referral is not just from periphery to center. It is also once that diagnosis is made, the treatment protocol is done, another referral has to be done from center towards the periphery. We give them the protocol, we tell the protocols, 8 cycles of such and such chemotherapy have to be done. Now you can go to your state. Government is also opening up in every state. There's something called a district cancer hospital or state cancer wing. So there you can go and you can get the exact same treatment done. And you can review with us after 5 months, 6 months. So that kind of from center to periphery. So that is the need of the hour. India being such a large country and only you can literally count on your fingertips number of good hospitals. So if everybody takes full treatment in those two, that's actually not possible. So the need of the hour is from center towards the periphery. The accessibility of cancer treatment near there, wherever in every district, there should be one chemotherapy district cancer center which can act as at least a chemotherapy center. Even if the specialty for making a protocol is not there, at least they can deliver the treatment. The protocol is made from that high volume center.
True. I remember maybe last year's budget only had some announcement that they want to set up cancer units in every district hospital. Now, if I bring this question to you, Dr. Sood, based on your experience, so we understand the external challenges, distance that they cover, district hospitals, what Dr. Roy also pointed out. Now, within the hospital, what holds you back from delivering the optimal patient-centric care that you believe cancer patients they deserve?
So I think patient centricity is not a desire, it is your moral compass. You have to do it. The processes in the hospitals are also enabling to you. You see, major hospitals now are having processes towards patient safety, infection control, and a lot of things related to quality which are patient centric. So the fulcrum is the patient centricity by all means. But when it comes to creating a plan of care where you are taking into account the patient's affordability and other issues, I think it is very clear, at least in organizations like mine, where Dr. Shetty has given us one principle. A solution is not a solution if it is not affordable. So the bearing is on me. It is my choice that how I, force the estimates to him rather than, based on his ability to treat. Because you need to do the best. Once a patient has entered the doors of my hospital, he deserves to get the treatment as any other patient. So customization of plans as per patient's affordability it should be at the liberty of the doctor. I think that is something one should push in the bigger corporates so that you are able to offer the best to each patient whosoever comes. Second thing, I think very beautifully said that decentralize the treatment. Most hospitals have multiple hospital chains, so you can have that hub and spoke model where you have big high-end machines which are capable of doing the extreme high-end precision radiation at the metropolitan cities and the lower energy LINACs which are capable or competent of doing 90% of treatments can be kept in the second tier and third tier city. So that will again take care of those more tangible logistic expenditures of the patients we talked about in the entire pan. So these are few things which can be done, but patient centricity elements are too many. We talked about the emotional component. There is the survivorship issue. So we have to integrate them. So it is not just the doctor. It is the availability of psycho-oncologists, availability of social workers also, which needs to be integrated into the system to prevent the fallouts. The compliances can be enabled better if you have a team which is comprehensive with team members beyond the medical profession, because we are more into treatment, more into prescriptions treatments, but the allied efforts from other ends can, increase the acceptance of treatment in the patient as well.
Are you seeing that happening more and more now? What you said that the cross-functional team, they all should be involved.
So that is the essence of today's practice. If you see any of the hospital in our city nowadays, it is the MDT approach. Each patient gets a plan of care which is vetted by all the stakeholders. It is not that if I am a radiation oncologist, the treatment would be dictated by me. It would be the team which would decide that this is the personalized treatment which would be the best for this patient, and that would be put forth. And I think most hospitals are now recognizing
the role of psycho-oncology right at the beginning, because breaking the news, acceptance of diagnosis, bearing the diagnosis, and even later on, when there is a grieving family, there is a support which needs to be offered. So it cannot be just the treatment. It is not about the tumor, it's about the patient, it is about the family. So that is how patient-centric treatment is now beginning to grow in most of the centers in the cities. But again, I think this amount of effort or this amount of coalition or collaboration or interdisciplinary approach is a far-fetched dream for our city.
Yeah, I will come to that urban-rural divide in oncology care little later. Now, if I come to you, Prabhat, at this point, see again, if you look back, there have been multiple government policies, schemes that have been introduced, and not in the oncology space as well. So, according to you, if you critically analyze them, what are the major gaps, which doesn't actually lead to the desired outcome that some of those schemes or policies should have translated to? But so, how would you assess that?
So I think we have heard PPP quite number of times. I believe it's not the normal public-private partnership. It's the physician, policymaker, and patients. Is our policies are made consulting these three together. Most often, one of them is missing, and especially patients. So when we think about a policy, let's say Ayushman Bharat, we had a lot of discussion. Right? A patient Ayushman Bharat program came with an intent to reduce the out-of-pocket expense. Right now, a patient has to come for a chemotherapy, let's say from Nasik to Mumbai. The amount that patient spends on his travel, though he may get free chemotherapy at hospital, but imagine, think of the cost that the patient will spend in commute, stay, and everything. Right? Is it as Dr. Sood was saying that it is a patient-centric policy that my out-of-pocket is not reducing with this policy? But is there enough opportunity for patient organizations? Many of them are sitting here who have been respectfully engaged in the policy discussion. If it happens, these are the genuine problem. It's a insurance money. Somebody is paying for the insurance for that Ayushman Bharat patient. So for a patient, it's the targeted therapy which is important, maybe, but is not getting it. Some initiative happens. Even 2 days back, we heard that custom duty exemption on few drugs. These are costlier drugs. 10% reduction, is it enough? Yes, it's a one step, but I think we need transformational step when it comes to policy. And as even in fact, the previous session was talking, currently we have one of the bigger programs is Ayushman Bharat. And that program has an ability to make things better with little bit of tweak, whether it's the amount that has to go up, whether the new drugs gets included, what is already part of the national cancer grid, optimal, essential, optional, whatever it is. But unless, as I said, I started saying that that equity is there, and that equity, who will demand for that equity? The equity demand will come only from people who are actually battling with it. But do we vacate our chair for them? Most of the time, no. I think today's, and Kamalji, I want to congratulate wherever you are. I think today, I think one of the such seminar where maximum number of patient advocates we will be hearing who are here. And I think the organizers need really a clap for them, because they have invited, included them in most of the panels, which is not a normal thing that we see in many of the congresses. Yeah, true.
Thanks. Yeah. So, Pratima, if I ask you the same question, and if you can bring out some of the examples that you might have seen where industry worked very closely with government and made something happen at the ground level, which impacted the health outcome of cancer patients. Would you like to throw some light?
I'll probably split this in two parts. One is the industry working with the government, and the second is what industry by itself has achieved, because both are great examples. I think the GPAC program, and I'm sure I have colleagues from Novartis will vouch for this. I had just started my career, and upon a visit to GCRI, I saw a huge GPAC counter, and upon inquiring, learned about the program. Much later, I learned that this program has benefited close to, and I think the Novartis team will probably validate the actual numbers. The the in-press numbers are 500,000 plus patients across LMIC countries who benefited from end to end. So no treatment abandonment was one of the key endpoints which the GPAP program has achieved. No such program ever heard of in the industry so far, and about 1.5 lakh patients from India itself will be treated through this program. Pan-India reach, lower and middle income families are the ones that benefited the most. So clearly, I think I was hearing the clinicians on the stage and was thinking what are the programs that could really impact that group who probably will never be able to afford innovation. This is a program that clearly touched those lives and transformed them for better. The second example I want to use here is that of Roche, close to around, I think, 20 odd years back. The HER2 testing on a mass scale was initiated by Roche. I think I mean, today, the reason why we get to see that breast cancer is the most prevalent cancer in women in the country is thanks to industry. I'm sorry that, I may be vouching a little too much, but it's a fact. I was a part of the company when the HER2 testing was given out left, right, and center across from north to south and east to west without questions. I think initiatives like those would probably be bullshit.
Correct. Now, if I come to you now, Dr. Sood, now, see, in India, we say that every 100 kilometers, the language changes, the culture changes. And at the end, patients are also a reflection of what we are as a country. Now, you sit in Delhi and you treat cancer patients where patients are coming from all parts of the country. And as we often say, that empathy, counseling, communication with the patient, they are such an integral part of patient-centric care. So, as a treating physician, how you can handle that in a diversified ecosystem what we have in our country?
So definitely, you see a diverse population, but fortunately, organizations are also diverse. Most of our teammates also belong from different cultural backgrounds. So rare of the rare, it is very very rare that sometimes you have a patient whose communication is requiring a translator, who could be anybody who's been assigned from the hospital or it is from your own unit. But mostly, I think most of us are very well versed with the common languages of our country. Me, myself, I'm very well conversant in 4 5 languages. And these are some things which matter because patient wants to hear his or her own language. So a simplified discussion with a shared decision making is what is actually improving the patient's ability to make decisions. So mostly it is the person's vernacular which is used. Very rarely the struggle does come, and fortunately, each hospital has a set of translators which have been designated for particular languages which might come to your clinic. So that happens rarely, but mostly it is easy to engage. Indian community patients are very open. Sometimes, if the mother is not speaking a particular language, I get a patient who speaks Methli, and I'll tell you over the last 2 years, even I have picked up so much of Methli from her. Her son deciphers everything, and we are able to communicate. So fortunately, the family steps in when such circumstances arise, but there are designated translators at most hospitals.
Yeah, because that's I mean, at the end, how much patient education material you give to a patient. The patient would love to hear from the doctor.
So I'll just share it, although it doesn't, is in context to this. So during COVID times, we did a lot of digital awareness programs. So I remember when we started initially, and our entire dialogue used to be in English. And when you read the comments, usually you should not read the comments. Sometimes they're very scary, and you start thinking, what did I do? So the people mentioned, हम अमेरिका में नहीं बैठे हैं, हिंदी में बात करेंगे. So that is time, it tells you that, if you are creating awareness and it is not of the patient's language, it is too much technical, then it is of no point doing those awareness programs. So it has to be in the patient's vernacular, it has to be understandable. And there, digital health can work. We created I did a program from IIM Bangalore, and my capstone project was on patient education. So there I created a lot of videos and how we can hack QR codes, and then these can be sent to everybody uses a smartphone. So that when they come to your clinic, they already have a feel of what is going on with them, child radiation planning, care, whatever it is, in their own language. So there are means, I think our country is now pretty competent with digital, innovations in there where you can build into programs which are in patients well active.
Great.
And AI is a big tool now to help.
If I take this to you, Dr. Goel, now you come from a setup. Let's see, it's very easy to say doctors should spend more time explaining the things, disease area, treatment, but you have 100 patients waiting outside in a kind of setup that you come from. And there are few centers like yours where the patient load would be 2x, 3x compared to other centers. And then there would always be that paucity of time that you can give to individual patients. So how would you ensure? And there, what digital and what Dr. Sood was pointing out.
Absolutely. So there are multiple attempts from our side to counteract this problem. So one is it's a teamwork. So it's within a different unit. There is one senior doctor, junior doctor, a team of assistant doctor. Then we have nursing assistants, we have counselors. So once the patient is done meeting with the doctor who will decide the treatment plan and everything, so maybe a junior doctor who will explain about the side effects, the profile. Then there will be a nursing counselor. When the patient is admitted in the daycare or in the ward, then they will come, they will tell about the red flags and patient has to take care of. A dietitian will tell them about the diet. And then lots of digital material. So I think the hospital also, and as individual doctors also, we post lots of content on our social media. It's easily available on Instagram or Facebook or WhatsApp. So rather than going in the random Google history, Google searches, patient can actually read the official authentic material, not from just our hospital website, from many other websites. So digital. Then we have ready-made pamphlets available, like chemo code. So we just give a pamphlet. So, okay, so this is how you take care of a chemo code, a diet. Look, this is a template for surgery. So surgical care, what you have to take care. So a lot of printed material. So most of the material is in both the languages. It's in English and in Hindi that we do. If particular anything else is required, then also that can be translated. But majorly all that kind of material. So the digital material, printed material, and the teamwork. So that is only the
Okay. Okay. Now, Pratima, if I come to you now you also pointed out, and other panelists also, and throughout the day we are hearing the disparity between metro, tier one, and the smaller cities. Right. And as we know that we are a fast urbanizing country, but still large part of India, they are still living in the rural part of the part of our country. So, are you seeing any perceptible, significant change, first of all, in terms of equitable cancer care, metro compared to the tier one, tier two cities, or even in lower down the ladder? And if no, then what kind of interventions might help in creating a sense of balance there?
I think this is a very pertinent question. While the signs are beginning to show up, we start to see some multi-speciality big hospitals, some cancer specialist hospitals in tier two cities as well. I believe we have a long way to go, given that a large chunk of our population sits out of tier two and tier three cities. Some of these steps could possibly be around simplifying access to health and simplifying access to better cancer care. Personally, if you were to ask me, I would look at Ayushman Bharat. Ayushman Bharat, besides what the government is doing, if industry or there are definitely other avenues which could bridge the access to Ayushman Bharat, because all of these approvals take their own sweet time before the patient can get onto therapy. And in some aggressive cases, some aggressive diseases, patients cannot wait. So definitely that could be one. I think a point which was discussed was also around private insurance. Again, a large part of the population who is covered under private insurance suffers from the ailment which is inadequate funds or inadequate coverage. A lot of drugs, even today, are not covered. One part of it is getting IRDI into the picture and getting the coverage, but the second part, which industry specifically could definitely be in the form of patient support, which could help to bridge access to therapy. These are few. A third one which comes to the mind is in the form of simple compliance packs. So if a 30s or a 60s pack is not affordable in one go, can this be broken into 10s? Make in India, the government has been speaking about it for the last 15, 20 years. If Make in India is a resort that a lot of companies resort to, would that bring down the cost of therapy? Would that make drugs more accessible to Indian patients, especially in tier 2 and tier 3? Are some of the thoughts. The last one that I want to leave here is a lot of innovation happens currently in western parts of the world which haven't seen 45, 50 degrees of temperature.
which a Jaipur sees, which a Agra sees. So ensuring that these products are stable under these temperature conditions also will play a very important role. A lot of the fear that we operate from as pharma industry is what if the cold chain was to place? What if the room temperature wasn't ambient? The drug would no longer be effective. I think these are some interventions which
Terrific. Now, Dr. Mehrotra, I mean, based on your experience of working at the community level, so if you would like to recommend some initiative, something that really worked at the grassroots level, which deserves a kind of a national scale up. So would you like to comment, something that can be taken up at a much larger level and make a big impact?
Well, let me twist the question a little bit. I mentioned a little earlier about the KPIT, the navigated program at DMC. That I personally feel, if I were to take just one simple, relatively inexpensive, and eminently replicable. I was just talking to the coordinator at TMC for the program as well, and she mentioned that in Indonesia, in the last 2 years, they're training for 20 people, and the government has made a plan that all cancer centers, private and government, have to have a navigator. So that is in principle not only true for cancer, it is true for tuberculosis. I mean, in spite of all our claim that eradicate tuberculosis by 2024, if we are nowhere near. Can happen for even cardiovascular. Can you imagine? You belong to a small village in Jharkhand from my friend Prabhas neighborhood. He or she comes to Willow. You talked about CHA Willow, talked about Ames, talked about Tata. The huge panoply. First, how to see a doctor in the first place, how to take an online appointment. I don't have a smartphone. I give 100 rupees or 500 rupees to somebody to book an appointment. That's again close. Land up there from morning 4 o'clock. You are sitting there. Finally, for 5 in the evening, if you are lucky, you get to meet a doctor for 2 minutes. It doesn't really examine you, or even if he or she does examine, rest of the people are just so careless, unfortunately. And then you have to get a CT scan, a pathology, get a biopsy, or FNA, whatever. It is a mind boggling, and that is why the number of doubts in all the government hospitals is increasing day by day. I believe there was somebody at AIMS Delhi who had been practicing as a facilitator or a navigator for 10 to 20 years, making huge amounts. So that is a very pathetic state. So navigation, if you look at one point of view, if the government doesn't have to spend a huge amount of money, that is one thing I feel from and replicate it to all hospitals. And for my friends who work in the corporate sector, we actually suggested to this individual that to train people, charge money, that they did this study in which they found that within 1 year, the people dropping out of Medicaid of the health system had gone up by 47%. So in fact, practically half the people were actually retained because, and they could also navigate to insurers. So Ayushman Bharat. That again is a very, very difficult situation. I'm fully in consonance with my friend here. And Pratima talked about how Ayushman Bharat, in spite of all the problems, is still one of the stars that we have. So how do we reach Ayushman Bharat? When I was at BCM, we actually had a website. I believe it's still on called India Against Cancer. You're most welcome to have a look at it. But you were a part of the advisory at that point. And where one of the most, the page that was hit the maximum was how to get funding. What are the tertiary care centers of the government? How do you go there? Their website, who is the person to contact? That has the 100 hits, everything else had 10 hits in a day or whatever. And it was referred to by the press, referred to by social media. But that is what we want. So awareness and navigation. These are the two things which I feel can be a game changer.
So just to add something here, since we were talking about the navigators, we at Narayana have also brought in a concept of care companions. So where the patient's caregiver, the primary attendants, are trained for basic procedures for which they will not come to the hospital again and again. Basic dressing, spectine management, colostomy care. So you are educating the relatively well-educated attendant, or if it is not an educated one, uneducated, to basic procedures, which bring down their cost of repeatedly traveling to the hospital.
paying for those procedures again and again. So that concept has also customized the cost for the patients when they are to attend the hospital for long-term care.
So, last question to you, Prabhat, of today's discussion. Actually, two questions combined. The same that I asked to Pratima, that you being someone representing an innovator company, and if you have to make innovative products more accessible in tier two, tier three cities, deep down the road in a country like India, what are those one or two interventions that would be really critical? And second part is that, in your view, what is the best way industry and government can really work together and make things happen? I mean, you have highlighted some of the issues, but at the end, you all need to work together. So, what are those one or two areas that, from industry side, you can collaborate more effectively and make a difference?
So I think a very important question. The first I'll answer the second one because so see the purpose of industry and government remains the same. For an innovator company is to ensure that the innovation reaches to people. Same thing, government also wants better outcome for patients who are under any kind of disease or treatment. And there are common interests for both, right? As I think Pratimaji was saying that, the volume is a big thing. Everybody looks at India because of the volume. Now, unfortunately, we have not been able to show that volume to our global counterparts that yes, we can support more and more patients. And that's why I think Dr. Monica, when in the previous session was talking about, there are various other access models which are in operation in our neighboring countries. It is not that it is not. It is happening somewhere. It's outcome based. The differential pricing. There are many such models that do exist, but we are still, as a country, is living in that era where the L1 is the norm, where life is not L1, it's Q1. So for Q1, we are going for L1. That is a practice. We are not moving away from that. There has been a lot of discussion, debate around it, but I think this is an area where I think a kind of a partnership that is required between not only innovator companies, also I think with Indian manufacturers. It is not, see, issue is not drug. Even the cheapest drug doesn't reach us to the people. Leave around oncology drug. So I think the partnership is required at all levels. The starting from, see, our community health, the public health system, it has to start from there. Now, if a partnership is happening, and I think all of us as our organization, we have a lot of materials for education and so on. But most of the time, it only restricts to few clinics where we operate. Whereas if you go to a district hospital, you may not find anything there. These are the areas where, I always say that logo and ego, we have to keep this aside. Once we work together, I think there is a lot can be done even with existing things. We don't have to recreate. There are pockets of excellence in our country. Can we work together to replicate what is happening in Telangana or Kerala? Can it happen in Bihar, Jharkhand, and Odisha? So there are models. We are a country where there are super models are operating in pockets, but unfortunately, that is not replicating. And I think that is where industry can jump in, work with government, bring other players, and ensure that the same model gets replicated in the other. We don't need to recreate something new. Second, as an individual each of the company, a lot is happening from patient support programs, right? The price at which the drugs are being launched in India is much different how it is outside. And also for people who are not part of insurance, I think every company have patient assistance program where patients they try to subsidize the treatment to a lesser cost, and not only the drug cost. There are navigators. There are a lot of companies who also provide navigator to support patients on their journey, diagnostics. So there are more such programs there. It is still less because the country is so big. Unfortunately, these programs are restricted to self-paid patients. So I think there are enough true partnership that is required, but that also calls for that openness to sit and find a solution. Otherwise, from like we may all industry will keep saying that this is possible. Government in their own meeting says this is possible, but are we really meeting together and finding a solution one step at a time? That is where I think is the way forward.
Excellent. So with this, we come to the end of the discussion. So thank you very much to all of you for sharing your views, and thanks to the audience. So thank you.
stimulating discussion. And over to please join us on stage, founder and CEO IHW Council, for the presentation of token of appreciation. We'll begin with Ms. Pratima Tripathi to please step forward, Commercial Director, Oncology, Servier, India. Please put your hands together, ladies and gentlemen. Let's all together thank the panelists for sharing their key insights and expertise with us. We'll now present a memento to Dr. Kanika Sood, Clinical Lead and Director, Dharmshila Narayana Hospital. Kindly keep the applause going. I would request Mr. Patil to please stay back as we have a group photograph towards the end of the memento ceremony. Dr. Kanika Sood, please give it up for Dr. Kanika. Mr. Prabhat Sinha, Director of Public and Government Affairs, Boehringer Eagleheim. Kindly keep the applause going. It's our opportunity to thank our speakers for sparing their valuable time for us. Dr. Ravi Mehrotra, founder CHIP Foundation. Thank you very much. Dr. Kapil Goyal, consultant, medical oncology, Rajiv Gandhi Cancer Institute. Please put your hands together for Dr. Goyal. Now, session moderator, Mr. Srimanta Bhattacharya, Director, RS Associates. We will now request our distinguished speakers to please come forward, come together for a group photograph. Thank you very much for joining us for this session. Ladies and gentlemen, we'll now begin the next session, which is on digital transformation in oncology. We'll begin in next 30 seconds. We'll quickly prepare our stage for the same. So we would request you all to kindly remain seated and please continue to keep your phones in silent mode. Our upcoming session will focus on digital health tools, AI-driven insights, and tele-oncology platforms that are shaping how cancer care is delivered and accessed. This session will also explore how data-driven decision-making, remote care models, and digital integration can improve reach, efficiency, continuity to care, and clinical outcomes while ensuring technology remains ethical, inclusive, and patient-centric. And our stage is all set. Please join me in welcoming on stage Dr. S. Huku, Advisor, Radiation Oncology, Sir Gangaram Hospital. Can we all please welcome Dr. Huku on stage? Welcome, sir. We also have with us Dr. Tejinder Kataria, Chairperson, Radiation Oncology, Vedanta. Kindly keep the applause going. A pioneer in advanced radiation techniques, Dr. Kataria is internationally respected for clinical excellence. A very warm welcome to you. We now welcome Dr. Ankur Bahel, Principal Director, Medical Oncology, Fortis Healthcare. Dr. Bahel is known for leadership in medical oncology and research-driven patient care. Please put your hands together and welcome Dr. Hemant Malhotra, Director, Oncology Services, Sri Ram Cancer Center. Dr. Malhotra brings decades of experience in academics and clinical oncology. And this session will be moderated by Mr. Prakash and Singhdeo, Country Brand Lead, Pfizer India. Mr. Singhdeo brings strong experience in digital health innovation and strategic healthcare branding. Can we once again welcome all our esteemed panelists on stage? I think we can do a little better. Over to you, to our session moderator for further proceedings.
Thank you so much, Mr. Ford, for the invitation. And this August panel, Dr. Rupu, Dr. Kataria, Dr. Bala, Malhotra. I have a couple of very interesting slides before we deep dive into our sessions on them. And it's about innovation in oncology. As you can see, digital transformation is something that is there throughout. And healthcare as an industry has an amazing
amazing background. The research that we do is absolutely practical. It is one of the industry leading across all industries. It is the sharpest research that we've done. But what when we see, but when we compare this to where we are today, if I can have the next slide, please. Compared to what it has brought, and specifically in this era of AI, and how AI is transforming healthcare. The AI-driven total healthcare market globally in 2025 was $34 billion. That's about 4,200 odd crores. And until 2030, it is expected to grow to 1 trillion, which is some 82,000 crores. Until the year 2025, the US FDA alone, and I'll come to India, has granted approvals to 950 other medical devices or AI and machine learning algorithm treatment, which are treatments for any types of diseases. While we are talking about that, in India, we have had everybody now is very familiar to ChatGPT, and I saw a couple of my friends there from the organizers also very uh, quietly and intuitively working on them. India alone accounts for 13.5% of the total users of ChatGPT. It won't become the highest user base for ChatGPT in the world. But you know what we as a country are searching today? The top three searches, and I declare that I used AI itself to find this, was how do I prepare for my exam schedule? How do I study for my upcoming exams? Is the number one search for ChatGPT in India. Number two is about sports queries and scores of IPL. Number three is related to how can I queries? How do I do this? How do I learn this? But at the other end, if you see what we are also doing in India, these are the AI-based startups in India, and there is some thing from AIMS as well. The last two are Bangalore-based startups, which are into breast cancer screening and are using AI to ensure that there is accurate diagnosis from the blood smear. Here, AI is not exactly a diagnostic tool, but it is in that direction. All of these are AI tools which are indigenously developed, not necessarily approved by CDSU, but some other places have found applications in India. So as far as health in India is concerned, sir, there's quite a bit that is already happening. And if you're not interested in any of these, I strongly suggest you research them as well because they are going to blow big time. But what I bring to you is ensuring that ethics at the back of it is always there. Ensuring that while we work towards and use AI, it is ethically driven. And that's why I bring to fore our discussions today. Bring to forth our discussions today regarding technology and how we are doing it. Sir, to you first, if I may. From the decades of experience that you've had, how has technology meaningfully impacted lives, specifically in terms of patient identification and patient safety in radiation oncology?
So before I tell you certain specific examples, that one line I can say that from the broad beam applications, by broad beam I mean when 20 years ago, if you were to treat a patient of cancer of the cervix, all the patients who came to you, you gave a rectangular field of 16 by 14 centimeter, which included the entire uterus, the urinary bladder, and the rectum. So that was a broad beam application of radiation. Same was true for head and neck cancer and other areas. So from broad beam applications, we have now reached a stage which is fine-tuned, which is patient-centric, precise medicine. And that is what radiation oncology is, and other disciplines are there too. Now, specific examples, imaging is a very important component of cancer care. Imaging helps you in diagnosis, but imaging helps us in radiation oncology to a very great extent because it is imaging based on which we plan our patients individually. CT scan development over the years has aided radiation oncology very much. The development in MRI, development in PET scan, and CT scan is done for every patient of radiation therapy for planning individualized. There are certain situations like brain tumors and central system tumors where MRI gives you more information. And there are still situations where they give you anatomical information. There are still situations where you need biological and physiological information, so you get a PET scan. So, one simple example, you treat a patient of cancer of the lung. On CT scan, you see 6 by 4 centimeter patch. Now, this 6 by 4 centimeter patch may have cancer, plus it may also have a collapsed lung because of the obstruction. So if you do a PET scan will tell you that 4 by 4 is the cancer, the rest is the collapsed lung. So that will have the patient taking a large amount of, normal tissues.
Oh, thank you, sir. Thank you so much. Ma'am, the question is to you. And while we are speaking about AI and looking at AI, has this practically improved in any of your treatment planning for your patients?
Definitely. AI is an integral part of our radiation treatment planning and delivery systems because, as Dr. Hooper said, that we use imaging in a big way for our treatment planning systems. And the AI is knowledge based deep learning algorithms which have now been implemented for capture of the image, for multi imaging data, that is MR, CT, PET CT, to be deformed iteratively and then planned for a particular patient. So these are seamlessly done and they have reduced the planning time from days to minutes. So that has added to the reduction in the treatment time without compromising the quality of the treatment of the patient. And that has given time to the physician to attend to the patient needs and provide care to the families which they were spending on the computer systems doing all this work. So it has definitely added to that. And secondly, the automated systems with the AI have assisted us in tracking the moving tumors like in the lung or the liver and deliver the treatments with sub-millimeter accuracy without compromising either the cure or the complications to the critical structures. The morbidity has reduced, the overall cancer cure rates have gone up, so these are the contributions from the computer algorithms and the artificial intelligence, which have been now embedded into the planning systems, and that they have aided to the cure of our patients.
Thank you, ma'am. It has definitely led to better patient outcomes in terms of safety as well as in terms of disease outcome. So if I can ask you, Dr. Bal, and from a medical oncologist perspective, you've always been data driven. Oncology decisions are data driven. But has the data driven way of thinking or decision making changed in helping personalize those treatment for patients due to advent of technology and AI?
Absolutely. So there are many perspectives with a physician or a medical says. First of all, what exactly is the data? So last 5 years, 10 years, we were doing Google searches and all. So now with AI, those we can't talk about one ChatGPT, or there are many such platforms where we can extract. I can do a cross trial comparison within seconds. I haven't seen myself going to a library. When you last went to library, we all have been to libraries to search that chapter, index, referral of that chapter. So now everything is with us. Second point, which I have learned in last 2 to 3 years, I cannot live without my ChatGPT. I'm telling you because it is replacing my existing EMR. The EMR in the hospital is a old, outdated one. Whatever I'm doing for last 6 months, I can take out the data. I can easily take out the data from mobile, from my chat GPT library, that how many EGFR or ALK positive mutation I saw, and in how many patients in last 2 years I saw EGFR ALK fusions and all those things. So data capturing, my own understanding of the data and my knowledge. Look, I was not trained in such kind of oncology practices. Today, the oncology practice is changing at a, I would say, devastating pace. I cannot keep a pace with the knowledge. But with this AI and all those things, at least I'll be having some, I'll be on the table that I can try that. Otherwise, I would have lagged even in organ specific. Even I manage a couple of organs in my oncology practice. Still, the data is changing so much. My patient look the same platform patient also has, and patient is also well read. जिसको disease होती है वो भी पढ़ के आता है, जो disease ठीक करता है वो भी पढ़ता है. So it has to be, you have to be well versed with the data. And if a new data has been published in last year, last month, ESMO and ASCO, I can't keep a pace with that. So this AI is helping me in keeping a pace with the technology, with precision, with genomics, everything.
And so, we are getting to learn this because these are developments that have happened in our lifetimes. For the newer generation that's coming up, people who have just started their medical colleges, do you think we should start advocating for a way to use or an ethical way to use AI course?
So yes, so we have been seeing the crops, the COVID crop. I call it COVID crop. There were some postgraduate students who have done their MD and MCH in that critical COVID period where we were learning about managing that virus rather than because there were no patient and it was a lockdown. So yes, a curriculum needs some change from all the level, from the medical oncology level, from a medical college level till the NITI Aayog level. We have to have this course also. Data science, a younger one is in ninth class, and he has a data science as a chapter. Even in 10th class in board science, data science is a, they know, the kids know Excel and all those things at a very faster pace. So if they are given this seed, if they are imbibed with this technology at this point, a lot much can happen.
Indeed, and I guess everyone who's has a child in the teens and now really needs to learn about 6, 7. But that's for another time. So to you, and if you know how digital tools are helping bridge a lot of understanding of patients and the gaps, do you think that in academic centers versus real world practices these to correlate and work somewhere?
So thank you, Prakash. First, I'd like to, greet everybody, congratulate everybody. We are on the eve of the Cancer Survival Day, which is tomorrow. So that is a kind of accumulation of the effect of all of us over here and all of us, all of you in the audience. And like greetings to all of you on World Cancer Survival Day. So your question is that if you have high level artificial intelligence and electronic capabilities at advanced academic centers, will that help or should that happen? So there's no question in my mind, and I think there's no question in anybody else's mind that this is an essentiality. And the various ramifications and the benefits of this, could be many. All of us have electronic medical records now, analyzing these EMRs and putting out red flags. Suppose I'm using two drugs in a patient, my pharmacist is using two drugs, and they are mutually antagonistic. So the AI algorithm in my EMR will flag that, and then major harm can be prevented to the patient. Then you can use this as a the basis of a multidisciplinary tumor board. For somebody sitting in a district hospital, he or she has a complicated case or a complication due to therapy given there. They can discuss that patient in a multidisciplinary tumor board, which is organized at the academic center, and know how to do what, how to proceed, when to refer. Then you can think of telemedicine consults augmented by artificial intelligence. This again, patient is at his or her home, and you are sitting at the academic center, integrating with a local physician, and that would be of major help to the patient. I mean, you can treat the patient as at his or her bedside. Then there are infinite applications for medical education. We have so many medical colleges coming up. Every district is planned to have a medical college. There is no way that we can find teachers for the students over there. So the academic center can, do virtual classes for these students, and it's not as effective as your lecturer standing in front of a desk and talking to you, but it is the next best thing. Uh, then you can, with the help of AI, do remote monitoring, extremely vital for dermatology. You take a camera, you show the skin lesion to the expert at the academic center, and you have a diagnosis in minutes, and you have a treatment recommendation in a minute. Similarly, revolution is happening in radiology, chest X-rays, CT scans, MRI scans, revolution is happening in pathology. A slide beamed through a microscope to an academic center of a rare tumor. The experienced person there using an AI algorithm can majorly guide in the diagnosis. So application of AI in academics is infinite. So I think there should be few centers maybe in every capital of the states of the country, which excel in integrating academics and AI, and with access, all the medical colleges, all the district hospitals, in a hub and spoke fashion should have access to these centers.
Indeed, and it's the pace at which it is growing, it is just a matter of time before it does get spread to everywhere as well. So to you, while we are talking about the good part of AI and that it is proving to be so beneficial, which it is. Do you come across some of the challenges that you would face and something that we need to be cautious about implementing it in an actual patient care setting?
See, just like any individual who doesn't have everything, good qualities, everybody has some bad qualities. So AI is a revolution, and everybody thinks that AI will solve all our problems. But we have to be very, very careful, especially during the early phase of implementation. Now, in radiation oncology, I'll just give you one example. As I told you, every patient, we do a CT scan for planning. There are multiple slices, and on each slice, you have to mark the tumor which you have to treat and mark the critical organs which have to be protected. It is too much of work. It is labor. The doctor spends a few hours on doing that. So there is AI gives you a facility which is called auto controlling. You feed the parameters, AI will control. Now you gave one patient, you gave 10 patients, you gave 15 patients, you checked all of them. It was fantastic. So the 20th patient, you said AI will do everything and you left it. You didn't check slice by slice. And unfortunately, that was a patient with prostate cancer where in one or two slices the capsule was breached and the tumor came out of the capsule which AI did not capture. You did not look at it, you prescribed, and after few years, patient failed in that. Similarly, a brain tumor, a small area which did not make contrast. You thought everything is good, AI is a very good tool, you missed that. Geographical misses, marginal differences. So, it is a very good tool, but at the same time, you have to be very, very cautious. The other important thing is that whatever model you use, you have to validate it locally. For example, mammography. AI is a very good tool for evaluating mammography images. But if a program is made in America, it is actually that system has learned on Caucasian women, on African American women. The breast volumes are different. The breast densities are different. The biology of the tumor is different. Comorbidities are different. It has trained on high-end, high-resolution mammography machines. And in India, when you bring it, we have, old machines, we have mobile machines. So AI becomes, unless you validate it for our this thing, probably it will give you false positive and false negative. It is trained on small tumors, centimeter. And in India, it sees a tumor which is 6 centimeter. It grows back. What is it? What am I seeing? So you have to validate it before using it in your own setting. Another thing which comes to my mind is it will give you the answer, but it will not give you the reasons for that answer. Now, it will say in head and neck cancer, I want to find out whether this patient needs chemotherapy with radiation or not. AI will say no chemotherapy. It will not, tell you why it has released. Now, if later on, if the patient recurs, it goes to, the medical legal issue. I cannot say that AI told me like this, and therefore I did this. And the other last thing, which is very important, like the data they were saying, we should know where the data is stored, who is accessing the data, because data, confidentiality is very, very important. You don't know the vendor is using it to train somebody elsewhere. So these are certain things. Of course, it's a very good tool. It helps us, but we have to be very, very cautious in using it, especially when we are starting using it, very early in our career or patients.
If I can say, if I can we say, sir, that it is a very good servant to bad master?
Yeah, the question is, as they said, the youngsters, they are dependent so much on this that there is erosion of clinical talent. So, on one side, you only use it wherever it helps you to cut down on time, but you have to be very, very vigilant in, using it for what purpose and for what results.
Sure. So you also brought up the topic of, and this is for a larger question for everybody of us to answer subsequently, is that while we are looking at AI models which are trained elsewhere, but at this point of time, we do not have enough or organized data set within the country which we can train our models on. If there's one hospital which is training on a data set, it is only restricted to that hospital's data. Now, there's a massive opportunity for us as somebody who would want to build on that data set. There's a centralized data set that is available with all parameters, and I'm talking about specific to cancer and other diseases of such great outcome. If there is a data set which is available, this presents as a massive opportunities for us to have our own models in place. On that, ma'am, if I may talk about your center, which is a high volume center. What are the some of the technologically advances that you have seen or tools that you have helped implement that helps you manage patients in such high volumes?
For a high throughput center where the patient's process had to be optimized, so you have to have a standardized operating procedures. And once you've done that, how do you implement that? So there has to be some record, and then you have to have a quality assurance program to verify and have the audits. So to fulfill all these, what I think digital transformation in medical records has helped us and come a long way. Doing the paperwork, paper charts, patient charts in the inpatients, in the outpatients, in my department, when the patient goes through various corridors, going to the labs, going to the radiology imaging, all the data sets can actually be collated under the patient's same ID, the central registration numbers or the universal ID, and you can access them in the hospital and also at your homes nowadays through the mobile apps. So that ease of access of the patient data has happened because of the electronic health records. So that digital transformation has assisted us and empowered the providers as well as the patient because they can take a look at their results of their labs, of their imaging, and whatever the doctor's prescriptions are on their own mobile apps. So this cross the disciplines, that is the patient and the provider, the digital bridge has been laid. And that has assisted us in improvising and also delivering a quality care for our patients. So that is one of the biggest things which has happened. And in cancer, actually, in my subject, quantum physics, mathematics, and imaging, genomics, proteomics, molecular biology, everything has to be brought together for the patient treatment. So then we can access all these. And the second thing which I think has happened is that if we look back 20 years ago, or even 25 years ago, 30 years ago, all the medical oncology drugs and chemotherapy drugs were plant based. They were derived from there. But with the digital systems, the synthetic products have been now made because we understand the DNA and the genomic and proteomic structure and the RNA, transformation of those products as they act onto the cancer. So the synthetic digital transformation has taken away the dependence on the plants. And there is a mass production of the medication which now can be available to a larger group of patients. Earlier, the drugs were more expensive. There were patents which were almost for 20 years. And now we find that the drugs are now coming in, even the targeted and the immunotherapies in a big way. And you see the sea change which is happening year to year rather than over decades. So these are two things which I think the digital technology has brought into healthcare in a very
Indeed, ma'am. Thank you. And thank you for talking about drug design and its implementing. I remember when I'm a pharmacist by qualification, and then I did a little bit of drug designing. When I was graduating out of my class, had a class as a course called Structure Drug Design, which we shortly called SAD. And it was a sad class because there was only two students who attended that lecture. And fast forward in today's date, the same institution, that is the most sought after class in the whole of the pharmacy was. So indeed, the times are changing. But
also it takes away, when we look at, let's say, talk about a simple product from Curcumin. Curcumin has more than 100 employees. So which one of them is working when we take it to the raw form with the milk and the pepper? Whether that is coming from the curcumin capsules or not. And the time when it rains, what is the alkalinity or the acidity of the soil, how much sunshine was there, that is taken away once you go back to the
thank you, ma'am. Back to you, sir. We know tele-oncology has proven itself over time and time again that it is something that is helping us continue with the cancer care. Do you see this evolving in the future? Do you see this improving or propagating enough within the country?
So I think it is propagating enough and it will go at a different pace. So I remember my own practice till now. So patient used to come to our daycare and the doctor used to say that your platelets and your TLC is not up to the mark. So please go back. And this patient is driving from 300 miles for chemotherapy and has been told that your platelets are not okay. At least the teleconsult part, the things which can be done remotely, the incidence of febrile neutropenia, sepsis, and all has gone down because of these teleconsults. If you do a basic thing in your department till the resident level and you tune them and your patient that, look, this is a QR code. This is a recent QR code for you for a diet. I am looking at the agenda of this meeting through a QR code. Everybody looks at our dietary. We have in our department have made QR codes for the dietary, QR code for the psycho-oncology. Last year we did a 2,900 patient population-based survey. What they think about the genetic counseling? Only on the basis of one QR code lying in front of my OPD, and everybody was scanning. What is it? So these teleconsults can look as the previous panel, they were saying that patient comes, travels, and nobody even examines them. They just say, "What is this?" and go in a heavy out and heavy burden OPD. But yes, when the patient has to travel a lot for just a simple thing that has been brought down. Initially, we used to say, "Go to Tata Memorial or go to CMC Willow." Now the same thing can happen. At least they can guide you, and I believe that in a teleconsult, patient and the party, both the doctor and the party are very serious. It's not busy OPD, it's one is to one. You can't see emotions, you can't see through eyes, but yes, in screen, you can tell them the right thing. You will read it properly and then advise them, and it is on the records. So, COVID has made us wiser, and this will probably increase and it will decrease our burden in the OPD physical well-being. I think so.
Indeed, indeed. Thank you, sir. And so the final question of this panel discussion to you. India is now developing. India is beyond the tier one and metros. It is in tier two, tier three, and at times tier four and rural areas. What do we do to ensure that the transformation that we're seeing here, metros, also reaches at those levels?
So I can think of several things which would be important to pass on the benefit of all this advance in electronics and computing. to the most peripheral parts of the country. I think the first and the most important thing is the last mile connectivity. You have to have a foolproof, constant internet connection, at least at district levels, preferably even more peripheral. The second thing which comes to mind is that you have to talk to them in their own language. So vernacular literacy is extremely important. So if I have a patient from interior Rajasthan and I'm speaking to him in English, there is no point of that telling him. I have to talk to that patient in Rajasthani and then only I'll be able to get through. Then I think another important thing is to develop peripheral, low-cost digital centers. So one in each district or one in each tehsil, where the patients can gravitate to sit and talk to their treating physician or the advanced center uh, by teleconsult. Then one more thing which I can think of is that you can do tumor boards like this, you can do teleconsults like this, and of course, patient education that can be very easily done and it can be done at very, very few areas. So these are some of the things I think which we need to do now as phase two, where the cities are very literate, our boys and girls are very up to date. We need to go to tier two, we need to go to tier three, and we need to go to our villages.
Indeed. Yes.
Recently, our hospital has adopted one of the village. Name it right now, call it is so what we have done is just the sarpanch is going tobacco consumption is too high in that village. The sarpanch and the punch is just giving us pictures of that any oral glucose deviation. So people are not coming, they're coming at advanced stages. So that digital picture can actually identify the first leukoplakia, erythroplakia, or that early cancer just by a picture. Three pictures of this buccal glucosa, one parent in this buccal glucosa, and if we have a 5,000 smokers or non tobacco users, and we have the pictures, it can be done within minutes. You can pick up. So this is the power of a not teleconsult, like AI into the picture. And one more thing, I'll just take 30 seconds. So I was the silica and cement industries have a high tendency to have lung cancer, and most of the laborers are smoking. Just if you have an AI based security cameras, and if you pick up that how many of these workers are actually taking a break of that smoke, the amplification of silico asbestosis and smoke is actually 100 times. So if you can stop those workers taking smoke in that break and the camera can identify, the AI can identify, the chances of developing an occupational hazard cancer can be reduced. So these are the technologies if we imbibe in our practice, at least we can do some wonders.
Amazing use case. Very, very exciting times for all of us to come in the days to come, and all of us will be here to see the transformation. Maybe the next session of this conference, the next year when we have it, maybe we will have more AI built into it as well. But thank you to each one of you for coming here and sparing your time and enlightening us. Thank you very much.
Give it a more energetic round of applause to all our panelists for a very insightful and a powerful special request moment to please join us on stage for our memento ceremony. Post this, we have insightful presentation and then the last panel discussion. Then we'll begin with the award ceremony. We'll start with Dr. S. Huku to please step forward. Advisor Radiation Oncology, Sir Gangaram Hospital. Dr. Tejinder Kataria, Chairperson, Radiation Oncology, Vedanta, kindly keep the applause going. Dr. Ankur Bahil, Principal Director, Medical Oncology, Fortis Healthcare. Thank you very much, sir. Dr. Hemant Malhotra, Director, Oncology Services, Sri Ram Cancer Center. And our esteemed session moderator, Mr. Prakash and Singh Deo. country brand lead Pfizer India. Let's all thank him for his able moderation. I now request all our learned speakers to please come forward, come together for a group photograph. Thank you very much. Thank you so much for joining us for this session. Ladies and gentlemen, we now march forward to our next session, which is a keynote address. Post this, we have one more panel discussion lined up, and then we'll begin with the much awaited award ceremony. With due respect, I now invite on stage Dr. Sunil K. Ketarpal, Deputy Director General AHPI, to render the keynote address. Can we please welcome Dr. Sunil K. Ketarpal on stage, ladies and gentlemen? Can we give him a more energetic round of applause?
Good evening, distinguished guests, colleagues, and friends. I have been asked to give a keynote address because of my, probably for this on Cancer's Day, because of my association which I had with Rajiv Gandhi Cancer Institute. I just give you my background. I joined Rajiv Gandhi Cancer Institute as medical superintendent in 2006, and I worked there for 4 years. So I can see Dr. Vijender Kataria, and Rajiv Gandhi has produced one of the best oncologists in the country. So I can see, wherever I go, I can see people from Rajiv Gandhi Cancer Institute. They are across all the, uh, now, I think on the World Cancer Day 2026, we stand together under a powerful theme. It's a beautiful theme called United by Unique. United by Unique. It reminds that while that cancer affects millions, no two cancer journeys are ever the same. No two cancer journeys are ever the same. Every diagnosis has a human story shaped by age, geography, income, gender, family support, and emotional resilience. Yet, despite this reality, cancer care is often delivered through the fragmented systems, very disconnected services, and uneven access. Accessibility for cancer care is always an issue. Today, I just want to speak about why cancer care must move from fragmented care to the united care, and why it needs many voices to succeed. It's important that we need to have many voices for a successful treatment of cancer. Now, let me tell you a brief story: the human cost of fragmentation. When a lady, 42-year-old mother from a small town, she first noticed a lump in her breast. She delayed seeking care, not aware of what is happening, what this lump is, not out of neglect, but also out of fear and lack of awareness. When she finally did, she was sent from one facility to another facility for screening and biopsy elsewhere and treatment somewhere else in a distant city. So no one explained to her about the process clearly. No one addressed her anxiety, her financial worries, or her clinical concerns. By the time the treatment began, her cancer had advanced. Not because medicine failed her, but the system did. It was a system which failed her to seek intervention at an appropriate time. So, this lady's story is very unique. It reflects what happens when it clinically care is capable, but structurally it is disconnected.
So united by unique, that is recentering cancer care. This theme asks us to reframe cancer care around people, not protocols. Patient-centric care. We always talk of patient-centric care. What does it mean? It does not mean only the clinical care, the medical care, or the treatment part. It is, I always say that practicing medicine is both art and science. The art part of the medicine, we know your uh, attitude, your behavior, your human touch, your eye contact, most importantly, your communication. This is the art of medicine, which is very important to have to integrate with your science of medicine. That is your clinical part, clinical care. And patient-centered care also means, as I mentioned, the communication with empathy. Empathy is a very, very, very key word when we talk of patient-centric care. And supporting the patients beyond the diagnosis and treatment. So this is what patient-centric care is. It means you are recognizing the health outcomes that they are deeply tied to the human experience. United Care does not erase individually. It respects and responds to it. Now, why cancer care needs many voices? We always say that cancer care should not be in silo, or it needs many voices. Cancer care cannot be addressed by a single institution or sector. It requires, if you see, the government leadership, the governance for the scale and equity. It requires private sector innovation. So for all stakeholders, there are multiple stakeholders. Private sector, innovation for advanced care. Private sector, they have all the best of uh, expertise, talent, technology, and NGOs for outreach, and patient navigation. We require NGOs, we require private sector, we require government leadership, we require professional associations for quality and standards, we require communities, families for trust and continuity. So they are all part of the healthcare ecosystem when we talk of cancer care. Now, why these voices they work in when we say that these voices they work in isolation, patient fall through the gaps. And when they work together, care becomes seamless and humane. This is very important. Now, the role of the government is very important, strengthening the foundation. India has made a meaningful progress through initiatives such as Ayushman Bharat PMG, Prime Minister Jan Arogya Yojana, which reduces the financial barriers to cancer treatment. Health and Wellness Center, we all know that about 170,000 health and wellness center, Ayushman Arogya Mandir, they are there, which are enabling the population level screening. Cancer screening is done, and National Program for Prevention and Control of Cancer, Diabetes, and Cardiovascular Disease and Stroke, that is NPC-DCS, which integrating cancer prevention into primary care, and the National Cancer Bridge, standardizing the protocols and knowledge sharing. Then we have the government has also proposed to set up a daycare center in 764 district hospitals in phased manner over 3 years, and which I think 200 we have planned for the year 2025-26. Now, this budget 2026, which was announced just 3 days back, we have this custom duty relief for about 17 cancer drugs, which will, to quite extent, will address the affordability part of the cancer care. And these initiatives form a strong backbone, but policy should be matched with the partnership, with the collaborations to reach every patient in every geography. So cancer care it should reach to the last mile, not only for the affluent and for the metro cities. Now the role of private sectors, NGOs and associations, they complete the circle. The role of government, of course, is very, very important, right from the level of the governance and the leadership. The private healthcare sector contributes advanced diagnostic and precision oncology, and they have specialized treatment capacity, research, innovation, and workforce training. NGOs, they serve as the human bridge. They drive awareness and early detection, guiding patients through the complex systems and addressing stigma. Stigma is something which, you know, we need to address. And the fear and the survivorship needs, these are addressed by NGOs, which serve as the human bridge. Now, professional associations, their role is to ensure the quality benchmarks, ethical standards, continuous learning, and patient safety advocacy. I think together these stakeholders coming to a common platform will transform the care from the episodic treatment into continuous support. So cancer care requires continuous support. The treatment is a long-standing treatment. Treatment is expensive. Emotional support, financial support. So I think we need to look very comprehensively. Our approach should be to not to address the diagnosis and treatment only. And most importantly, I would emphasize here on preventive oncology, which I think I need to mention to speak for 2 minutes on preventive oncology, which is the most powerful, I should say, intervention. And we are truly committed to United by Unique. But prevention must lead our strategy. See, it has to be part of your strategy, right? Where we should address the preventive aspects of oncology right at the strategic level. And preventive oncology, I think I need not elaborate, just to mention a few. We talk of tobacco and alcohol controls and HPV, human papilloma virus vaccination, which I think Tamil Nadu was the first state government to introduce, at the school level, giving free vaccination to all the girls aged, I think it's 9 to 14 years implemented. And also, lifestyle and nutrition awareness is important because we know NCTs, how it is taking toll these days. And lifestyle diseases should be, addressed. The nutritional awareness also need to be, talked about at every level. It should start right from the school level. And environmental and occupational risk reduction, regular screening and early detection. Two of my doctor friends, incidentally, when they underwent the preventive health checkup, that is the annual health checkup, they, you know, it was incidentally detected that they had renal cell carcinoma, both of them. This was just incidentally no symptoms. Usually, the renal cell carcinoma will not have any obvious symptoms, no hematuria, no pain, nothing. But then they got operated and they are fine. One of them was operated 15 years back. So it was just incidentally detected, ultrasound, simple ultrasound test detected. Why? Well, I mean to say that we are very poor in preventive preventive health. Even the organizations, the institutions should focus on preventive health. And preventive health, actually, we can save a lot of, we lose a lot of productive days. Once you detect the disease, it is too late, and then you start the treatment. I remember in Rajiv Gandhi Cancer Institute, I was just conducting a study on, the OPD number of OPD visits, first time OPD visits, first timers. More than 60% of the patients were reporting at an advanced stage in OPD. Just imagine. So nearly 70%. So then it is too late, of course. They can only improve the quality of life. And so it's very important that we should always, at the school level, we should have that education. In Japan, at the school level, they give a lot of emphasis on nutrition. At the lunch break, they all talk about the nutritious food. They all sit together. The children, they are taught at the school level. So this is something, and every school will have a dietitian in Japan.
They have a dietitian on roll, you know. This is so important. And हम लोग बच्चे को चिप्स दे देते हैं, मैगी देके स्कूल भेज देते हैं. What to talk of? I think it's high time now we should start telling our children about this. And now coming back to fragmented care, from fragmented care to the united care. Now united care means integrated referral pathways, multidisciplinary care teams. We know we have this tumor board, uh, multi-specialty clinic, you can say, financial and psychological counseling, survivorship and palliative care integration. See, healthcare is preventive, promotive, curative, rehabilitative, and palliative. It is preventive, promotive, curative, rehabilitative, and palliative. So, across the spectrum of healthcare, we need to, I mean, all these elements of healthcare we need to address. And most importantly, lastly, I would say that it means ultimately it is listening to the patients. Because systems will improve only when patient voices are heard. Patient feedback, patient experience, we is important. The human touch. You may have AI, you may have the technology, advanced technology, but then the human touch, the eye-to-eye contact cannot be replaced by AI. Or AI will definitely replace the doctor. The one who is using AI with the one who is not using AI. Because AI is important. We need to, it's an integral part of our, day-to-day life. But then we should not be dependent on AI. It's how and what we train, what we feed to the AI. But let AI not master us. So AI and the legal liability, the ethical, moral, and legal liability lies on you, not on AI. If anything goes wrong with the patient, it is not the AI which will take the responsibility. It is the doctor, it is you who is going to be the onus will lie on you and who is going to be liable legally, morally, ethically. So cancer challenges the body, but fragmentation it challenges our systems. Now on this World Cancer Day, let us commit to the breaking silos. Let us all come together. Invest in prevention. Again, I'm emphasizing, please invest in prevention. We don't invest in prevention. Invest in prevention. Elevate patient voices. Please let them speak. Please listen to the patient. And, communicate with the patient. And you need to build a lasting partnership. You need to build a trust among all the stakeholders. Because when the care is united, the outcome will improve. In healthcare, what matters is outcome. When care is compassionate, the trust grows. And when we honor the uniqueness, we restore humanity to healthcare. So together we are united by unique and united in purpose. Thank you very much.
I request Homer sir to please join us. Round of applause, ladies and gentlemen, for Dr. Sunil. Thank you very much for such an informative address. And please give us this opportunity to thank you for your presence, for your sharing your thoughts with us. We now present a token of appreciation, a token of gratitude to Dr. Sunil K. Khetarkar, Deputy Director General, KHPI. Thank you very much.
Okay.
And ladies and gentlemen, we now march ahead to the final panel discussion for the day, and then we'll begin the award ceremony. Our upcoming session is a flagship dialogue that brings together patients, clinicians, policymakers, and industry leaders to align lived experience with system design and policy action. The discussion will focus on bridging gaps between intent and impact, ensuring that patient voices actively shape policy framework, access pathways, and care delivery models. Our stage is all set. Please join me in welcoming on stage our esteemed panelists. We have with us Dr. Vivek Tomar, patient advocate and founder ALK Positive. A leading patient advocate, Dr. Tomar works to amplify patient voices and access to targeted therapies. A very warm welcome to you, sir. We also have with us Dr. Ali Asgar Patwala, lead market access surveyor India. Can we please give them a more energetic round of applause? Dr. Patwala focuses on bridging policy, pricing, and patient access. We now welcome Ms. Vandana Mahajan, lead counselor Lung Connect India. Ms. Mahajan brings psychosocial support expertise to patient care pathways. Welcoming our guests. We also welcome Dr. Sham Agarwal, senior oncologist at Ganga Hospital. A highly respected oncologist, Dr. Agarwal is known for patient-first clinical leadership. A very warm welcome to you, sir. And this session will be moderated by Dr. Abhishek Shankar, Assistant Professor, Radiation Oncology in Delhi. Dr. Shankar combines academic excellence with patient-centered clinical practice. We once again extend a very warm and hearty welcome to all our esteemed and learned speakers. Over to session moderators.
That might be easier for this. That might be easier. And the first person is using keeping care of. Absolutely. Okay. So I think can we have it here also? Otherwise we have to look back to this here also. Even I don't remember what I've written in my back. So, and how to go next this. So thank you so much, IHW Council, organizing this even on the eve of World Cancer Day. So I have heard a lot and everybody was so good in addressing the problem. I think generally you don't hear this discussion during the typical medical conferences. So I'm Dr. Abhishek and I have been given this responsibility to moderate this panel with all my very, very learned panelists. So let me just start, with my declaration. So probably no financial disclosure. Given I've used my own card to reach the venue, so nothing is given by ISW Council. So probably technical declaration is it's a very important in technical era. People are leveled to use ChatGPT or AI tools for making the presentation. I want to disclose that I have not used ChatGPT for making the questions, right? And I declare no competing interest unless you count my ongoing war against disparity and inequality in cancer care. So coming to the some housekeeping rules, because this is please keep the discussion evidence based. Please keep your point in brief and to the point. And this is not a typical TV debate. So passion is welcome, but please no cross talk or shouting. So no TV style debates because we are aiming that everybody should reach back home safely. So this is the request, right? So coming to this hand up. Do you think cancer policy in India meets real patient life needs? Just hand up. Do you think yes or no?
Please, you can. Cancer care policy in India means real patient life need. Yes or no? If you say yes, probably we are going to stop it here because there is no further question. We are just up to the mark. So I think organizer will have relief because they are saving time. Okay. So do you think yes or no? We have to just okay. No. So we have to go ahead with the panel discussion. Thank you so much because I worked so hard on the questions. So coming to the next question for Vivek. So I think you have been a patient advocate and we have met in quite in WCLC. You are a very important voice in the lung cancer advocacy. So what do you think, biggest disconnect when with what is the patient requirement and what is the policy? What is the disconnect? What do you think? Okay, I'll share.
Hello, and thanks for the housekeeping. And you have not covered Hatapai, so we are not also going to do that. And to all who are here, just for your attention purpose only, how many you are clinician here? If you can raise your hand. Okay, good. How many are patients and caregivers? Any policy maker here? Okay. Okay. Thank you. And you may need to, ISW may need to provide more, okay, next time to have more policymakers here for such type of session, but thank you. I'm Dr. Vivek Tomar, a patient advocate, and I work this in my volunteer work. When my love, my wife, my late wife, Kusum was diagnosed with stage 4 lung cancer despite a never smoker, our world does not only change, it stopped. It stopped because we realized that we are not fighting only with the disease. We are fighting with the whole healthcare system of India. In India, 75% of cancer are usually diagnosed at very advanced stage. However, our policies heavily, and I emphasize heavily structured and emphasized only with a curable structure. Either it is early diagnosed, stage 1 or stage 2, or it is a system where it's cured. Though it means it is ignoring 75% of cancer patients in India. Those who know, I am the founder of India's first lung cancer support group for oncology, that is ALK lung cancer. And my wife was first patient from India on serotonin and alectinib. And I am the one who bring those medicine after a long fight with the healthcare system, including policymaker, DCGI, and industry. And that was an uphill task against a clock that never stopped. My wife was losing life, was on a deathbed. Clinician said, घर ले जाइए, कुछ नहीं हो सकता. And I was fighting to have a medicine that was in somewhere healthcare. So for me, a policy, the biggest challenge is a policy should not be about access to hospital bed. It is also the navigation how a patient can reach to that hospital bed and a hope that patient can remain in that hospital bed. We need policies that says that not only treat pathology, we need policies that treat disease and humanity. Thank you.
If I ask you, because policy himself or herself has to spend a day like a patient, what will shock them more in our system?
So if policy,
Yeah,
okay.
policy has to
So,
be like a patient. So what
so
will be more shocking?
they will find that Sue is pitching.
They wanted to be the policy only. They don't want to be patient, right?
Yeah.
It's difficult to be a patient in the country like India or anywhere in the world. And I think coming to the second panelist, so I think you belong to the industry. And I think there are too much bottlenecks. When you talk about the clinical innovation and patient access, it's like the same. You order the food on food app and you're very excited about delivery of the food. And but I think it's always showing that, arriving shortly. It is same in terms of the patient access, right? When you do the innovation, but because of the affordability, accessibility, that's very, very difficult in country like India. So what are the biggest bottlenecks? You want to do good, but there are many stuff, right? So please tell me the bottlenecks. And if you tell me about the bottlenecks in last 5 years, tell me how did you countermeasure those bottlenecks?
All right. So I think a very pertinent question, and I would like to start because innovation, right? The first and foremost thing, and this is very specific to cancer or the oncology, I want to ponder upon a question: how much indigenous research is happening in India in the cancer care ecosystem, right? Which means that we have to rely upon the Western worlds to bring the innovation to India. And if we are relying Western worlds to bring innovation in India, it will come at a cost. We have to bear that cost. And then, from an industry perspective, if I have to talk about it, recently, I think the recent shift, how the Trump administration is working on the different pricing policies. Everybody wants the drugs to be there, which are available at the world at the same price. But overcoming all of those bottlenecks and barriers, let's say we bring the innovation to India, where the HCP, like sir, wants to prescribe it for the patients, right? And patient really wants that standard of care which is available. However, who is going to fund about this? And for how long it will be funded? And under what policy framework allows that particular standard of care essentially to be given so that the patient outcomes are optimal? So when we talk about the access bottlenecks, right? We have to think about how we can bring the innovation indigenous, doing the research and development so that we can bring about the cost. And then India itself is a country within multiple countries, right? So one fit will not work. And then you talked about how we are overcoming. And I think the way we are looking at it and overcoming is essentially we talk to our global colleagues and say that this is how the disparity map of India is. You have a 3% or 4% of population who can afford anything.
Don't you think that they compare India with China, right? They have a multi-billion, the revenue from China, and they see Indian population. They don't know India is very diverse. So, mainly, what do you think that pricing is an issue, government policy is an issue? What is the main issue which is making the access very difficult, especially the innovative?
So it's a multifold work that need to be.
If I ask you one or two, tell me the two important bottlenecks that you find which is making the access very difficult.
So definitely an affordability.
Yeah.
And the second, I would say the policy. Okay, framework. There's no framework as such in India at which a drug can be launched, right? So you can launch it at any price you want to launch it. So the market force which determines how it will be launched. So it's a mix of diverse things. So if there is a policy framework which says that this is how the innovation should be bring in India at price, then it will definitely.
Okay. So coming to the one of the very senior oncologists of the country, Syam Agrawal sir, I think you just deal with so many innovative drugs. So what do you think that policy constraint, because cost, access, and coverage affect your treatment decisions? Because now in the personalized era, you want to give what is evidence based and what is the new account. So what affect? How many times it affects the decision?
No, so currently the whole country is so very well connected with the international developments in the field of oncology. And whenever there is a new launch in the US or Europe, we get to know about it, and through Google, etc., patients know about it. But the problem is that there is number one, delay between the launch of the drug in the European market, American market versus India. So that's one leg. We've got several drugs which are now available in the US, and I don't have access to them in India because they're just not available. And of course, as has been pointed out by the previous speaker, the cost issue. So, although they come out with a lot of patient assistance programs, which is still prohibitive, at least for the first 2, 3 years. Only 2, 3 years down the line, the drugs become cheaper when they are perhaps coming close to becoming off patent, and when perhaps the Indian pharma industry is able to produce either generics or biosimilars. So those 3, 4 years for a new drug is a huge, huge hassle. We are all aware of it, but we do prescribe it, but patients can't get it. So this brings us to a very, very important and pertinent point, which I think he raised and you also raised. There's a huge lacuna in our country for developing new drugs. In the last 75 years,
India has not given more than two, three, four anti-cancer drugs to the world. We're totally dependent on US, Europe, and now China is coming out with immune checkpoint inhibitors. We are only talking about copycat, biosimilars. I mean, this is high time that the pharma industry, and of course, for example, the biopharma hubs, which are not going to be, put up by the government of India, they should spend money on basic research to get their own drugs. This is like 225, 2026. So where are we in terms of competition in giving the world new drugs? So I think that's a huge bottleneck in my mind. And that's one of the bottlenecks, of course.
So follow-up question for this, because now there was a news that one of the Indian company that went to the court and one multinational company before their patent off, I think the court directed that you can make the biosimilar. Don't you think that this is a threat for the multinational company because they will be very hesitant to introduce their drug to the Indian market if we just treat them like this? What do you take on this?
So let that be. Then, for example, if you have Indian biopharmaceutical producing a molecule, it will be much cheaper and therefore going to be accessible to much more population at large than as compared to a 2 lakh rupee drug, which is monthly to be given to a patient. And how many patients? Like 0.5% of the population can afford. So what's the point in that? So I think I would encourage. This is what I'm saying that the Indian pharmaceutical industry should spend more money on research to develop their own products so as to have more access to the masses, not only in India, but once you have a cheap molecule, it goes all over the world. And that's where the Indian pharma industry is heading at this point in time. That they produce those generics, produce these biosimilars, and they are going to South America, they are going to, Russia and so many other countries who can't afford those original molecules. So I think, but then we don't have those resources. There's a need to give that push, whether it is from All India Institute, from Gangaram Hospital, from Tata, or from those biopharma hubs or the pharmaceutical industries. So I think that has been missing for the last 15, 20 years. And as I said, other than the CAR T cells, which was just got launched from Mumbai, and maybe some LS paragenase. There's no, I mean, we're good at processing. I mean, you can have nano drugs of the same molecule, irinotecan or paclitaxel and so on, but the molecule is the same. So you're just playing with that. Where is the new molecule? Like you have now 5 or 6 immune checkpoint inhibitors produced, and they've done all basic research and clinical research and now launched in India. So why can't we do that?
I think we need to shift. Like right now, we have an industry academia partnership. We need to shift from academy industry partnership.
Because we have to come together, we have to join hands. Of course, money is required. So pharma is, I'm sure, it's making huge amounts of money when they're selling drugs all over the world. So where is the dearth of money? Is the dearth of, there's no will to produce new molecules. So I mean, that's my opinion is to companies like Reddy's and Intas and Natco and so on, who are really doing so well, pharma, and producing so much of generics which are going all over. We don't want to stop them to come over. But then, sure, where is the indigenous, original Indian research?
They are now afraid of the Indian farmer copying their.
No,
Not at all. I think so. Firstly, I'm an Indian, so I'm very much born. We are talking about farmer. Yeah,
So I think I'll take a discussion a little one level upper. It's also about definitely the indigenous research, but it's also about creating those policy so that the MNC can come here and do research here in India. See, they're currently doing with all the big institutes, they started doing the clinical research. They're convinced with the quality of data that is coming through the clinical research, etc. So their innovative molecules are now being clinically researched here. But the research from the preclinical phase also should happen where the government can support the MNCs and everything. And then it's a synergistic effect that
And clinical trial centers have so much value. Maybe coming to the Bandanaji, you are patient. Counseling is a very important one, and it is not taken into the essential counselors. It is supported. What do you think? How important is the counseling? You must have counseled many patients. How and when you were diagnosed with, did anybody counsel, or do they really think that this is an important part to counsel, starting from the doctors to the caregivers, or what was or part of the survivorship journey? Please.
I think thank you for that question, Dr. Abhishek. And with putting this across to somebody with the lived experience of cancer, um, I have felt it very closely, and it's been 10 years since I've been working as a counselor. First of all, I think the first step to changing it is we need to change the misclassification of counseling as supportive to integrating it with the main treatment plan at the time of diagnosis. It has to begin from there. And you asked me what are the clinical, implications of not providing counseling. This is also from a personal experience, right? Not from what I've seen. We know that cancer comes as a package deal, Dr. Akshaya, right? It's not only the side effects, it's not only the disease, it's also depression, anxiety, distress, which when these are not spotted at the right time, what it does is it leads to poor compliance and also poor disease management, right? Another thing that I have felt very closely and noticed is that counseling, when not provided to survivors, right? The distress moves on into survivorship. And what this does is increases hospital dependence. Yeah, it does. It does. I've seen it personally. I talk from a very personal, perspective. Also, it's very important that psychosocial support should be integrated because what it does is it magnifies, intensifies the pain, the fatigue, and also um, the it brings mistrust from a patient's
So
perspective.
did you get a psychologist to counsel yourself?
No, not at all. And that is one of the reasons that drove me towards counseling, Dr. Abhishek. And I think today I can very proudly say in the last 10 years, I've counseled people in thousands and thousands.
You have done a job, right?
Yeah.
Did you measure the impact? Did you follow the KPIs? That if patients say it was subjective or objective?
Um, it is very important to measure it the right way. It is not being done in our country, Dr. Abhishek.
So
It's
coming
not.
to this questions, right? So we got a grant which is called communication strategies, right?
Yeah.
From ICMR, and we got to do it because I understood communication is very important domain of cancer survivorship. So we have two important tools we have developed. It. Anybody want to close it? I think it's going to be. Yeah.
I would love to know more about the tools there.
Yeah. So this is two things.
Okay.
Symptom management unit. We have just developed 30 symptoms, and this is patient and caregiver. I always survivor and caregivers. I take them as a diet, and 13 symptoms they can just manage by themselves. This is the algorithm for the severity. Then is the 8 weeks tips. We call it telephone interpersonal counseling. We have just developed it and validated it, and I can tell you that this helps you to get a big effect on the quality of life. Second thing, patient admission to the hospital. And third is the symptom severity. And this is working so well, we will publish it. And now we are just trying to see whether what will be the right sequence, SMT alone or SMT followed by TIPSY. This is the one thing we are going to do it. So I think very soon we will be happy to publish it and we can share the results with this.
So that'd be wonderful, Dr. Abhishek.
It's 8 years and it is working. And I can now understand all the psychologists are the top favorites for the patients, not the doctors, because they give time. And in hospital for the cancer patient, if somebody is spending time with them, I think 40 minutes to the survivors, 40 minutes to the caregiver every week.
Absolutely. And I think caregivers are just overlooked.
And I will come to that because we have the article on this because there's many problems, right? Task shifting, there's a role dispute, role transition, and which is very, very difficult. And for the younger people, it is very, very difficult to regulate the emotion. They have developed, emotional regulation intervention to us. So coming to the, research questions. So this is a survivorship we talked about. We did a survey, and this was the distribution. And I think Survivorship. Now we have the gynae cancer, we have the survivorship assessment tool and the care pathways. These are the needs coming to the again, Vivekji. So there are various way of cancer care. Risk prevention, screening, diagnosis, treatment, palliative care, and you importantly highlighted the survivorship. What do you think that what is most underrepresented in the policy? When it comes to policy, you don't find anything about those areas, and which you need very important.
So as a patient advocate, I will mention 2 points in one line. Yeah, and I can cover 2 points. Uh, so those who know me, I work in the name of Rise to Survive Cancer, and survivor is the reason for the reason that survive is a philosophy, and survivorship is missing in the whole policy system in India healthcare system. So first point is survivorship, and the second point is the total cost of this survivorship. So if I elaborate, so there was a girl who was diagnosed with cancer, and the medicine cost, as Dr. Gaur says, that so much that the family has to sell everything. Okay, everything, and it has been 14 years, and her husband is still paying the debt, and that husband is me. Okay, so that's got the point of financial toxicity. And let me cover that first one. Then I will come to the survivorship. That a patient, you can give the treatment even in PMJ if you are give the surgery free of cost. What about the patient coming from Bihar to Tata Memorial or Gangaram or AIMS, and when he goes back, there is nothing in his bank account. When I go back from those targeted therapy, there was nothing. I don't have a house or anything. Still after 14 years and still paying my debts. So that's the financial toxicity, and nobody covers this total cost of survivorship. That surgery was very successful at PMJ, but after that, the family doesn't have anything. And remember, in cancer, there is never a single patient. There is always a second patient in the room, that is the caregiver. Whether patient lives or not, the caregiver will always be a patient like me. And I am a proud patient because I love my wife, but it is so wrong for everyone that you are ignoring the second patient and the policy. And now coming to the survivorship, India has the highest number of survivors in 2 ways. With the modernization of the immunotherapy targeted therapy, one and there are two R's. First one is if you have a stage for what type of cancer or advanced cancer, and you have latest treatment available by if you have money or whatever your central government employee, so there is a word of resistance. You are surviving. And I know patients in my group, which I'm running for now 14 years, that is now 10 plus years at stage 4. That's now, record breaking time. They are survivors and they are living in the fear of when the resistance will come and they don't have the next medicine. The second is reoccurrence. So patients like you and many others who are sitting in this room, if they got treated and what ask us to celebrate because you got treated, but there is a fear. There is a fear, one, of that it will recur. There is a fear of mental torture, which is already there. We are mentally broken. There is menopause, there is children, there is nothing left in the body, there is financial toxicity, and unfortunately in India, there is not a single policy either at state level, central level, or at private level which talk about survivorship. All the pieces are wrong.
So I think this is a very rightly pointed. If I just look into the survivorship research, probably it has gone into number, but we will see very less number of original research published in India. I think that everyone was working on this because I have this grant and another two grants on lung cancer survivorship and GYN cancer survivorship. First is survivorship to tell all of you. Now the definition of survivorship has changed, and I would like to educate everyone that now, once you're diagnosed with cancer, until the time you're living with cancer, this is survivorship. So now it starts with this. And second thing I wanted to, ask another panelist, they talk about policy and reimbursement. This is a very, very important. For a company, I think what is more important? For me, I think company believes in the delivery milestone. How many drugs you have, sold, how many pin codes you have reached. But I don't see a serious concern about what is called how much it has impacted the patient life in total. And I think as a company, probably we need support from your side. I know that you guys do many conferences, but there are large, if somebody wants to, Vivek, Vandana wants to do a patient related conference, which is very important, but you will say that we can't, our company policy doesn't allow it because we can't, So what do you think? I think from the delivery milestone, from a company point of view to the patient impact, what is more important for a company? And do you think there is a need to change in the how we view the cancer care in India?
Fundamentally, to be honest, we are doing it as an industry. But you see, ultimately the problem is, and we are at an immediate fix what we are currently doing as an industry. So we see, because Hausa is talking, there should be a clear shift from volume based, what you talked about, milestone based pricing to value based, and a lot of panelists, esteemed panelists talked about it, right? That's a clear shift we need to do. In India, how we look at company looks at an ecosystem, right? So we need to do trade-offs. So the ecosystem that we are currently looking, okay, there is only like a 10% of the population, which is the federal population, where there is no affordability barrier. Okay. And there we see that, okay, if there is no affordability barrier, we try to give a price, set a price where essentially you try to make some profitability out of it. Then you see a majority of the population which is out of pocket, and to make drugs more affordable to it, you do a lot of assistance or free unit that is being directly given to the patient, so that there is a balance of the profitability that needs to be maintained, which a global commitment a company has given.
So what should I take? Either there are, either this is an offer to sell the drug or it is a real assistance in terms because we are talking about in a different domain. It's not about selling the drug. It's about the other domain which was survivorship. Awareness. Do you really think awareness is so poor? So what companies are I haven't seen any companies in India related to pharma which has come forward and talked about making people aware. They have taken a task, let's work on communication.
So
Let's work on health survivorship.
So I would say I think there's long way to go. Company has started doing it. So for example, I'll give an example of assistance program that has been rolled out. Now that assistance program is not just a drug assistance program, but it actually covers the holistic care that we're trying to offer beyond the pill that we had as a portfolio. So we try to offer psychosocial counseling solutions. We try to offer a diagnostic subsidized coupon solutions, etc., etc. Patient awareness materials, right? But there is a limitation. I mean, it's a commercial organization, and we are governed by certain regulatory frameworks where our limitations are there. But
yeah, I one important thing. When I see like any other thing, when I see the efforts taken by the pharma company in Europe or America, they are completely different. Maybe we organize more conferences in Asia, so your budget is going to the giving the conference organizers. So I can understand that, but I didn't see that commitment towards the survivorship because I have been part of many panel experiences, WHO, ICC. I see how they organize the conferences, how their focus has been shifted the last many years to what is important for the patient. But I don't see that noises in India till today. So,
so there are common interests which company works upon.
yeah.
I would say because let's say if Servier as a company, our focus in oncology is rare cancers, right? So we would like to engage in whatever things we could do in top type of a rare cancer kind of a thing, be it a disease awareness, patient navigation,
So we
etc.
have
So,
cancer
so
benefits, rare disease.
yeah, so
Even everybody's aware.
correct. So it's
Yeah.
an area, but I would agree to it. There is a long way to go, and then therefore.
Yeah, sure, man.
Pleasure. So and as somebody who works with a lot of cancer patients, I think most of the panel discussions that are funded by the pharma, patients struggle to find a place in the panel. And this is absolutely outrightly honest, not a deduction. It is an honest statement. So the farmer needs to do more because a panel which does not have a patient voice is an incomplete panel. Just wanted to add that.
Right? Happy with and that was I was talking about. You see the constitution panel, we doctors are also responsible. That is
Exactly. This was going to say.
you want
So
to take the
no,
glass.
so I don't think we can just purely blame pharma
Yeah.
for not contributing to creating awareness about cancer and so on. If I were to do, which I do, for example, a breast cancer awareness camp or a myeloma awareness camp, they are forthcoming to support us. But I think such like initiatives are far and few. So even the advocacy groups. So I mean, that noise is not there. So now, for example, everybody's aware, especially the literate ones, that 45 years onwards, supposed to do a mammogram once in 2 years. Well, in India, 2% do it. 2%, as opposed to US, 70 to 80%. So the awareness is there. But why aren't women doing it? I mean, that's a hard fact. So there are social, cultural, and so many differences between India and maybe abroad. But then, of course, you need to have more and more awareness about the
These
disease.
opportunities, sir, I will come to the next question. So, what do you think that, what policy reforms? Because now from the volume-based care that we provide at volume-based medical sciences to the volume that you provide at Gangaram Hospital, which is more of patient-centric care and outcome. What are the, policy reforms you see it needs to come in a country like India?
No, so as a institution, as you know, we are a charitable institution. I mean, we have the commitment for treating 22% of the patients free of cost in the wards, not in the OPD. So we have a 3,000 patient OPD every day, which runs free for from 9 to 12 every day for all specialties, including cancer. And 20 to 25% of the patients who are admitted, they get free surgery, free radiation, free chemo when you're talking about cancer care. And the policy is, for example, we do have the PNJ, the Ayushman. So there the limit is 5 lakhs. I wish it was more because the cost of the new drugs which are coming in is really, really huge. So if you can increase the limit, number one there, and have more and more centers adopt that policy, I think we'll be able to cover more and more patients because a lot of charitable institutions, they're just for names. So, institution like Gangaram, where you have a waiting list for free wards, 3 months, 2 months, is very few. So I mean, there's a lot of need for doing the charitable work, having more and more, policies for free institutions like P&J adopted by, the maybe even by the corporate hospitals, so that a lot of people can take the benefit.
Yeah, so recently we just concluded the study on cost analysis in relation to PMJY and for breast cancer and lung cancer, how this, 5 years, how the shifting, because most of the patient require more money in the first year. So if you calculate the 5 years, we are going to publish it, sir. So, Bannaji, your question related to, caregivers, do you really think caregivers also needs counseling?
Oh, absolutely. Um, Dr. Rajagopal, who's the father of palliative care in India, he says caregiver is the silent patient. And we need to focus on the caregiver. We don't realize the burnout it causes. We don't realize the emotional baggage that a cancer diagnosis brings on the patient. We don't realize how burnout leads to changed family dynamics. It leads to reduced efficiency, not only while performing your regular relationship issues, but also at work. And at work, you're exhausted. I've seen so many caregivers give up their jobs because they can't balance it. They can't balance taking care of their loved ones and working. I've seen so many relationships break, Dr. Abhishek. And there is no mandated policy that we have where we include support to the caregiver, every caregiver, right at the time of diagnosis. So caregivers need special care and we need to identify this unmet gap.
Yeah, I strongly agree. They are the mirror image of the patient, and unfortunately, patient is given utmost priority, and they're not even taking this. The study was this, and I can tell you that caregiver needs to be more because, and there is a, like you talked about return to work. It is a very important topic in relation to cancer survivors and caregiver too. So I think they just wear multiple hats But I think nobody's there to take care of them. So I think I totally agree with you. Now I don't see survivor and caregivers in two different domains. I consider them as a diet. So whatever intervention we are going to do in these studies, we are taking together. So I think I have promised that I will finish this panel discussion.
Can I just add one more thing? When we talk of caregivers, please make a mention of the children also. We totally, it does not matter what age the child is. I've experienced it when I was diagnosed. My daughter was 11 years old, and I've seen how much the impact is on kids. We don't. I was not guided about how to provide support to her, and it leaves a lifelong impact. So we need, when we talk of caregivers, we talk of spouses, we talk of partners, we talk of children, we talk of parents. We need to include the entire family structure and not single out just the spouse.
So last question, one policy suggestion to the government from your side.
Please hear what the patient says.
And what about caregivers? Don't listen to them.
Please hear what a family diagnosed with cancer says. You know, acknowledge it, account for it, and include their concerns while you're making policies and funding. The funding is done for the policy.
So, one piece of advice you don't increase the health budget. Is that they have already increased it. We have to wait till the next budget.
Just 2% of the national budget is nothing. It's nothing.
Yeah. So I think I'll go with the earlier panelist, Mr. Snell. It's high time we think the PPP should be the patient, the policy partnership. So I think integrating them and making a policy which is equitable will help. Okay. You're leaving doctors, man. Yes, okay.
Interesting question. So I would add that as the cancer progressed, advancement and treatment advancement, targeted therapies and diagnosis, molecular profiling should be part of the national health policy with subsidiary. Why a rich people in India has the right to live when every lives matter. When a mother is mother, either in a poor home or a rich home. So why Ayushman Bharat scheme does not have a single targeted therapy, like for example in lung cancer. So if you want to save each and every life, why a PIN code decide who lives not? Why a bank account code decide the code of the life? So I want to change the policy and ensure that insurance coming forward, policy coming forward, PMJ include subsidized profiling and targeted therapy so that everyone has a dignity to live in the
Advocacy pursuits, exactly. So this is, I think, asked when I was in the short. I'm very impressed with you. Can we have the sound, please? This is as good as without sound. So, time लगेगा.
yeah. Except one decision policymaker, but the government applies.
Now you tell me how do you define policy making?
So I will define the policymaker. My wife has participated in 6 clinical trials. Because of that, thousands of people are living in this country. And she died because someone either in FDA, DCGI office or policymaker has not signed something and that medicine has not come. So that is the policymaker who has not signed it. So why in life and policies depends on one signature?
All officials are not policy makers. You can't because they're official labs. So there may be
In 70s in the US, cancer was made as a key drug and tons of money has been pouring ever since. And whatever we are seeing today is a result of that money which is poured in cancer research through NCI and other industries.
I agree.
So unless you have money, unless you have political will, you'll keep talking. In a country of 1.4 billion.
NCI extra needed budget is a $5.3 billion. Just imagine.
So the political will to fight cancer at every level.
So whether you really think if there was political will, this this panel discussion was
There are people in the
we got the opportunity to discuss because there was no political will. I have we should be thankful to that. But just one should take about, and especially to everyone, just remember, even the oncologist sitting here, that everyone is patient in this life today or in future. So when you work, be a patient advocate, always think about it, and every voice matter. I was sitting with DCGI, and it's a right example. I was sitting with DCGI with lot of industry people, oncologists, senior oncologists from Rajiv Gandhi and everywhere, and Ministry of Health, Secretary and everyone, and it was a discussion like a financial discussion, it like a market discussion. And me, I started to speak and everything changed. Then that humanized the problem. And after I stopped, within 15 minutes, Secretary and DCGI has passed three rules which relax the clinical trial rules, which all PIR now. So every voice matters. So in government also there are or there are good people if they don't have to, so we have to continue that. Sir, you are strong enough to put your voice. There are millions of people who have a story to tell, but who's going to listen to them? So either you make a platform to take all the people who has a story to tell and give them a platform. You're very lucky that you got an opportunity to speak there. But there are many. Dr. Abhishek, let's end it here. Otherwise, the organizer will not be happy with us. I want to, leave this as a happy moment. Okay. Thank you so much for listening. Thank you.
Request and so on to please join for the moment presentation ceremony. Can we all please put our hands together and thank our esteemed panelists for a very insightful and thought-provoking session. We'll begin with Dr. Vivek Tomar to please step forward. Patient advocate and founder, ALK Positive. Dr. Ali Asgar Patniwala, lead market access surveyor India. Please put your hands together and thank all our panelists. Ms. Vandana Mahajan, lead counselor, Lung Connect India. Kindly keep the applause going. Dr. Sham Agarwal, senior oncologist, Srinagar Hospital. Session moderator, Dr. Abhishek Shankar, assistant professor, radiation oncology, AIMS Delhi. Will request all our esteemed panelists to please come together for a group photograph. Kindly come together for a group photograph, please. Step forward and come together for a group photograph. With this, we conclude the final panel discussion for the day. We have very insightful address coming up. Post that, we'll break for tea and then the much awaited award ceremony will begin. Thank you very much. Ladies and gentlemen, with due respect, I now invite on stage Ms. Sujaya Krishnan, former Joint Secretary, Ministry of Health and Family Welfare, Government of India, to deliver the closing keynote address. Ms. Krishnan has played a pivotal role in shaping India's national health and cancer control programs with deep experience in policy design, system strengthening, and public health implementation. Her insights bring a valuable perspective on aligning policy intent with on ground impact as we look ahead in strengthening India's cancer care ecosystem. Can we all together please welcome Ms. Jaya Krishnan on stage?
Esteemed members of the medical fraternity, industry, ladies and gentlemen, a very good evening to everyone present here today. It is a privilege to address the seventh edition of the Cancer Summit and Awards, a platform that has over the years brought together policymakers, clinicians, researchers, industry, and civil society with a shared purpose to strengthen cancer care in India through collaboration, innovation, and equity. Cancer today is not only a medical challenge, it's a systems challenge. How we prevent, detect, treat, finance, and support care across the patient journey will determine outcomes, not just for individuals, but for families, communities, and the health system as a whole. India's cancer burden is rising steadily, driven by demographic change, longer life expectancy, and lifestyle factors. Yet the challenge is not incidence alone. We continue to see late stage diagnosis, uneven access to quality care, concentration of services in urban areas, and high out of pocket expenditure of family. These gaps tell us something very important. Cancer care cannot be addressed through isolated interventions. It requires strong systems that work end to end, from prevention and early detection to treatment, follow ups, and long term support. Shifting the focus from late intervention to early action requires patient awareness and education. There is a lack of widespread awareness among communities regarding cancer prevention, risk factors, and science and systems, particularly among the lower education levels and rural environments. Across common cancers, though tobacco related cancers are relatively well known, there is a lack of awareness of other factors such as family history, diet, and environmental factors. Low cancer awareness has also fueled many misconceptions, including stigma around female-centered cancer. Large-scale randomized trials in the past 2 decades have produced robust evidence that implementing simple screening tests can effectively prevent death from common cancers in India. Screening programs for oral and breast cancer are available in different parts of India through the NPCDCS, but implementation needs to be strengthened. Participation rate in screening, it is crucial to ensure that effective referral mechanisms are in place so that clean spotted cases are diagnosed and treated in a timely fashion. One of the most critical shifts India must make is moving upstream in cancer care. Early detection and screening are not optional add-ons. They are the most powerful tools we have to improve outcomes and to reduce costs. This means risk-based screening models, community-level outreach, and strengthening primary and secondary care as the first point of detection. Technology can significantly support the shift through digital screening tools, AI-assisted diagnostics, and data-driven stratification. But these tools must be embedded into public health pathways, not remain limited to pilots or urban centers. Early action saves lives. It also preserves systems capacity. The World Cancer Day theme, United by Unique, defines the crucial role of personalized patient-centered care in the fight against cancer. It highlights the importance of adapting cancer treatments to cater to the unique needs of each individual. The agenda of this summit rightly highlights innovation in diagnosis and treatment, including precision medicine, AI, digital health, and new therapies. Technology is already transforming cancer care in three important ways: diagnostics through faster, more accurate detection through molecular and AI assisted tools, care delivery through tele-oncology and remote consultations, extending specialist expert beyond metros, continuity of care through digital platforms, enabling follow-up, adherence, and coordination. However, innovation must be evaluated on one simple question: does it expand accessibility and affordability at scale? Technology that does not reach tier 2 and tier 3 cities and rural India will not close India's cancer care gap. India has a shortage of clinical trials, with only 350 interventional cancer trials registered on the Clinical Trial Registry of India between 2007 and 17. Most clinical trials were concentrated within the urban cancer centers. Northeast India, despite having the highest rates of cancer incidence and mortality, was reported to have few or no ongoing studies between 2007 and 17. Standardized and user-friendly clinical trial data programs along with infrastructure and capacity building, could help expand the reach of clinical trials to historically excluded or regional sites in India. A fundamental aspect of clinical research in India should be to tackle cancers that are common, deadly, or unique to a region with a focus on practical and accessible treatment. Collaboration and research are key to promoting clinical research in India. Example, the establishment of a clinical trial network in oncology under the national grid, the collaboration for research methods development in oncology, etc. A few areas to highlight include close de-escalation, drug repurposing trials, and recent attempts to develop homegrown, cost-effective cellular therapies for cancer. Since most cancer patients in India have advanced disease and poor performance presentation, clinical research on supportive and palliative care is important. Integrating cancer care with public policy and insurance is necessary to improve affordability of cancer care. Addressing the issue of access and disability of cancer care requires a multifaceted approach involving a wide range of stakeholders. Consensus guidelines on common cancers in India has been published by the Indian Council of Medical Research and should be followed to enable consistent and quality focused research cancer treatment across different settings. Price control measures on essential cancer drugs are important. Certain recently developed innovative cancer treatments are not cost effective for use in the Indian context at the current reimbursement rates. The incorporation of generics and biosimilars could be a cost cutting strategy. Cancer care is expensive, prolonged, and complex. Without financial protection, it can devastate households. This is why policy integration is central. Strengthening cancer care through the Ayushman Bharat and national insurance frameworks, clear reimbursement pathways, and standardized treatment protocols are essential to improve affordability and access. Public insurance must be aligned with preventive screening, diagnostics, and treatment continuity. Policy must not only pay for care, it must enable timely, appropriate care across the patient journey. Reaching beyond metros would need equity as a design principle. Efforts are underway at the national and state levels to invest in building healthcare infrastructure and workforce for cancer care in India. Standardized and robust referral pathways across all levels of care, from primary care to regional hospitals to tertiary care centers, need to be established to ensure continuity of care and enable timely diagnosis and treatment. Decentralized care could be an effective strategy to improve access to quality care, particularly in areas with limited healthcare resources. Equity in cancer care will not be achieved by excellence in a few centers alone. It requires strengthening of district and regional cancer facilities, decentralized models of care, tele-oncology linking peripheral centers with tertiary expertise, and training and capacity building of healthcare professionals across regions. Cancer care must be designed for where people live, not where facilities are concentrated. The focus on tier 3, 2, and 3 cities in this summit is therefore both timely and necessary. Private-public partnerships must move from participation to co-creation. India's cancer care ecosystem includes government, private hospitals, pharma, medtech companies, NGOs, and patient groups. The question is whether all these actors have a role to play. They already do. The question is how well we work together. Effective public-private partnerships can expand infrastructure, accelerate technology adoption, improve training and research, and strengthen patient support systems. But partnerships must be aligned with public health priorities. Be transparent, and accountable and focused on long-term outcomes, not short-term gains. Collaboration, not competition, will drive sustainable impact. Let me conclude with a simple thought. Cancer care is one of the most demanding tests of any health system. It tests our science, it tests our financing models, it tests our compassion and coordination. The purpose of platforms like this summit is not only to exchange ideas, but to align intent with action. If policymakers, clinicians, industry, civil society move forward together, guided by evidence, equity, and accountability, India can build a cancer care ecosystem that is accessible, affordable, patient centric, and resilient. That is the challenge before us, and that is the opportunity. Thank you so much.
Thank you very much, ma'am, for your words of wisdom. I request Omer to please join us on stage and present a token of gratitude to Ms. Sajaya Krishnan. Can we all please put our hands together and thank her for her sharing her thoughts and her gracious presence? Former Joint Secretary, Ministry of Health and Family Welfare, Government of India. Can you please have the memento on stage for Ms. Krishnan? Please give it up for Ms. Krishnan, ladies and gentlemen. Thank you. Ladies and gentlemen, we'll now pause for a 20 minutes tea break and then we'll kickstart the award ceremony. Tea is organized outside the hall. Kindly join us in 20 minutes for the award ceremony. Thank you very much.
Spaniard and a well-being advocacy institution, inspired by the UN holistic approach to sustainable development goals. IHW Council is dedicated towards its high-five philosophy of good health, good food, good water, and good lifestyle. Since 9 years, IHW Council is driving its advocacy missions of holistic health and well-being, fighting non-communicable diseases, climate action and social determinants of health, women and child health, policy discourse and public awareness. Among all the missions, fighting non-communicable diseases in the area of deep concern with more than 41 millions of deaths due to cancer, and it is likely to increase to 55 million by 2030. The advocacy mission, IHW Council, is firm on its commitment to create events through various focused public awareness initiatives and B2B networking platforms.
Actually, there cannot be, any bigger concern as the cancer is posing today to us. Cancer हारेगा देश जीतेगा should also be a motto for us.
The combined advocacy initiatives and global support towards cancer care inspire us to create rapid global cancer alliances.
हेल्थ सर्विसेज कैसी होनी चाहिए ये तो महत्वपूर्ण विषय है ही। पर उसके पहले हमको हॉस्पिटल या डॉक्टर के पास जाने की जरूरत न पड़े इसके लिए हमारे एयर पोल्यूशन और वाटर पोल्यूशन को कैसे सुधार इस बात पर जो मेरे क्वेश्चन है कुछ ऐसा लगता है कि वन में ये खाया गया और सिर्फ स्वस्थ रखना हम सभी का कमिटमेंट है और जो why आप इस धर्म को अपना करके जैसे जैसे इंसान के बीमारियों के हमने जो संख्या किया है निष्ठ होकर के हम इस काम में आगे बढ़े इससे बड़ा काम कुछ नहीं
to reduce the impact of cancer in low and middle-income urban developing countries, bringing awareness, strengthening health systems, capacity building, health advocacy, and global diplomacy, support research, patient support programs. It's time to come together. Join the IHW Cancer Summit and Awards to strengthen the mission. From
That project is
Former Union Minister of Health and Family Welfare Government of India. Can we give him a more energetic, very warm, like welcoming round of applause? A matter of great honor and privilege for all of us to have him as our guest of honor. I would request Mr. Omer to please welcome him with a floral bouquet. Requesting Mr. Omer to please welcome him with a floral bouquet. आइए फिर एक बार जोरदार तालियों से स्वागत करें रॉबिन जी का. Ladies and gentlemen, as we move towards the award ceremony, a moment to recognize excellence, leadership, and unwavering commitment to cancer care and public health, it is only fitting that we hear from a leader who played a defining role in shaping India's health journey. It is now my honor, my privilege to invite on stage our guest of honor, Shri Ashwini Kumar Chaubey ji, former Union Minister for Health and Family Welfare, Government of India, to address the August gathering. Can we welcome sir on stage with a very warm round of applause?
नमस्कार जी. मुझे खुशी है और मैं गर्व महसूस कर रहा हूँ कि आज इतने सारे हमारे चिकित्सकगण, हमारे पदाधिकारीगण जो स्वास्थ्य से जुड़े हुए लोग हैं, मैं आप सबका तहे दिल से आप सबका बहुत बहुत अभिनंदन, नमस्कार. हमारे इंटीग्रेटेड हेल्थ एंड वेलबींग काउंसिल IHW बहुत ही पुरानी संस्था है और उनके कार्यक्रम में आना बड़ा ही मेरे लिए अत्यंत ही पारिवारिक लगता है. मैं 2 दिन पहले मुझे कार्यक्रम की जानकारी मिली, मैं बाहर से आया था और आज व्यस्ततम कार्यक्रम था, फिर भी मुझे लगा कि एक तो स्वास्थ्य से जुड़ा कोई कार्यक्रम होता है तो मुझे बहुत ही आनंद आता है और मनुष्य का जीवन सचमुच कहते क्षिति जल पावक गगन शबीरा पंच तत्व निर्मित यह अधम शरीर. हमारे कमल जी बराबर इतने अच्छे अच्छे कार्यक्रम रखते हैं और बहुत वर्षों के बाद मैं इस कार्यक्रम में शरीक हो रहा हूं तो मुझे लग रहा है कि जहां शरीर पंच तत्व में विलीन हो जाता है, इस शरीर का क्या महत्व है. लेकिन शरीर को स्वस्थ रखना, शरीर माध्यम खल धर्म साधन, शरीर, इसी शरीर से सारे अच्छे कर्म होते हैं, इसलिए शरीर को स्वस्थ रखना ये आवश्यक है. आज आपने बहुत ही गंभीर विषय पर लगातार दिन भर सुना कि आपने चर्चा किया है. देश के बाहर से भी कुछ चिकित्सकगण आए थे, ये जानकारी मिली और आप लोगों ने काफी इस पर कैंसर के अवेयरनेस का, फिर उसके डिटेक्शन का, सभी चीजों के बारे में आपकी पूरी जानकारी. तो मैं कहना चाहूंगा कि हमारे यहाँ संस्कृत में श्लोक है, सर्वे भवन्तु सुखिनः, सर्वे सन्तु निरामयाः, सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखात्. सभी सुखी हो, सभी भद्र हो और सभी एक दूसरे की पीड़ा को अपनी पीड़ा समझ करके पीड़ित मानवता की सेवा में लगे रहे और स्वस्थ रहे. तो मानव सेवा माधव सेवा, नर सेवा नारायण सेवा, यही असली सेवा है.
और मुझे लग रहा है कि स्वास्थ्य समय कम है और देर से मैं आ पाया, क्षमा करेंगे, क्योंकि मुझे लग रहा है कि अ, मैंने स्वास्थ्य के बारे में, और मेरा नाम जो आप सुन रहे हैं अश्विनी कुमार, इसके पीछे भी एक कहानी है, लेकिन वो कहानी लंबी हो जाएगी। इतना ही कह देता हूँ कि बचपन में मैं जब पढ़ने गया था आम के गाछ के नीचे, तो मेरा नाम घर का कुछ और था, नूनू बाबू कहते थे। और वहां जब मैं गया अपने पिताजी के साथ, मास्टर साहब ने कहा नाम क्या होगा, तो रजिस्टर में नाम कुछ लिखा नहीं आ गया, और अश्विनी कुमार। अब मुझे तो अपना नाम लेने में भी याद नहीं रहा था, और मैं बहुत रोया, भागते हुए बोरा लेकर के। स्कूल में हम लोग एक बोरा ले जाते थे, और आम का गाछ थे, उसके नीचे पढ़ते थे, कोई छत नहीं। बाद में जाकर के छत बना था बहुत दिनों के, साल के बाद। तो मुझे लग रहा है कि शरीर को स्वस्थ रखने के लिए हम सब लोगों को, तो अश्विनी कुमारों जो देवताओं के वैद्य होते हैं, भगवान के वैद्य अश्विनी कुमार, मुझे दादी ने कहा कि बेटा तुम्हारा नाम सुख सागर में पढ़ के मैंने नाम रखा है अश्विनी कुमार, तुम डॉक्टर बनोगे। मैं उछल गया, मैं डॉक्टर? वो मीठा वाला जो होम्योपैथी का हम लोग यहाँ डॉक्टर बाबू आते थे, दवाई देते थे, होम्योपैथिक की दवाई, बड़ा आनंद आता था खाने में। तो मैंने कहा अच्छा डॉक्टर बनूंगा, तब तो दवाई भी खाऊंगा बचपन में। तो मुझे याद है कि, और ये कहानी सचमुच में मेरे जीवन में, मैं आज तक सब कुछ डॉक्टर के खान में रहा, बिहार में भी, देश में भी, लेकिन मैडम डॉक्टर नहीं बन पाया। अब भगवान ने अगर दूसरे जन्म में कुछ अच्छे कर्म किए होंगे तब तो ठीक है, मनुष्य योनि में अगर जन्म होता है तो निश्चित रूप से मैं चाहूंगा कि मुझे इसी स्वास्थ्य से जुड़ा हुआ डॉक्टर, और कोविड के कालखंड में जो सेवा करने का अवसर मिला आदरणीय प्रधानमंत्री जी के नेतृत्व में, मार्गदर्शन में, सचमुच में वो एक बहुत ही यादगार रात है। मुझे लगता है कि कल विश्व कैंसर दिवस, और उस अवसर पर आपने पूर्व संध्या में ये कार्यक्रम आयोजित किया है, और इस गरिमामय समारोह में हम उपस्थित हो रहे हैं हम सभी, तो निश्चित रूप से यह आयोजन केवल एक औपचारिक सम्मेलन ही नहीं, बल्कि विज्ञान, नीति और सामाजिक संवेदनशीलता, उसके संगम का प्रतीक है। और निश्चित रूप से कैंसर आज केवल चिकित्सकीय चुनौती ही नहीं, बल्कि मुझे लगता है कि यह एक व्यापक सार्वजनिक स्वास्थ्य प्रश्न है, जिसका प्रभाव परिवारों को, आर्थिक स्थिति, कार्य क्षमता, मानसिक स्वास्थ्य और राष्ट्रीय उत्पादकता तक पहुंचता है। मेरे मित्र कल आए, बहुत दिनों के बाद, कल शाम को एक कार्यक्रम में मैं था कॉन्स्टिट्यूशन क्लब में, और उन्होंने कहा कि मुझे, मेरी पत्नी को कैंसर हो गया है। मतलब कितना, थोड़ा, मैं 1 महीना से सोया नहीं, परिवार के लोग, सारे परिवार के लोग चिंतित हो जाते हैं। तो फिर मैंने टाटा कैंसर हॉस्पिटल में डायरेक्टर से बातचीत किया, और उस समय देखा उनके चेहरे पर कितना जो कष्ट था। उनको लग रहा था कि मैं टाटा जाऊंगा, कैंसर हॉस्पिटल में जा रहा हूं। और फिर बातचीत हुई डॉक्टर पंकज से, तो बहुत कुछ, पंकज चतुर्वेदी वहां के डायरेक्टर थे, तो उन्होंने कहा घबराओ नहीं, आप चिंता मत करो, आप परसों आ। तो सचमुच कैंसर बीमारी के नाम सुनते ही लोगों में बहुत ही परेशानी हो जाती है, और जो उसका डिटेक्शन सेंटर, मैंने सबसे पहले उनके सहयोग से, और अपने क्षेत्र में, पार्लियामेंट क्षेत्र बिहार में, मैंने सभी जगहों पर एक, वहां के हॉस्पिटल में कैंसर डिटेक्शन सेंटर खोलवाया। तो निश्चित रूप से ये प्रश्न उठता है कि किसी बीमारी का दिवस क्यों मनाया। अब कल कैंसर डे है, भाई वो तो याद भी नहीं करना चाहिए ऐसी चीजों को, लेकिन अब उसको मनाना क्या आवश्यक है। तो उसको मनाने के लिए उसका उत्तर स्पष्ट है कि कोई ये उत्सव नहीं होगा, बल्कि ये चेतना का अवसर, वार्निंग जिसको कहते हैं, और उसके लिए अवेयरनेस, पीपुल्स अवेयरनेस एंड पीपुल्स पार्टिसिपेशन, लोगों को जागरूक करना और लोगों की सहभागिता सुनिश्चित करना। इसलिए पीपुल्स अवेयरनेस, लोगों के बीच इसकी जागरूकता कैसे बढ़े, उस काम के लिए कल से हर साल हम अवेयरनेस लोगों को कैसे कर सकते हैं, तो इसलिए कैंसर डे मनाने का काम हम लोग करते हैं। मुझे लग रहा है कि कैंसर का, मैंने पहले कहा कि नाम सुनते ही भय का वातावरण हो जाता है। सचमुच कई बार रोग की वास्तविकता से अधिक उसका मनोवैज्ञानिक प्रभाव भी पड़ने लगता है। साइकोलॉजिकल इफेक्ट इसका बहुत जबरदस्त होता है। मुझे लग रहा है कुछ बीमारी होती है, बीमारी सुन करके ही कोई भी बीमारी, लेकिन कैंसर जैसी बीमारियों का, परंतु आज चिकित्सा विज्ञान ने स्पष्ट किया है कि सभी कैंसर जानलेवा नहीं होते। और मैंने देखा हूँ कैंसर 15 साल, 20 साल, 25 साल तक मैंने उम्र देखा है। अभी तो 40 साल का ब्रेस्ट कैंसर एक हमारे एक निकट संबंधी, उनकी बेटी की मृत्यु हो गई अन्य किसी कारण से, लेकिन वो अभी जिंदा है, उनका 40 साल पहले ऑपरेशन हुआ। तो ये मैं समझता हूँ कि कैंसर कोई जानलेवा बीमारी जरूर है, और इतने साधन, इतने सब प्रकार की चिकित्सकीय उपकरण तैयार हो गया है कि आज हम सब लोग स्वयं चिकित्सक हम सुविधाओं हैं। और मुझे लग रहा है कि अनेक मामलों में सर्वाइवल रेट में भी काफी उल्लेखनीय सुधार भी हुआ है। सचमुच में समय पर अगर पहचान हो जाए, उचित अवसर हो जाए और सकारात्मक मनोबल, तो ये तीन जो तत्व हैं जीवन की दशा बदल सकते हैं, जीवन की दिशा को बदल सकते हैं। और इसलिए हमें यह संदेश समाज तक पहुंचाने की आवश्यकता है कि कैंसर जीवन का अंत नहीं, कैंसर जीवन का अंत नहीं, बल्कि समय पर चिकित्सा होना और सहयोग की मांग करने वाली स्थिति उत्पन्न कर रहा है। तो मुझे लगता है कैंसर नियंत्रण के लिए हमें समन्वित, इंटीग्रेटेड रणनीति बनानी होगी। आपने इंटीग्रेटेड मतलब एक समन्वय नीति, मैं जब कभी भी बिहार में मैं जब स्वास्थ्य मंत्री था तो 2010 में मैंने पूरे बिहार में यात्रा की थी स्वास्थ्य को लेकर, और सात मतलब पूरी तरह से मुझे याद है कि 11,000 स्वास्थ्य कुंभ लगाए, और उसमें हमने सभी को इंटीग्रेटेड हेल्थ पॉलिसी का बनाने के पहले मैंने सभी को साथ लेकर के, चाहे जितने भी एलोपैथ हो, आयुर्वेद हो, होम्योपैथ हो, प्राकृतिक चिकित्सा हो, इलेक्ट्रो होम्यो, सबको साथ लेकर के मैं और गया। उसका बहुत बड़ा लाभ मेरे मित्रों, आप सबको जानकारी होना चाहिए कि अभी एक कैंसर के दृष्टिकोण से जो हम सब जानते हैं कि अर्ली डिटेक्शन होना चाहिए, और स्वाभाविक रूप से इसको जो एफोर्डेबल हम कह सकते हैं कि उसका इलाज और जो पूरी तरह से कंटिन्यूम ऑफ केयर, तो ये तीन चीज आवश्यक है। और ये चार जो एक मैंने कहा, अर्ली डिटेक्शन, एफोर्डेबल इलाज और कंटिन्यूम ऑफ केयर, तो निश्चित रूप से यदि प्राथमिक स्तर पर तंबाकू नियंत्रण, मैंने बहुत सारे टोबैको नियंत्रण कार्यक्रम में भाग लिया, तो तंबाकू नियंत्रण, एचपीवी वैक्सीनेशन, पोषण जागरूकता और स्वस्थ जीवन शैली पर बल दिया जाए, तो निश्चित रूप से अनेक मामलों को इसको रोका जा सकता है। और यदि जिला और ब्लॉक स्तर पर स्क्रीनिंग सुविधा हो जाए, जैसा मैंने पहले कहा, तो इसके लिए स्क्रीनिंग की सुविधा हो तो और भी सुलभ हो जाएगा, और रोग प्रारंभिक चरण में ही पहचाना जा सकता है, इसकी इलाज अच्छी तरह हो सकती है, ये हम सभी जानते हैं। मुझे लग रहा है भारत सरकार ने इस दिशा में महत्वपूर्ण, मैडम ज्वाइंट सेक्रेटरी भी रह चुकी है, मुझे लग रहा है कि आयुष्मान भारत, बड़े सौभाग्य हुआ कि प्रधानमंत्री जी नरेंद्र भाई मोदी जी के नेतृत्व में आयुष्मान भारत का हर प्रकार का कार्यक्रम करके, बैठक करके और आयुष्मान भारत को लॉन्च किया, और आज देश में लोगों को बहुत लाभ मिल रहा है उसका। और मुझे लग रहा है कि जन औषधि केंद्रों द्वारा भी सस्ती दवाएं उपलब्ध कराई जा रही है। क्षेत्रीय कैंसर जो जगह जगह रीजनल कैंसर इंस्टीट्यूट खुला, उसको भी सुदृढ़ किया जा रहा है, और 1 फरवरी का भी बजट, 1 फरवरी 2026 का जो बजट भाषण हुआ, हमारी सुलक्षणी वित्त मंत्री जी ने अपने भाषण में कहा, बजट भाषण में, कि निर्मला सीतारमण जी ने कैंसर संबंधित सभी जीवन रक्षक जो दवाइयां हैं, उसमें उन्होंने उसके कुछ ब्यौरा दिया है। वो सभी दवाइयां बहुत सस्ती होंगी। तो हमारी सरकार लगातार ऐसे दवाइयों को सस्ती भी कर रहा है, और यह केवल वित्तीय राहत ही नहीं बल्कि सामाजिक संवेदनशीलता का भी एक प्रतीक है। और मुझे लगता है जब दवाएं सुलभ हो जाए, सस्ती हो जाए, तो उपचार का विश्वास भी सुदृढ़ हो जाता है। इसमें कई दो मत नहीं। और मुझे लग रहा है कि आज आप सब लोग यहाँ आए हैं, और बहुत जल्द में बहुत लोगों को, आप लोगों को पकड़ना भी है हवाई जहाज। तो मैं आप सबसे इतना ही कहूंगा कि ये जो मुझे लग रहा है कि अभी एक बात और मेरे ध्यान में आया, आगे बढ़ते हुए हमने मजबूत कैंसर रजिस्टर्ड सिस्टम भी काम किया है, डेटा ड्रिवन पॉलिसी। तो डेटा ड्रिवन पॉलिसी और आर्टिफिशियल इंटेलिजेंस का आधारित डिटेक्शन टूल्स, ये एक बड़ी बात, इसको भी हमने बल दिया है, इस पर हमारी सरकार ने इसको बल दिया है। और भारत की जनसंख्या विविध है, इसमें कई बहुमत में, अतः शोध भी भारतीय संदर्भ में इस पर लगातार होती रही है और होना भी चाहिए। तो मुझे लग रहा है कि जीनोमिक, जो मैं गया था उस समय हेल्थ मिनिस्ट्री में, तो मैं मद्रास में जीनोमिक सेंटर को देखने गया, काफी मुझे उससे उत्साहवर्धन हुआ। और इसलिए जीनोमिक रिसर्च, जो क्लिनिकल ट्रायल्स और स्वदेशी औषधि नवाचार, ये भविष्य की दिशा में कैंसर को उन्मूलन की दिशा में देख रहे हैं। मुझे लगता है आज इस मंच पर नीति और चिकित्सा एक साथ उपस्थित है, यह एक ऐतिहासिक अवसर है। मुझे लग रहा है कि यह पॉलिसी प्रायोरिटी के रूप में मुझे प्रिवेंशन को स्थान मिले, तो निश्चित रूप से यदि स्क्रीनिंग सेवाएं ग्रामीण क्षेत्रों में विशेष करके, अगर हम भारत के ग्रामीण क्षेत्रों में पहुंचा दें, तो निश्चित रूप से उपचार की वहीनता सुनिश्चित हो जाएगी। तो भारत कैंसर नियंत्रण के क्षेत्र में वैश्विक उदाहरण बन सकता है। ये ग्लोबल रूप से हम इसको उस पर प्राप्त कर सकते हैं। आयुर्वेद का कथन है, धर्मार्थ काम मोक्षाणाम आरोग्यम मूल मूलतमम, यानी कि जीवन के सभी पुरुषार्थों का आधार स्वास्थ्य, इसलिए स्वस्थ शरीर रखना ये बहुत ही आवश्यक है। और मुझे लग रहा है कि चाहे विकास हो, अर्थव्यवस्था हो या तकनीकी प्रगति का, उसका अंतिम उद्देश्य मानव जीवन की गुणवत्ता है। मानव जीवन स्वस्थ रह करके हम उसकी गुणवत्ता को, इसलिए कैंसर हमें स्मरण कराता है कि स्वास्थ्य ही वास्तविक में वही संपत्ति है। एक व्यक्ति के लिए संपत्ति कुछ भी नहीं, सभी धरी रह जाती है। स्वस्थ है तो हम संपत्ति हमारे पास है। और अंत में मैं इंटीग्रेटेड हेल्थ एंड वेलबींग काउंसिल को बहुत साधुवाद देना चाहता हूँ। कमल जी, आप सौपत्तिक सचमुच में आप दोनों ने ये बीड़ा उठाया है, एनजीओ के माध्यम से आप इतना अच्छा काम कर रहे हैं, इसलिए मैं बेहिचक जब भी आपका संदेश आता है तो मुझे लगता है कि नहीं, मुझे कार्यक्रम में जाना ही है। और चाहे वो पर्यावरण में था तो आप पौधे भी बच्चों के साथ लगाने में हमें सहयोग किए थे। तो निश्चित रूप से आपका व्यवहार बड़ा आनंद है, और मैं बधाई देता हूँ आपको बहुत बहुत। आइए हम सब मिलकर यह सुनिश्चित करें कि कैंसर के विरुद्ध हमें जो ये संघर्ष केवल चिकित्सालयों तक ही सीमित नहीं रखना है, हमें डोर टू डोर और उसको राष्ट्रीय संकल्प के रूप में हमें उसको ग्रहण करना है। जब यह संकल्प हो जाएगा तो हम सिद्धि की ओर, निश्चित रूप से सिद्धि की ओर पहुंचेंगे। आइए हम सभी यही संकल्प लें। कल कैंसर डे है, उसकी पूर्व संध्या में यह संकल्प, आरोग्यम परमम भाग्यम, आरोग्यम परमम भाग्यम, स्वास्थ्य सर्वात साधनम जीवे सर्द। आप सभी सुनो, मैं यही कहता हूँ कि सर्द मतलब स्वस्थ रहते हुए अनंत काल 100 वर्षों तक सुखी जीवन, स्वस्थ जीवन, यही कामना है, इस संकल्प के साथ मैं अपनी वाणी को विराम देता हूँ। जय हिंद, जय भारत, स्वच्छ भारत, स्वच्छ भारत, स्वच्छ भारत, एक भारत, श्रेष्ठ भारत। आइए हम सभी भारतीय नागरिक अपने इस संकल्प को हम गांव गांव तक पहुंचाएं, कस्बों तक पहुंचाएं, केवल शहरों तक सीमित ना रखें, तो निश्चित रूप से हमारा यह 140 करोड़ का देश सुखमय जीवन व्यतीत कर पाएगा। ओम शांति शांति।
सर, we request to please stay back on stage. अश्विनी कुमार चौबे जी से निवेदन है कि कृपया एक बार फिर से मंच पर आ जाएं. Requesting Omar sir to please present a token of gratitude to Shri Ashwini Kumar Chaube ji, a senior statesman and a deeply respected public servant. Shri Chaube has been instrumental in advancing landmark national health initiatives and driving transformative public health reforms across the country. Thank you very much for gracing us with your presence. Thank you, Mr. Omar, for doing the honors. And ladies and gentlemen, we'll now begin with the award ceremony. I would also request Ms. Sujaya Krishnan to please join us on stage for the presentation of awards. Meanwhile, we extend sincere thanks to our jury, which comprises of Ms. Sujaya Krishnan, Dr. Sanjeev Kumar, Dr. Urvashi Prasad, and Dr. Jugal Kishore. And with this, ladies and gentlemen, we proudly begin the Cancer Awards 2026, celebrating impact, excellence, and care that truly puts people first. We'll begin with the first category, which is Patient and Patient Advocacy Awards. And the first award is for Innovation in Patient Support and Cancer Care Advocacy, and it goes to Ms. Anchal Sharma. Turning a stage to cancer diagnosis into a movement of hope, Anchal Sharma transformed lived experience into action through can heal, restoring dignity, comfort, and confidence for cancer patients. Scientific applause going throughout the award ceremony. Award ceremony should look like an award ceremony, with all of us cheering and applauding for the awardees as they come on stage. Our next award is for excellence in patient advocacy and empowerment, and it goes to Dr. Vivek Tomar. A powerful voice for patients, Dr. Tomar has championed advocacy in cancer care and prioritizes understanding, empowerment, and informed decision making, ensuring dignity and agency across the patient journey. And now, ladies and gentlemen, we march ahead to our next category, which is Organizational Excellence Awards. And in this, the first award is for Excellence in Precision Medicine, and it goes to Pfizer India. Requesting representatives from Pfizer India to kindly come and receive this prestigious award for Excellence in Precision Medicine. Representatives from Pfizer. Five gentlemen for advancing precision-driven oncology solutions that enable targeted evidence-based treatment. So we now move forward to our next award, which is for excellence in multidisciplinary care, and it goes to Kailash Healthcare for delivering integrated cancer care through coordinated multidisciplinary models that ensure seamless diagnosis, treatment, and follow-up. Please give it up for Kailash Care, ladies and gentlemen. Up next is our award for excellence in cancer prevention initiatives, and it goes to CHIP Foundation. Sustained leadership in tobacco control and cancer prevention, driving public health action and behavior change at scale. Please give it a Fortune Foundation. Are you all congratulate to come on stage? Our next award is for excellence in screening and early detection, and it goes to Optimal Oncology for strengthening early cancer detection through its Early Detect platform, enabling primary care physicians to identify risk earlier and improve survival outcomes. Please put your hands together for Optimal Oncology. We would request our audience to kindly enter from the mid stage and exit from my right. We would request all of you to please follow this order. Up next is Excellence in Oncology, Hospital of the Year, and goes to Paras Health. Please give it up for Paras for delivering comprehensive patient-centric oncology services backed by clinical experience, technology, and compassionate care. Oncology Hospital of the Year, and it goes to Rajiv Gandhi Cancer Institute and Research Center for setting national benchmarks in comprehensive cancer care, research, education, and high volume clinical experience. Let's all congratulate Rajiv Gandhi Cancer Institute. We also have an award for the one who applaud the loudest and will reveal the name towards the end. So kindly keep the energy going, kindly keep applauding. We have full pleasure dinner ready for all of you. The energy is not going anywhere. Up next is Leadership in Cancer Diagnostics, and it goes to Life Cell Diagnostics Private Limited. Please give it up for Life Cell. For redefining cancer diagnostics to integrated solid, liquid, and germline genomics, enabling faster, actionable, and tumor-informed clinical decisions. Our next award is for outstanding contribution to cancer education and awareness, and it goes to Tegda Biopharmaceuticals India Private Limited for launching India's first national podcast-led Hodgkin's lymphoma awareness initiative, translating complex science into accessible knowledge at scale. We would request the audience to please exit from my right and enter from the stage. Please give it up for Takeda Biopharmaceuticals India Private Limited. Next is outstanding contribution in cancer treatment access, and it goes to Glenmark Pharmaceuticals Limited for transforming access to immunotherapy through predictable pricing and patient support models, reducing treatment dropouts and financial burden. Please put your hands together and congratulate Glenmark Pharmaceuticals Limited. Once again, request you to please exit from my right and enter from mid stage. Marching ahead to our next organizational award, which is the last organizational award for outstanding patient experience, and the award goes to Kailash Healthcare for consistently delivering empathetic, responsive, and patient-focused care across the cancer treatment journey. Where's Dr. Pallavi to kindly receive this award? With this, we now begin the Individual Excellence Awards. And the first award is for Excellence in Medical Oncology. It's an Individual Excellence Award that we've started. And it goes to Dr. Ankur Behel for advancing evidence-based oncology through impactful research, education platforms, and collaborative learning. Please give it up for Dr. Ankur Behel. Up next is Excellence in Medical Genetic and Pediatric Cancer Care, and the award goes to Dr. Neerja Gupta for advancing genomic-based diagnostics and precision care in pediatric oncology and rare genetic disorders. Ladies and gentlemen, our next award is for outstanding contribution to prostate cancer care and awareness and advocacy, and it goes to Dr. Sanjay Pandey. Combining clinical expertise with sustained advocacy to improve early detection and outcomes. Up next is an award for excellence in industry leadership and policy advocacy for cancer care, and the award goes to Dr. Amita Yadav for bridging science, policy, and public impact to strengthen biotech ecosystems and equitable cancer care access. Please give it up for Dr. Amita Yadav. Our next award is for excellence in cancer research, and it's backed by Dr. Ankur Varshney for pioneering the Merit and Mastery Excellence Program, strengthening research-driven oncology practice, and streamlining patient pathways for faster site care. Next is an award for cancer care leadership, merit oncology, and it goes to Dr. Dipanjan Panda for advancing community-led awareness and early detection of hepatobiliary and GI cancers and establishing one of India's early dedicated HPV oncology services. Kindly keep the applause going, ladies and gentlemen. Up next is Patient-Centric Innovator Award, and it goes to Dr. Rajit Chanana for building an ethical, evidence-based oncology model that reduces unnecessary testing and empowers patients with clarity, choice, and trust. Up next is Cancer Awareness Champion Award and goes to Dr. Vikas Goswami for driving year-round cancer awareness and early diagnosis efforts, enabling detection at more treatable stages. Our next award is for Public Health Champion in Cancer Prevention and is backed by Dr. J.C. Balachandar. Dr. J.C. Balachandar for leading a statewide obesity-focused cancer prevention movement aligned with the Fit India mission, translating lifestyle change into community impact. Let's keep congratulating all the awardees. It's a moment of great pride and honor when we see the whole audience applauding for you. So let's be a part of their celebration. And especially for some all suited with his shades on. So I think we should also be a part of probably getting all the selfies clicked. So kindly keep the applause going and let's congratulate all the awardees. Up next is Breast Cancer Care Excellence Award, and it goes to Dr. Ajay Gogia. Dr. Ajay Gogia for globally cited research, academic leadership, and patient first breast cancer care within India's public health system. Sponsor of the year, and it goes to Dr. Professor Tejinder Kataria. Please put your hands together for Dr. Professor Kataria for pioneering advanced radiation oncology technologies in India and redefining precision, safety, and outcomes in cancer care. Next, with Dr. Manish Sahani for excellence in cancer research, for innovative, non-invasive prosthetic solutions that have transformed rehabilitation and quality of life for head and neck cancer patients. We have so many doctors here, so I'm sure you know that when we applaud, there's better blood circulation, we get better hair and skin, and there's medical benefits also. Up next, public health champion in cancer prevention, and it goes to Dr. Neelam Gada for championing tobacco de-addiction through community-embedded evidence-based cessation programs. Next award is for excellence in radiation oncology leadership, and it goes to Dr. S. Huku. For over 4 decades of leadership in high precision radiation therapies, setting national benchmarks in IMRT, IGRT, and stereotactic radiosurgery. Stereotactic radiosurgery. Up next is Cancer Care Leadership Award, Radiation Oncology, and it goes to Dr. Kanika Sood Sharma for combining clinical leadership with large-scale community advocacy in breast and cervical cancer awareness and early detection. Please put your hands together for Please give it up for Dr. Kanika Sood Sharma. Our next award is for inspiring cancer warrior and patient advocate, and it goes to Dr. Captain Ritu Biani for transforming survivorship into nationwide advocacy through grassroots campaigns, expeditions, and cancer literacy initiatives. Dr. Captain Ritu Biani. Clinical Oncology and Patient-Centric Cancer Care. And the award goes to Dr. Bhavna Sirohi. We have Miss Shilpi receiving on behalf of Dr. Bhavna. We can also applaud for the one who's receiving on behalf. Our next award is for excellence in medical oncology and academic leadership, and it goes to Dr. Hemas Malhotra for building Rajasthan's first medical oncology division and VMT program and shaping oncology education nationwide. Next is leadership in patient advocacy and access to cancer care. And the award goes to Ms. Vijay Venkatesh, requesting Mr. Anil Nagpal to please receive it on behalf of Ms. Vijay Venkatesh. For policy, leadership, and comprehensive cancer care. And the award goes to Dr. Dinesh Pendharkar for redefining large-scale cancer care delivery through system leadership, mentorship, and advanced therapies. They say that, action speaks louder than words. I'm just experimenting that now. Our next award is for excellence in pediatric hemato-oncology and bone marrow transplant, and it goes to Dr. Vikas Dua for leading over 1,000 pediatric transplants and expanding curative options for complex childhood cancers. Please put your hands together for Dr. Vikas Dua. Next is Breast Cancer Care Excellence Award, and it's backed by Dr. Mansoor Ahmed PA for grassroots breast cancer awareness and early detection efforts across Kashmir, impacting thousands of lives. Dr. Mansoor Ahmed Mir. Award is Dr. Professor Meenu Walia for Breast Care's Cancer Care Excellence. Requesting Mr. Sailesh Gupta to please receive it on her behalf for research-driven compassionate care across breast and gynecological cancers, shaping evidence-based practice. Strategy and growth, and it goes to Captain Navneet Bali for driving scalable, future-ready healthcare expansion through strategic leadership. Captain Navneet Bali. And it goes to Dr. Monica Puri for strengthening excess-led cancer care through policy, partnership, and global health experience. Dr. Monica Puri is on stage. Let's all congratulate her. Up next is clinical leadership in uro-oncology. And the awardee is Dr. Professor Sudhir Kumar Raval. Would request Dr. Archana to receive it on her behalf. For advancing complex urological cancer care through surgical precision and multidisciplinary excellence. Clinical leadership in uro-oncology, Dr. Professor Sudhir Kumar Raval. We have Dr. Archana receiving on his behalf. Advanced surgical oncology care, and it goes to Dr. Sushil Kumar Jain. For delivering high precision complex cancer surgeries with consistently strong patient outcomes. Ladies and gentlemen, we now march ahead to the last in a very special category, which is Lifetime Achievement Awards. And the first award in this category is for Lifetime Excellence in Medical Leadership, Research, and Public Health. And it goes to Dr. Sarman Singh. Let's give a very energetic round of applause for the special award, the Life Achievement Award. For visionary institution building, kindly keep the applause going, ladies and gentlemen. Translational research and 4 decades of impact across science, policy, and public health. Next Lifetime Achievement Award is for Lifetime Achievement in Oncology, and it goes to Dr. Sham Agarwal. Also, next of patient first oncology leadership, aligning innovation with compassion, clarity, and outcome. Please give it up for Dr. Sham Agarwal. Ladies and gentlemen, the last Lifetime Achievement Award is for Lifetime Achievement in Cancer Care, and it goes to Dr. Surbesha Khanna. We need a more louder and energetic round of applause for founding North India's first comprehensive cancer center and shaping national benchmarks in access, education, and compassionate oncology care. Let's all give it up for Dr. Surbesha Khanna. Ladies and gentlemen, with this we conclude the award ceremony. We would request all our awardees to kindly join us on stage for a group photograph. You may bring your trophies along with you. Kindly join us on stage for a group photograph. You may bring your trophies along with you. Requesting all our golden awardees to please join us for a group photograph. Do bring your trophies with you. Half of you may come on stage, half of you may stay off stage. Ladies and gentlemen, a bright smile is a mandate for a group photograph. Let this moment be etched in our memories with a memorable group photograph. And with this, we conclude the 7th edition of Cancer Summit and Awards. We once again thank you all for your participation and support, for joining us for this important event, for this important initiative. And we will now request you all to please join us for dinner. Wishing you all a great evening ahead. Thank you very much. Once again, many, many congratulations to all the golden awardees here at the 7th edition of Cancer Summit and Awards. Thank you very, very much. We wish you a great evening ahead.
Thank you everyone for your gracious presence and congratulations all our awardees today. Thank you, Mike.